வெளியில வந்து Hello. Okay. Okay, start the session. கேக்குதா? phone கேக்குது.
ஆஃப் பண்ணுவேன்.
You mute this one.
யாரும் பாருங்க.
Output, no, output mute பண்ணுங்க இது.
அது இன்ஃப்ளூயன்சர் வரும்.
Now it.
டபுள் ப்ளூ முன்னாடி வந்து லைஃப் ஆட் விட வேணாம் இப்போ வராது மேடம் இப்போ கரெக்டாக வரும் வரல ஓகேண்ணா தேங்க்ஸ் சரிண்ணா ஓகே ஓகே
This for what is that? Mute it. Mute it. Here also mute it.
So carboplatin is called to set for neurotoxicity and ototoxicity compared to cisplatin. Oxaliplatin is also used.
What's wrong with them? No, because all the people they are not at all listening.
Sir,
No, audible. Oh, yes.
So oxaliplatin, it causes
Sorry.
Yes, sir.
So carboplatin. Next are the antimetabolites, mainly methotrexate and the analog of methotrexate, which is pemetrexate. So methotrexate, we all know it is almost 100% curative in choriocarcinoma. Other cancers like ALL, breast and head and neck cancer, as I already mentioned, just now the non-cancer uses are psoriasis, rheumatoid arthritis, and organ transplantation. So it can be given either orally, intravenous, or intramuscular. So main side effects are of course myelosuppression. And if we have to use methotrexate in very high doses, what is known as leucovorin rescue or citrovorin factor rescue can be introduced. Apart from that, glucartidase, which is a methotrexate cleaving enzyme, is also approved to treat the toxicity. Pemetrexate is an analog of methotrexate, which is used in mesothelioma and lung cancer. Side effects are almost similar to methotrexate, but we have to attenuate the toxicity with folate and vitamin B12 supplementation. Next slide. Next slide. So coming to the Vinca alkaloids, which inhibit tubulin polymerization and microtubule formation. So drugs like vinblastine and vinorelbine, these are used in lymphomas and various types of lung cancers and also breast cancer. Vinblastine, it's a part of ABVD combination with doxorubicin. And these have to be administered intravenously, and we have to reduce the dose in impaired liver function patients. Next slide. Vincristine is again used in leukemias, Wilms tumor, and it is part of the CHOP regimen. It has to be administered intravenously, and hence extravasation can cause irritation and ulceration. It is the least myelosuppressive Vinca alkaloid. Apart from this, eribulin, which is used in breast cancer and liposarcoma, and it is less sensitive to the exclusion by P-glycoprotein. Next slide. Next slide. So coming to the taxanes, we stabilize the microtubules by causing what is known as freezing of the microtubules and inhibit the depolymerization. So paclitaxel main uses are in ovarian, breast, lung and head and neck cancers. It is metabolized by cytochrome 3A4. So you have to reduce the dose in patients with hepatic dysfunction. Peripheral neuropathy is dose limiting. Can I continue? So next group of drugs are the camptothecins, which inhibit topoisomerase enzyme 1, and topotecan and irinotecan are the drugs in this group. So these are mainly used in ovarian cancer, lung cancer, and in particular irinotecan is very useful in treatment of colorectal cancers. It is part of folfiri and also folfirinox combination for GI related tumors. So these have to be given intravenously and reduce the dose in patients with renal dysfunction. And irinotecan can cause acetylcholinesterase inhibition, which results in cholinergic syndrome. So this can be treated with atropine. Next. Next slide. Yeah, next slide. So coming to the antibiotics, so dactinomycin used in Wilms tumor, myosarcoma, living staphylococcus sarcoma, and other choriocarcinoma also. So since it has to be given intravenously, it can cause severe injury or extravasation. It also can cause GI side effects like nausea and vomiting, apart from myelosuppression. Next. Previous slide. So donorubicin, doxorubicin, and mitoxantrone. So these drugs inhibit topoisomerase 2, and donorubicin and doxorubicin mainly they are used in leukemia, sarcomas, lymphomas, and other types of cancers. And the main problem with these group of drugs is they are highly cardiotoxic. So they can cause tachyarrhythmia, they can also cause cardiac failure. So compared to these two drugs, mitoxantrone is less cardiotoxic compared to these two drugs. Next one. Now coming to some of the drugs which have diverse mechanism of action. So bleomycin used in testicular cancers, lymphomas, treatment of bladder cancer, and it is also a part of ABVD regimen. But the major problem with bleomycin is it causes pulmonary toxicity, apart from cutaneous toxicity in the form of skin rashes and erythema. Next slide. So coming to arsenic trioxide, it inhibits and generates certain reactive oxygen species, and tretinoin also. Both these drugs or substances are used in acute leukemias, but again, these two drugs, the major limitation is they can cause what is known as leukocyte maturation syndrome. It can also cause QT prolongation. Apart from this syndrome, tretinoin can also cause hypercalcemia and renal failure. Next slide. Next slide. These are certain other drugs which have a diverse mechanism of action, like for example, ifosfamide, which is used in testicular cancer, and but it can cause neurotoxicity. So methylene treatment can be used to reduce the CNS toxicity. Next slide. Next one. Yeah. So coming to the other drugs or substances like streptozotocin. So this is mainly used in malignant insulinoma and carcinoid syndrome, but it causes frequently renal toxicity and sometimes it can even lead to renal failure. Next slide. Now coming to the newer target like the tyrosine kinase inhibitor. Next slide. So EGFR inhibitors like erlotinib, gefitinib, and osimertinib. So mainly these are used in advanced non-small cell lung cancer with mutations. And also erlotinib is used in advanced pancreatic cancer along with in combination with gemcitabine. These drugs, they have a tendency to cause dermatological side effects like skin rashes. Apart from that, stomatitis, interstitial lung disease. So some of the drug interactions which are important with respect to erlotinib is anticoagulant effect of warfarin is enhanced, and the bioavailability is reduced by concurrent use of proton pump inhibitors. Next, growth factor receptor in other growth factor receptor inhibitors. Next line. So sunitinib and sorafenib. So these are inhibitors of VEGFR and other intercellular kinases which participate in angiogenesis. So these drugs are mainly used in pancreatic tumors, carcinoma. So important side effects, they can cause thromboembolism, proteinuria, GI perforations, fatigue and hypothyroidism. So the common side effects, it can cause bone marrow depression and sometimes even congestive cardiac failure. So we need to monitor the blood pressure, the thyroid functions and blood counts at regular intervals. So used in metastatic RCC and hepatocellular carcinoma. Next slide. So these are the other drugs which come under this group, inhibitors of VEGFR. Next slide. So BCR, ABL and PDGFR KIT kinase inhibitors. Now this KIT is nothing but a pro-oncogene which is implicated in causing just tumors, that is gastrointestinal stromal tumors. So imatinib can be used in these kind of GIST tumors. Apart from that, in leukemias and melanoma. But the important side effects, it can cause GI-related side effects. Apart from that, fluid retention and edema. And these drugs are substrate for cytochrome 3A4. So we have to keep in mind some of the drug-drug interactions. So dasatinib, it decreases, the bioavailability is decreased after concurrent administration with antacids or H2 blockers. Next slide. Next one. Yes. So coming to inhibitors of RAS and JAK pathway, sotorasib and ruxolitinib. So ruxolitinib is used in polycythemia vera and myelofibrosis. Important side effects and very frequently encountered is anemia and thrombocytopenia. Rarely basal cell carcinoma and squamous cell carcinoma also. We need to reduce the dose in renal as well as hepatic impairment. Next one. Now modulators of protein degradation. Like thalidomide and lenalidomide. So thalidomide is used in either newly diagnosed or refractory multiple myeloma. The most serious side effect of thalidomide is sensory neuropathy. So it is contraindicated during pregnancy. Apart from this, these side effects, it can also cause sedation and constipation. While lenalidomide compared to thalidomide, it lacks the potential to be to cause heterogenic side effects and less of neuropathy, sedation or constipation. Next slide.
Mute
Proteasome inhibitors like bortezomib. Again, it is used in multiple myeloma and lymphoma. It can cause thrombocytopenia, peripheral neuropathy, neutropenia, and rarely it can even prolong the QT interval. So coming to the cytokines which stimulate immune response. syndrome, the symptoms are hypertension, respiratory difficulties. Apart from that, it can also cause hypothyroidism, thrombocytopenia. However, all these symptoms are reversible when we stop the drug. Next slide. So, rituximab, it is an produces antibodies targeting the cell surface antigen, mainly in lymphomas. Hypersensitivity reaction, so we should use slowly, we should increase the infusion rate and use anti-histamine also. So rarely causes skin reaction, SJ syndrome. Risk of tumor lysis syndrome is more in patients who have high risk of tumor burden. So important adverse effects are vasomotor symptoms, decreased libido, osteoporosis, dyspareunia. But one thing is there are no major drug-drug interactions which are noted with this group of drugs. Tamoxifen is a SERM, selective estrogen receptor modulator. So again, this is used in advanced or metastatic HR positive breast cancers in both pre as well as postmenopausal women. So the important side effects are either because of estrogen receptor agonism or antagonism. So it can itself cause endometrial carcinoma, thromboembolic events, vasomotor symptoms and menstrual irregularities. Again, drug interactions with rifampicin and paroxetine can be seen. Next one. Tormethine is another drug in this group which is used in postmenopausal women with HR positive breast cancer. Rarely prolonged the QT interval when there could be increased risk of Torsades de Pontus. So again, the same drug interaction. So we have to use with caution or prescribed drugs like warfarin and phenytoin. Fulvestrant, the selective estrogen receptor down regulator. This is also used in metastatic or advanced HR positive breast cancer in postmenopausal women. And the important side effects are injection site reactions, bone pain, fatigue, vasomotor symptoms, but no major drug interactions are seen. Aromatase inhibitors, like anastrozole and letrozole, they are competitive inhibitors, while exemestane is irreversible inhibitor. So they are used as adjuvants in the treatment of postmenopausal women with HR positive breast cancer. Also for breast cancer prevention in postmenopausal women. So mainly the side effects are again vasomotor symptoms, osteoporosis, vaginal dryness and dyspareunia. Drug interactions are seen mainly with tamoxifen and estrogen co-administration can reduce the efficacy of these drugs. And finally, the glucocorticoid receptor agonists like dexamethasone and prednisone, which are used in the treatment of malignant hematological disorders. So there is also symptom palliation in various cancer types because of decrease in edema and also some amount of anti-inflammatory action and anti-emetic action. So the major toxic effects and the drug interactions with corticosteroids we all know. Next. Now, I would like to just mention the recent advances in drug repurposing. So, certain studies have been done which says that all these classes of drugs like antiplatelet drugs, aspirin, which was used in the treatment of colon cancer, but it is also having some use in the treatment of breast cancer. Apart from that, if we combine diclofenac along with sorafenib, it is used in the treatment of metastatic renal cell carcinoma and even multiple myeloma. Sulfasalazine and certain OX2 inhibitors are also implicated in the treatment of colon cancer, RCC, bladder cancer. Next slide. So antipsychotic drugs, especially valproic acid, olanzapine, and the SS and other antidepressants like SSRIs. So there was a study where they found that if a patient is with schizophrenia is treated with the antipsychotic drug, their chances of any kind of cancer is less in such patients. Apart from that, valproic acid, which is mainly an anti-epileptic drug, but it is also used as a drug for treating bipolar disorder. So this drug also has some amount of cytotoxic activity along with causing apoptosis, and also it inhibits this angiogenesis. So these are the other drugs which have been implicated in treatment of certain types of cancer. Next slide. Finally, what is the role of artificial intelligence? So AI algorithms, there are two types: network-based biology analysis algorithm, and the other one, machine learning-based biology analysis algorithm. So these models are provided with a framework to study the relationship between network characteristics and also cancer. So it has led to the identification and also discovery of various types of novel drug candidates for the treatment of cancer. Finally, coming to the cancer vaccines. So we have two types of cancer vaccines. There could be preventive cancer vaccines and therapeutic cancer vaccines. So preventive cancer vaccines, for example, against the development of HPV, next slide, or hepatitis B virus, so HBV vaccine, next slide. Therapeutic cancer vaccine, so BCG vaccine, mainly which stimulates the immune system, has been approved for patients with early stage bladder cancer. These are the other vaccines. So what are the important and common side effects which are associated with these cancer vaccines? So there could be back pain, anorexia, fatigue, flu-like symptoms, joint pain, myalgia, and neuralgia. These are the various vaccine targets under evaluation in clinical trials. Like we have just seen what is the role of EGFR inhibitors, HER2, like trastuzumab. Next slide. RAS and JAK-STAT pathway. Then the role of personalized neoantigens, telomerase, tumor-associated antigens. Next slide. So I would like to conclude by saying that the global impact of cancer is extremely negative, and the treatment also is highly challenging. But if we have thorough understanding of the molecular pathology of cancer, along with the pharmacokinetic properties, the various drug-drug interactions, and the risk-benefit ratio of these newer targets. It will help in maybe discovering newer targets which can maybe help in eradication and cure of the disease. These are my references. So I would like to end with these 3 quotes. Thank you.
Thank you, Dr. Sapna. It was a overwhelming presentation with starting from giving an overview about all the anti-cancer drugs, including the newer targets where you can look for. You have actually touched the AA and vaccines. Very good presentation. Thank you for that. Any questions from the audience? If you have any queries, you can even raise after the session is over to Dr. Sapna. Thank you, Sapna. We move on to the next session. Yes.
A very good morning, all. I thank the organizers for giving me this opportunity to introduce Dr. Ravindra. He is the Associate Medical Safety Director. He did his MBBS from Government Medical College, Maharashtra, Meerut, MD Pharmacology from KIMS, Bangalore. He started his career as a safety physician in Nature Group and moved on to the product leader and management roles in pharma companies as well as the CROs for over the past 8 years. He managed key molecules during development and post-marketing phases of drug development. He also possesses 6 years of clinical experience, supplemented by specialized training in pharmacovigilance, material-vigilance, and cosmetovigilance, with extensive expertise in signal reduction and risk management. So I think now we all know artificial intelligence is evolving. The next topic is the young pharmacologist, promising speaker, pharmacovigilance, artificial intelligence transformation, practical insights on preparing for the challenge for the upcoming pharmacologists.
Yes, sir. Thanks. Open your you open that quite for this. Okay. Yeah. Hi everyone, good morning. Myself, Dr. Ravindra. My topic for today is PV at AI transformation. And I'll be talking more about how practical insights, like we have seen PV from the sidelines, like how PV is and how AI is now integrated, how AI will be forward. Like what are the challenges? But what we see is AI, what we do, AI do this, AI do that. I'll be talking more about how we can learn AI and how we can actually implement ourselves rather than relying on something like ChatGPT, right? So, what we'll be discussing is what is AI and machine learning. Then we'll look at what is the PV and what is the role of do we really need AI. Then I'll be taking few case studies, few sections of PV like ICS signal. Then there is a new use like social media, how AI is helping, then signal management, and the most important part that is like is skill sets. Now, what is the skill set that the current working pharmacologists will be, as well as the skill sets? Okay, the skill set what the current working pharmacologists need, as well as the one who are doing MD. They will be in the AI is gonna come, whether you like it or not. It's like a running fast train that is going to come toward you. So either you can board it or you can. So I would prefer to make it my friend rather than. So with that, let's start. So what is an artificial intelligence? So this conference has been all about artificial intelligence. So what I will try to do is I will keep as layman as possible. So everybody should have it. The AI is nothing but the system that designs us first, in line with how humans interact or how human intelligence is. So basically, how we are reacting with each other. The same way AI is learning how humans are behaving, how they are talking, what they like, what they don't like. This is what the AI is. Now, AI is a very broad term. So AI has been around since last 7 years. Yeah. So this is the major part in machine learning. Machine learning is nothing but it just process the structured data. Age, male, gender, female, age, male, female, adults, elderly, like that. And it is the most commonly used technology. Then there is something called as deep learning. Now, as a pharmacologist, we should focus more on deep learning. It's like a neuronal network, like our brain cells. We have neuronal plasticity. AI also developing this now. The whole AI structure is based on our neuronal structure. So I will not go in detail, but I just wanted to highlight this one because AI is not new. It's there since 1950. When Alan Turing, he devised the word called as computing machine and intelligence. Then four scientists came together in Dartmouth conference and they decided that this has to be termed something. This is called as artificial intelligence. Then there were many softwares released like Alexa, Frodo. Then the expert system in 1980 identified it and they started using it on a commercial basis, like stock markets. They started to use it to use those inputs and use it for commercial use. But then IBM came. IBM Deep Blue came in 1997. It defeated the world chess champion. Then again, another chess came in 2011. They came and they defeated a quiz contest. Then another came 2016. AlphaGo. This is a Google game. So till this time, why AI never caught attention because it was just defeating the player in particular section. Then came the ChatGPT in 2023. Once ChatGPT came, it started to interact with everybody. And we know what happened over the last 2 years. So for PV, how it started, we started getting data. Initial data was less. We never needed anything. Data started to grow. We started using big data analytics. Then we understood this is not going to go. We needed something to act on its own. We started using machine learning. Then we introduced natural language programming. And what we have completely utilized is robotic process automation. Now, at this moment, we have so many things to work on. So why not to delegate it to someone? So we started working on AI. But before we go, I want to make a highlight. Like what I have seen is people always get confused with automation versus AI. AI is not automation. Let's say I have an email which comes to me. Immediately, someone has to receive an email that yes, you have received an email. So this process cannot be a manual process. I cannot sit whole day 24 hours. This is called as automation. Someone is sending immediately a recipient that thank you, your mail has received. Right? This is automation. It is for repetitive tasks. You don't need humans. And believe me, in PV, almost 99% are automated. So there is nothing much to do in PV actually, because we have already automated everything, right? From the case intake, how we assess, how we use, whatever technology we can use. We have employed everything. Over my 8 years, I can say PV have changed every year. So what AI is needed? AI is for non-repetitive tasks. I have to think about something. I want to know which is the newer drug in this current scenario, which can help me with this particular drug. So that is where AI will come. It will tell you what is the latest research, what was done in 2022, which is the drug. That's the reason AI is different. So make sure going forward, whenever I say AI, it is not for repetitive tasks. It is automation has to be segregated from AI. Anyone can do automation. I can sit here. I have done automation of aggregate reports overall, which used to take months. I have done it like few minutes I can do. This is called automation, but that need an intervention. So whenever we use AI, we will be looking at non-repetitive. So what does it means? It's not there to replace us. That's the first point I would like. It's meant to augment our processing. Okay, it is doesn't mean it is not obeying you. You tell them to do it, will not do. It will suggest you. It's an intelligence, and that's how we should look. Now, what we look at PV is there's something called ICSR aggregate report single detection. No, this is gonna change the way we look at PV. Okay, so let's come to PV. With that, I'll not spend much time on this because PV is the science and activity related to detection, assessment, understanding, and prevention of side effects, either with drugs, vaccines, medical devices, you know. Okay, so this is the overall process. Let's take a small example. Take a second to look at the slide, and I'll be taking you through this. Let's say the first box, that is the current data. We have so many races. Let's say Dr. Shivamoorthy is here. Okay. One day he's sitting somewhere and one patient comes to him, he says, "Sir, I took that alpha-zosin medicine. My liver charts are way high." Immediately he sends an email, he downloads the same form, they fill it and reports. Now that's called as spontaneous. Or he decides to report in a literature. It goes to the literature. Any is the source. It's a post-marketing study, whatever. The data comes to the PVT part. So we collect the data, we segregate the data, put it in the database. And then this data is reported to the health authorities. We call it the expedited report. Are we following to this point? Yeah. So now what happens is liver enzyme, we check first as a signal team. We check whether liver enzyme increase is known or unknown. Then if it's known, then it's okay. This is fine. But if it's not known till now, what I do is I check everything. I'll check the literature. I'll ask the clinical team. I'll ask epidemiology team. Do you have any evidence of any sort? I'll collect the data and then I'll report it to the aggregate reports and risk management. If it is a risk, I need to quantify how much big it is a risk. Is it overtaking the benefits? So this is in short. So the first process is called ICSR. The second and third process are aggregate report, a risk management plan, and signal detection. So I think everybody is clear till PV. So we'll not indulge much into it. This is probably the most important slide of my presentation. It's just says case intake, case processing, signal detection, reporting, and risk management, which I just said. So where to implement the AI? Now the question is there, where you will implement. Now this can apply to academics, it can apply to research, clinical trials, anywhere. The 4 questions that need to be answered is, can you automate that particular task? If I'm getting something, I have to send a reply, yes, I can automate. This is the first step. I look at case intake, case processing. Every state has to undergo these 4. When you have the 4 yes, then yes, you can implement the AI. Because if you can do it, the AI can do it. Then do you have the data to train the AI model? I cannot, let's say I'm doing a clinical research, I cannot use AI there. Because you don't have the data to train the AI. It's like a child with no memory. You fill it with the memory, it becomes expert till the time it overtakes. So, yeah. So then is the data structured or not? Structured data means, as I said, it's gender. Can you define medical history? Can you define it? But no, let's say, like in Indian scenario, how we are I'm feeling uneasy. What is uneasy? AI is not understand. So it's structured versus unstructured. And then you should know your organization structure, how the process is going to go, like systemic review, how it works. You know, then you can use the AI at that stage. Okay, and why we need AI and PV? You can see there is 300% growth in the last. This data is derived from the FAIRS database of FDA. It reports the number of cases reported. Okay, you can see last 10 years, the count has increased 300%. This was downloaded last week, just for your info. And the count is continuously increasing. Why is it happening? Now, because AI is getting implemented, people are reporting, AI is collecting the data, AI is reporting to the PV team. The PV team is adding in the database. PV team is reporting to the health authorities. And their AI is working at USFDA level. They are also, so it's kind of an AI process itself, and it's gonna expand itself. Humans cannot do this. So we need AI to process these. So why AI is important? There are 2 aspects why we need machine learning, because it's a set of process structured data. Whenever we have structured data, machine learning. But we don't have a structured data. We are doing an analysis of something extremely new. We need natural language processing. How humans think. We read 10 books and then we sit and think which is the best approach. The AI does the same. Okay, it can employ sophisticated algorithms. It can assist to find out new signals, new safety issues. So it is useful for data mining. The most tedious task, I would say, let's say data mining, AI coding, predictive analysis, and clinical trial. So does that mean we never use all these things before? Yes, we have. We have disproportionality, TRR ratio, chi-square, everything. But those they give majority times false positives. With AI, picture is changing. I can say I have seen cases where literatures used to be like 10,000 literatures to come. In one organization they employed AI just to look whether there is actual an association between the event and the drug. The count dropped to hardly 50 to 100, that much dramatic. So it is actually helping people to utilize their brain for a more productive task. So I'll be taking one just from case study. I just wanted to introduce ICSR. ICSR is nothing but a document when PV to capture the events, details about the suspected area in the medicinal product. So the steps I have mentioned, receipt, triage, we enter into the database, we do a quality check, then a medical reviewer like MD Pharmacology will come in, he will look at it, and then it's health authority. So I'll be just looking, we'll just take one part because everything is you can apply AI everywhere. So we apply for two things, structured and unstructured data, insertion, and then decision. So I'll take an example of intake. So any source you received a case, now what the team has to do is first segregate into whether it's serious or not. We'll take the same example, hepatitis. Alphadosin, the patient took the alphadosin, 2 days back he came with the yellow skin, and then you did a lab test, you found ALT off the charts. Then what we need to do? They need to see whether it is serious or not. They need to check whether it is already reported or not. They need to assign priority. Should I take it right away? Should I have that report the health authority or should I take the physician health? Then acknowledge the report and route to the correct person. The problems with humans is we have to work 24/7. We have to work in the shift. Someone has to take a lead. These all things are there. So the inefficiency is human errors, the response time. Let's say you received 100 cases today. Turned out the 100th one is the most important part. But it took you at the end of the day. That's the reason AI is actually implementing. It is causing, it is working 24/7, automated responses. The moment someone sends it, immediately there is a response that yes, we have received your query. And plus, it will also show these are three examples. As I said, AI is not going to obey you. It is to show you further insights. How it is written, from which country it is coming. Is it coming from a particular school? I gave vaccine. I remember a scenario when neuroencephalitis occurred in school in a European country. Everywhere it was quiet. Suddenly 20 cases came. So this was detected with AI. So AI is not me. That's what I like to tell. For literature, yes. Now we need 30-page literature. As the medical science is evolving, everybody is publishing. We are getting tens of thousands of literature. It will summarize everything, make a small narrative. It will tell you the important point, what is the medical history, what is relevant, what is not relevant, everything. It will also look, are there any similar cases everywhere? Then it will also check if you need a full text article, you just tell it. It will go check whether your institution has an access, it will give you. So everything can be done with AI. This is how AI is implemented for literature. Okay. Now signal management. I'll not go into the very big definition. I'll take a simple. Signal is nothing but any new information. Okay. Or a new aspect of a known information. As I said, the example again, alpha-dosin increase in liver enzymes. It's already known. But then this patient had a 3 or 10 times more increase in liver enzymes. This is a new information. So this becomes everything. The signal processing usually works with the detection. I first found it. Shivam had sent me the mail. I have examples. So I added it. I detected it. I took it. I checked immediately other sources. I validated it. Yes, this is a new information. Then I did an analysis and prioritization. This has to go very fast. I decided to timeline. So and then the assessment completed, and we found out yes, this is a new signal. This is how the signal process. Now in this process, I need data from preclinical team, I need data from the epidemiological team, clinical trials, have you found anything similar during our clinical? Just one case. during clinical trial. Nothing found after that. But after 10 years, we are finding hundreds of cases now. This is how the signal management usually, comes up. So I'll make it very fast. So signal, yes, as it can look at all the data sources, literature, all our sources, you can the partner, everything can be done automatically. And it can collect, and it can provide its inputs. It's all up to you to act on it. It will never act on its own. That's what with the data. Now, aggregate reports. So brief idea about aggregate reports. It's a report required, let's say, 1 year, that's it. So I'll collect data from clinical trial. I'll collect data from the post marketing. I'll look for pregnancy exposure data. I'll look for any abuse institutional. Like after those, I got to know there is increase in liver enzyme. So I have to put that also, data assessment. Look at the benefits, whether it's really beneficial. So all this information I have to send mail to each department, collect the data from their databases, and then I have to spend months, sometimes 1 month at least, to prepare one report. But with AI, now we are able to do it within 2 weeks, 3 days. Yeah, that's all. So this is how it is helping us to do the monotonous task. This one I would like to highlight. This is what not everybody is doing. We are also not. I don't. I'm not saying like this is exactly. But this is called as chemical fingerprint. So chemical fingerprint is nothing. Let's say anyone have used that SMCH or something. So SMCH software will tell you a molecule with a hydroxyl group at one end is known to produce genotoxicity. Okay, now this is a known information. We found another molecule with the same location hydroxyl group. But does that mean even this one will produce genotoxicity? No. There it has to be checked whether there are other molecules. So all such molecules data is collected together when we are doing the lead optimization. And it will show us whether the new molecule is going to be with a lot of PDFs. So with this, this is the only new thing which I think every pharma studying student should know, because this is called as social media monitoring. What we are doing till now is going on since last 20 to 30 years. Social media monitoring, everybody is posting online. Twitter will go, Facebook will go, and then you say, "Oh, I took this medicine; it's wonderful." Okay, during COVID time, what happened? People were telling, "Take albendazole." Okay, take antihistamines, it protects, or you take oxycycline, it protects. How it was done? This all information AI was checking on, and it was reporting to the NH that okay, people are using this person had an ADI. AI can be implemented at a vast scale now. It can ask the person, I saw you reported, can you please provide me the details? This is how we are increasing our awareness. We are making the drug more safer. So, as I said, the successful AI implementation that are working till date are these. First, adverse event identification, converting a literature to an actual case, then aggregate analysis for signal and all. Then data to context. Okay, so let's say someone had done a systemic review and they mentioned in one study, 10 patients reported increase in liver enzyme. It doesn't carry any meaning to anyone, but AI can go to that link, open that article, is there individual patient? So it's actually decreasing the amount of time that we are taking. Then real-time contextual index. If something is known or not unknown, maybe as one company, I know increase in liver enzyme is known. But in Asia, the other MH are saying, no, it's not known. So how to check like which company knows what? So AI is actually helping there. And then evidence generation. Let's say tomorrow, if you want to take a new project, clinical researcher, it will definitely come in hand. So overall benefits, yes, I have repeatedly told the same thing. Real-time working, it's audit readiness. It's all the trails are available. What happened yesterday, what it did today, what time it did, what second it did, everything can be audited. And then it's actually reducing the cost to the company also. So, and scalability. Scalability is the best one. Let's say during COVID, what happened is COVID vaccine came, many people started to report. The company is so small, it has 100 people, and they started receiving tens and lakhs of ADI at the same time. Do you feel it's feasible during COVID time to hire people and get this done? But AI, we can use the scalability, we can use the cloud computing. just increase the speed processing and get it done. Okay. Now, what are the potential challenges? Ethical issues, obviously, I don't want my information to be used by someone. Okay, so data privacy and security. So data quality and integrity. AI results can change because it's a child who is getting trained. The better it gets trained, its opinions are going to change. So the results AI producing today may not be consistent tomorrow. Okay, then reliability and reluctance among masses. Many people think AI is going to take their jobs, replace everybody in the system. So that is one. And bridging the skill gap. The problem with we always talk about industry, academia, and healthcare should work together. But the skill gap is the major issue, right? So the AI awareness, what we have in industry versus AI awareness, what we have in healthcare. Physicians are at all not bothered about AI. They have to, they have to work. But that bridge gap is the issue. And then need for continuous training and legal implications. Okay, health authorities are also, last year around 300 guidelines were released, out of which 25% health authority guidelines are for AI. So yes, health authority are looking at. Now coming to the last bit, this is one topic I wanted to discuss with everybody. What are the skill set that we need now? We know what AI is doing, but what I want to do now. So there are two types of people what we have in the community at this moment. Those who have entered into the domain, they have been in the domain for quite some time and they don't want to learn coding. Okay, I'm fine with that. Everybody have a role in the system. So that for that, I divided the skill set into non-technical and technical. So technical involves coding parts and non-technical is where you just need to follow the process, learn about it, and you can go ahead. So the non-technical are generative AI, Power BI, and macros development. And technical are programming languages like Python or R programming language. Then there is machine learning, big data analysis, deep learning, and natural language processing. So I will not be talking about all of them, just a few, which I think everybody should start working right now. Okay. So generative AI, Power BI, Python, and NLP will discuss. So I'll not tell about generative. Generative AI is nothing but it's a type of AI which can create content. It can respond to you in pictures, ChatGPT like text. Okay, it can create videos from text to videos, and it is used everywhere. Like let's ChatGPT, then DALL-E is there, which can convert text to image, everything. So this is already known, but how will then there is a Power BI. So I'll give you the resources to learn this. Power BI is a Microsoft business analytic tool. I believe every MD pharmacology who is undergoing training now should learn Power BI. The reason is tomorrow you will be locating everywhere. Let's say I'm sitting in India, my team is somewhere in France or someone in Argentina, and everybody have a different acumen, but they are extremely qualified. They have their data. Now what we are doing today is we are presenting one slide after another slide after another slide. Yes, right. But what if I can collate everything and show it as one slide? So this is what Power BI looks like. So it will, now this one was a clinical trial done and for which Power BI was used. It will show you the enrollment happening over time. So there is enrollment team, the country where it is being happening, the gender, age distribution, whether they achieve their targets or not. Then what are the baseline characteristics in this patient population? How they similar? And you can click on each link and then you can segregate the data. This has to be done one time at the start of the process. And next time, the process team will automatically take the newer data and it will present the data. You don't have to do it every time. So Power BI is freely available. You can easily work on it. So where to learn this? This is always a task. So what I have done is I have collated all the free as well as some authentic sources. I would suggest if you are looking for generative AI, learn prompt engineering first. Prompt engineering, nothing but you should know how to ask the question. AI is a child, it will not ask. If you tell, go there, it will ask you how long, how much far I have to go, where I have to go, where I have to stand. Everything it will ask. You tell it more properly, it will work better. So prompt engineering being used extensively now, particularly for high source. So these are the resources. I think slides will be shared with you. I have provided links for each one. So they will provide you starter level, start with it, go with the pro level. Then Python and R. Now coming to the technical, those who want to excel, let's say 10, 20 years down the line, they want to do extraordinary in the field of BI. I would recommend two programming languages, Python and R. So Python is a versatile language and it's most commonly used for AI building or the machine language LLM, which you call it. So because it has so many modules which are actually meant for AI. Okay? It's a very old language, but its use have started. And R. Now this is the most common used by researchers, statisticians, and because it's used because all the inputs that you provide in text or coding, it will provide output in graphs. Okay. So I would recommend these two. I will not give links for these because this is open source. Anyone can go to their website and you can learn all the videos as well as manuals for them. Okay, next one is NLP. This will be the last one. So NLP, and I would like to stress on this one. This is going to be the future because it is there with us today in everything that you do. Natural language processing is nothing but the discipline of building machines which learn human language. They interact with you. They modify our behavior. This is called as natural language process. Now it has two components. First is they understand you. Natural language understanding. And then they provide a response to your energy. So most common example, Alexa, right? Then ChatGPT, Apple Siri, with Hey Google, everything, whatever we do, they are all based on energy. So how do they do it? If you look at an example, I'll just provide this one example because it's a very big topic. If you look at the data below, how it is looking at the data, it is tagging everything. The name, it's a person. Chinese, it's a religious of the NORP and the person who is where it is located, regional activity. Date, it is looking British, American, AI, where it is working. Now he is the head of Google Bed, means he is looking at the organization. This is how he is looking at the data. And what data, what we will be using, the same way it will keep looking at. So you just have to tell it. So these are few applications which you already know. Some of the examples like scientific analysis. Online, someone is saying, oh, I took the medicine and I'm having very severe headache. It indicates negative analysis. It will collect the data and it will let you know. Toxicity classification, then machine translation, Google Translate, simplest example. Okay. Then name entity, I just said, spam detection, what happens in Gmail, that is also a natural language processing. Then grammar error correction, Microsoft Word, how it detects that you are doing something wrong or some word need to be added to the dictionary. This is again an NLP. So basically we are surrounded by NLP, but we never understood that we are using it. But the reason I feel that it's very easy to learn, I can say it will not take more than 3 to 4 months to learn the NLP. So I have collected an exhaustive list actually. So those who want to read, they can use the introduction and guides. Those who don't like it, the courses are available for free from the leading institutes like Oxford, then this Yandex Data School, and everything. These links in this they will be provided with you in the slides. Okay, so coming to the conclusion and takeaway, pharmacovigilance is there. It's gonna be there, and its importance is gonna increase. The reason is new drugs are developed now. AI is gonna develop drugs so fast, and health authorities are taking it fast track to approve these drugs. Like what happened with COVID vaccine. These things, when it comes to post-marketing setup, you are gonna get more and more ideas. And who's gonna handle them? AI. So the strategies will also be designed by the AI. It will not tell you the strategy, you ask it. So we are going to work in collaboration. It is going to augment the way we do it. We will reduce the number of steps that we have to just one step. Let's say I'm sitting here and I'm handling the whole portfolio for a big, let's say anti-infective agents, whole thing. Because there are 10 AIs working with me. So this is going to be there. So I would suggest we are at the budding stage now. What happened at Industrial Revolution is going to happen with AI now. And if we, as a healthcare professional, if we don't take this seriously, because all the European countries, they are taking it very seriously. If you go there, you will find fierce data studies with the help of AI. Any article, any journal you go, they are doing it on an extensive basis. How they are analyzing so much data? They don't have manpower. They're using AI. So my only suggestion would be, we are at the start. We have a head start at this moment. We can learn. We can go ahead. Thank you. Any question?
Thank you, Ravindra, Dr. Ravindra, for the wonderful session. He covered the core area of pharmacovigilance in collaboration with the promising topic artificial intelligence. He gave us the basics, understanding, advantages, challenges, and he also gave us the resources how to apply for the budding pharmacologist. And we had a very good fruitful session in the morning. Any queries?
What is the utility of SQL? What is the utility of SQL in data?
SQL is nothing but, let's say, if I have, it's a shell, let's say, SQL is nothing but a shell, where you put all the information. It's a database. So there are multiple databases. SQL is one of them. There are MySQL, SQL. So based on.
So it's a database, thank you. So it's actually SQL is not being used recently because SQL have what is a very rigid structure, like how a shelf is there, you cannot move it, you cannot compress it dynamically as you want. So we use MySQL and there are other Reddit and all. So but yeah, it's a database. It just store what AI is learning. But as I said, AI have its own layer. You cannot peek into the AI and see what it is doing at the moment. Like how I cannot peek into your brain and see what you're thinking. Because it's not a visible or structured thing. It's just neuronal network. Yes. Sir.
I would like to know what is the status of use of AI in industry for pharmacovigilance in India.
As I said, just take, there was one slide where I mentioned there is some theoretical implication, what is happening, what is going to happen. They are developing, the problem is health authorities, because we have to get compliance from them that whatever we are doing is actually as per their instruction. We are still drafting the guideline.
No.
But what I showed in one slide, how it is
Converting
converting the narrative. When information is received, let's say someone just reported increase in liver enzyme, 57 years. No information is there. It will create a story for you based on all the information. It will also highlight what is not wrong. So this is what we are industry is doing. And AI is being used in cases actually. So everything that ICSR, literatures, signal detection, risk management plan, and as well as the one like social media monitoring, it's yet to come in industry because it's not advised by the authorities. So that's the reason it's still under monitoring, but there are many companies working on it, and they are trying because this is a real world evidence. That's what we are looking at. This information comes out and nobody reports that. They all look at the data, the real world.
Ma'am, question does not want like that. Ma'am, question does not like that.
Actually, I feel there should be more awareness created about the role of AI in pharmacology. Because at least in our institution, we still collect the hard copies of the API forms and then we transfer the data.
In all the institutions.
Yes.
There are some subtextuals and all like.
Okay. Yeah, the it will be shared. Can signal detection predefined with AI algorithm? Yes, actually, yes. What it can do, what it will do is it will look at certain set of criteria. Let's say, like if there is significant medical history, was the patient taking any other drug which are known to cause it, and it will provide an explanation. But it has to be defined by each organization. So it's not universal. Yes, AI can be detected with predefined AI algorithm.
Again, sharing.
Yes.
Ravindra, I think this was one of the excellent presentations on AI that I heard till now. Just one question, you said that we have to learn from the Europeans or the Westerners about using AI. My question, why Indians are behind using AI? We have technologies, we have experts, we have a lot of data, but still, why are we lacking using?
The first reason would be, maybe I'm correcting, we never talk about AI or any computer programming or anything. I have met pediatricians from, actually I went to this same there during my MD. He was teaching how to use R as a predictive model in children's. That's the anti-cancer drugs if you're giving. First 2 days blood withdrawal can tell you after how many days the toxicity level can be reached. That is what called predicting. And that too, it was with the R.
So I think that's one, because this basic understanding of what is a coding and the resources to learn. If you look, almost all the tools that we are using are not developed by Indians. That's
The academicians have a lot of
Yes.
responsibility.
sure.
One of my comments regarding this is that actually there is a gap between the engineering, like even IITs and your government institutes. Because IITs, what they think that take the data from that, we develop the model, and if any patentable issue on this, they share, and there is a gap actually. And our doctors, they don't know about the patent and IPR issues. So this is causing a very big gap. Actually, we are able to develop it, but this gap is actually creating some miscommunication between these two people. So optimized development is not. Thank you.
Continuation to the map question, we use Google Form to collect areas. So we then manually update in VisiFlow. Is it possible to link that Google Form to the VisiFlow so that the data get automatically updated and I think this question is very common here today because everybody is using SIMATS forms. I showed you that NLP, right? There was two points to it, what we call understanding and the other one was generation. So understanding means when you scan now, actually, if you, I think 2 months back, so a guideline is released actually by WHO, where they are implementing AI at every level. They themselves are using AI to extract data from the form. Because one person can sit and do all the work. Thousands of people are doing. As the time will pass, my understanding is it will come to every institution level that you will have certain softwares. It's very easy actually. I don't know why we don't use it. You don't need a chat GPT. You can develop your own AI. There's something called as open source LLMs models. You take it, install it on your laptop computer. Okay, make it a sandbox, keep it separate. Train it what you want to train it with. Let's say I want to train it with all pharmacology books. I just have to give it. It will finish all the books. I have done it already. It will finish all the books in, let's say, in 2 hours or something. And then you ask him any question. It will tell you discrepancy among the books. So it has, the role is, its imagination is the limit now. That's what it is.
More questions?
Thank you very much.
So thanks for the interactive session. We are going for the next session. So there is a small announcement. Now there will be sponsored video followed by that. We'll continue the session.
Alkmaar Clinics is a healthcare organization providing a wide continuum of facilities for medical confidence protection. Driven by scientific expertise, our mission is to advance and
For the presentation, I can use my laptop or this one. Okay, so can you see my latest slide I mailed today morning so that you can download it? Our MPS, or I can take it to the pen drive.
You can take it.
Hello. Recording. Okay, okay, not.
So welcome back after the tea break. I'm really happy to introduce the next speaker, Dr. P. Sharma, Assistant Professor Pharmacology, AIMS, Guwahati. Sir has completed his DM Clinical Pharmacology in PJME of Chandigarh, featured in Standard University World Top 2% scientist list in 2020. That's a great honor, sir. So happy to introduce you here. His early career as an investigator award, American Gastroenterology Society has received from Washington, D.C. Best Researcher in Young Research Forum from Bali, Indonesia. So we have a well-known figure on research here to be with us to talk regarding the pharmacogenomics. He's also a member of Drugs and Therapeutics Committee, AIMS Guwahati, in Stem Cell Research Committee and a member evaluation, IIT Guwahati. Sir is going to enlighten us about the pharmacogenomics and clinical therapeutics, which is a much awaited field in future. Over to you, sir.
So at the very first, I thank Professor Vikas Medishar because under his guidance, we could learn something in the domain of pharmacology. So this all credit goes to sir. So I will start basically. What is basically pharmacogenomics? So the topics that is I am going to cover. First is your what is pharmacogenetics versus genomics, that which instruments you may require. Because many times many of you are either students or your faculty and you want to buy the instrument. Which instrument you have to buy, you don't know. Then different types of genetic variations and level of evidence and clinical implications. Because just simply observing a genetic variation and its association with some clinical phenotype is not optimum for a clinical decision making process. So level of evidence and clinical implications. So these all domains I will task during my presentation. So what is pharmacogenomics? Basically, genetic variations that influence the individual response to drug. So drug response variation, that can be either kinetic, dynamic. So basically, that is the effect of the genetic variations on individual response to the drugs. So what is central dogma of molecular biology? So that is basically DNA. So we all know from DNA, that is RNA, mRNA. Then from mRNA, the protein comes and ultimately the protein. Whatever we see in our surrounding world is basically protein. That is the abundance of different proteins which we see as phenotypic characteristics. Like the color of your plant is that is green. So that is phenotypic characteristic. That is due to expression of some specific proteins. So alteration in any of this pathway, alteration in the ultimate phenotypic characteristics. This phenotypic characteristic may be alteration in the protein. So that protein may be a drug metabolizing enzyme or any kind of thing. So which can alter ultimately the overall whole process and the phenotypic characteristics. The thing that the clinical characteristics we observe is the phenotypic characteristics, and this is the genotypic characteristics. So the human genome, 3 billion base pairs, approximately 30,000 genes. When the 99.9% of genetic code remains the same, individuals differ from each other approximately 300 to 1,000 nucleotides, with an estimated total of 10 million SNPs and thousands of CNVs. That is, what is CNV? That is copy number variant. So some copy number variants can be seen. I will show about what is copy number variation. So identify which of these variants or combination of variants have consequence on drug effect. So this is a huge task actually. So personalized medicine. Many of times we talk about personalized medicine. What is personalized medicine? It is basically you see some so whenever you go to a shop, you don't take whatever they give. You make it as per your own. That is personalized medicine. As per your own makeup, genetic makeup, body makeup, body surface area, all those parameters. So that is personalized medicine, and genetics plays a very key role in the personalized medicine. So next, pharmacokinetics and variability in drug response. There are many factors. This is a very small list, but the list is very big. Age, race, ethnicity, weight, gender, and among these, genetics plays a key role in the personalized medicine. So what is the difference between pharmacogenetics and genomics? So genome, that is a bigger term. So genetics means you are dealing with a small set of genes or small predefined genes. But genome, you can go for a wider scale study. That is a wider scale. The genetics basically a small number of DNA variants, but that is genome that may contain so all the genes in a genome. So this is basically pharmacogenomics. So that is the genome wide is a gross or overall bigger approach compared to pharmacogenetics. So this is the evolution how it happened. So you can see as per year 1991, it started many long ago, up to since 91. You can see pharma GKB databases that started giving level of evidence to different genotypic annotations, and ultimately, so this is how it developed the CPIC Clinical Pharmacogenomics Implementation Consortium, Ignite platform, then Pharma Web platform, so and ultimately drug labeling by your FDA. So all this is the time sequence how it developed sequentially. Next slide. One second. Yes. Use this. Okay. So next for genomics, because my task is to task it, because in 30 minutes I cannot cover up the whole genomics, but many of you will be interested in which instrument you want to buy. Okay, so these are different. This is real-time PCR machine. So here different filters will be there. What is this? This is basically a thermal cycler. So it will amplify. It will amplify the DNA segment. It will amplify the DNA segment, and in the final outcome, that may be either qualitative or quantitative. Qualitative means whether the fragment is amplified or not, yes or no. Or quantitative, it can be a CT value, that is cycle of threshold, means how much cycle it took to reach the threshold, your detection value or fluorescence detection value. So these are the many among these many of your PCR machines. So why it is important? Once I was doing dengue virus tracking. Earlier we had step 1 class in our lab. So step 1 class had 4 filters. But in dengue virus, for 4 filter and 1 your baseline, that is rocks. So 3 we could do multiplexing for 3 and 1 for baseline. So I could do only for 3. So then dengue tracking was not possible in that case. So in that case, this is containing 6 filters, all this contains 6 filters, the current one, higher one. So you have to prioritize as per your requirement, how much filter you require, how much multiplexing. Multiplexing means how much genes you are amplifying in the same your point or same appendor or same your PCR field.
So that is multiplexing. So this is one kind of your real-time PCR. This is why it is real-time PCR, because they give you the amplification data in real time. Okay, so real-time PCR instrument, that is, they give your amplification data. Here you can see the real-time amplification graph. You can see over here. Then these are other different systems. So these are different systems. Now came your digital PCR, droplet digital PCR. What is droplet digital PCR? They basically make small your droplets. So by using emulsifier oil, okay, by using that emulsifier oil, each of the droplets will be amplified specifically, or as part of thermocycler perspective cycles. Then each droplet will be amplified and each droplet will be analyzed. So here we don't need a control. Earlier, in case of this real-time PCR, if you want to do a quantitative, like let it be how many DNA copies, we need standard. Standard means how many, like in bioassay we do standard. Acetylcholine 10 milligram per ml, 100 milligram per ml, or 0.1 milligram per ml. That's standard curve. So basic concept of bioassay is same all across. So the same here we need that bioassay, that standard curve, but in this we don't need. It has one calculation is there. On that basis, we can do absolute copy. But another point is there. We can do any unknown genotype. Let it be any unknown genotype which is not found in literature. You found for the first time. That is possible here, but that may not be possible here. So advantage, disadvantage, all are there. So this is the process. This is the process. This is the Manhattan plot. This is Manhattan plot. You can see. So this is basically output of the droplet digital PCR. These are different comparisons. I will not go. This is how it looks. This is the droplet digital droplet generator and the amplifier machine. You can see. So and basically in pharmacogenomics we have to amplify the DNA. Or if we are doing your mRNA based study, one, it can be either genotype based study, it can be mRNA or expression based study. Genotype means any problem in the gene or any mutation or any change in the gene, or expression based means is there any expression, mRNA expression. So these two are the major areas. So for mRNA expression, this all we can do by earlier things. Next is, but those system has a disadvantage. What is the disadvantage? That you can amplify selected few fragments. Let it be only 1000 base pair, 2000 base pair. So you can amplify a selective target. But if for doing the whole genome, that is not possible by those instruments. You have to run PCR for lakhs of times if you want to get data of the whole genome. So that is not possible. So that became possible after the introduction of the NGS platforms. NGS or sequencing platforms. So first sequencing platform that came was Sanger sequencer, which could amplify up to 1000 base pair, and we had to trim two sides, that is 150 base pair around in both sides. So that is basically 1000 minus 150, 150 this side, around 700 or 750 base pairs, you get very good quality data. So ultimately, we can amplify 750 in a single run base pairs. So for doing the whole genome, that was not possible even with the Sanger sequencer also. Okay, so there comes the importance of next generation sequencer, which can amplify multiple targets at multiple sites in enormous speed. Okay, so there comes the importance of long read and short read sequencer. What is long read? Means like PacBio or nanopore sequencer. These are long read, means it can take very long reads. 1 lakh base pairs, 70,000 base pairs, more than that. But short read is 200 base pairs. Those are your ion next generation sequencing platforms or your Illumina platforms. These are short read sequencing platforms. So, but the PacBio, this is a long read sequencing platform. This is a long read sequencing platform, and nanopore, this is a very short sequencing platform. So these are the different platforms from which you can generate your genomic data. So it can be either transcriptome. So for transcriptome, you will use the whole mRNA profile. For genome exome profile, it can be the whole exome profile, or it can be the whole genome profile, whatever you want to. But the amount of data would be quite high for the whole genome, little less for the whole exome. So
little more for the whole transcriptome. So this is how the amount of data generated will be vary from different instruments to instrument. And here comes the importance of knowing what you want to do in your study, how much data you need. So data generation. So here first step we have covered. First step, that is. So basically DNA data generation or RNA data generation. This part we have covered. How to generate the data. First thing, we have to extract the DNA. We have to do quality control whether the DNA is okay or not. Then we have to select a suitable system. Who is PCR? If you want to run for a small gene, or you want to run for the whole genome, or you want to run for the whole exome, which are in the gene, or which are being the coding sequence or the expression which will be further sequence into or further generate mRNA. So you should know what you want to do. Then based on that, again, for which type of PCR you want to do, like real time, if you want to do real time data, or you can go for your droplet digital PCR if you have a pre-optimized your known variants data, then you can go for droplet digital PCR. So, and if you want to get data of the whole genome or a very big data, then you will be requiring these sequencing platforms. So these are different. Your data like nanopore sequencing enables genome-wide variant calling with high precision and recall. So that is phase analysis of lung cancer genomes using a long-read sequencer. So this is a long-read sequencer data. So long-reads are earlier were not used much in genotyping, but now they are also being increasingly used or explored in terms of pharmacogenomics. So there can be many approaches like forward genetic approach, phenotype to genotype approach, reverse genetic approach, genotype to phenotype. Genetic conformations lead to phenotypic variability, that we all know. Type of genetic variations. So DNA से data हमने ले लिया. What can be the data? The sequence difference is same as sequence differences in the same genes are called alleles. Coding regions we can see the regulatory regions, because many times polymorphism or any variation in the coding sequence is not itself enough. It can the promoter or the regulatory region that will also influence. The regulatory region may influence the number of copies to be generated. Then introns, then in the 5 days or 3 days planting region, if alleles are present in more than 1% of heterologous individuals in a given population, the variation is called a polymorphism. If it is less than 1%, then they are called sequence variants. So now coming to this diagram. So variation. So here you can see this is the gene promoter, this is the exon, this is intron, this is another exon, that is the intergenic region. So here will come another gene. So variation can occur in all these points. So whose variation will cause change in protein product. So exon variation in change in protein product. So basically this is the splicing area, intron and exon. This is the splicing area. So splicing area variance and this exonic variance, this will cause change the protein product. This may change the protein product, but abundance means how much protein is produced. That may be influenced by all these promoter polymorphism, even exonic polymorphism. So all this can influence the how much abundance. So abundance and your protein production means there is a amino acid sequence change or other change. So those changes can be by this. So the common germline genotypic polymorphism are SNP, single nucleotide, there is a polymorphism or change in the single nucleotide, then insertion or deletion, there is some insertion fragment is inserted in the genome or deleted, then copy number variations. I will show you. So this is basically, let it be a normal gene. So there is a duplicate. Here see, you can see. So here this black, so this green, this is 2. So there is a duplication of one gene. Okay. So there are duplication of several genes, duplication of a part of the gene here, and this is a deletion. So these things you can see, and this is copy number variance. Here it is 3 copies, here 3 copies, but here it is 5 copies, and this is in the paternal chromosome, that is 1 copy. So copy number variation can be here. So these all are important in pharmacogenomics. SNPs again can be non-synonymous or missense. That is synonymous or sense, means there is no sense in that, Nonsense means it is incorporating a stop codon. And non-synonymous or missense means it is incorporating a different amino acid. So we have to think as per that. Polymorphisms can occur in the non-coding regions also. Intonic polymorphism, I have already told. SMPs in the non-coding SMP in promoters enhances or may alter cis or trans acting elements in the regulatory gene transcription or transcript stability. Now we can see indel, and indel causing indel, and this is a frame shift mutation because see this G is deleted and ultimately whole the frame is shifted to this. Ultimately what happens? AAG. Here you can see AAG, CAC, CAC, GT. So the shift frame is shifted to this side, and ultimately the net protein produced that is completely different. You can see. So this is the impact of, so knowing the type of mutation, type of sense, genetic sense is very, very important. Then copy number variance, I have already showed in this diagram. This is copy number variance. So how this can occur? There can actually many theories are there, like duplications, deletions, inversions, etc. Inversions, this is the inversion. Duplications, you know, deletions I have already told. So copy number variations, they can generate from many of these mechanisms, and that is very important in many of the diseases. Then comes haplotype. In body, in one single chromosome, there is not a single, only many times it is visualized like this. This is the enzyme, and this is your substrate binding site. Okay, there can be a single amino acid which is responsible for modification of the substrate, but if that single site is modified, then that will have a huge impact. But it has two or three supportive nucleotides or amino acids, which were helping the primary amino acid to conduct or exert its activity. But if it has supporting structure is also very, very important. So haplotype means in a single chromosome, one gene that is acting along with one nucleotide that is acting along with another nucleotide to exert a combined effect. So that is haplotype. And linkage disequilibrium. So linkage disequilibrium means what happens? Let it be you assume two friends. They go everywhere together. So if you see him, if you see Mr. A, you just think that Mr. B will also be there. That is linkage disequilibrium. Okay, they are not linked. If they are linked, then they are in linkage disequilibrium. So we have to see, because many times we have a parameter called multicollinearity in a regression model. So multicollinearity can actually disrupt a regression model. And if we incorporate those, don't incorporate linkage disequilibrium in a huge genetic dataset analysis, then it can have a significant impact. It can lead to failure of the models. So that is very, very important. So here you can see different examples like CYP2C19 gene. So promoter, these are the different exons in introns. So this is splice. This is because it is the junction is splice. So and we can see different variants. This is normal CYP2C19 star 1. So star 1, that is the wild type. Here you can see star 1, that is the normal metabolizer. But यहाँ पे क्या है आप देखिए, this is here you can see G and there is one R. What does it R? Because there is no R nucleotide. So what is R? R means it can be any or non-specified. So and G and A means it can be any G and A. So ultimately there is no function. But you can see in the promoter all are C. In the promoter, if there is a T, then increase expression. So in the allele means what is the allele? Like pair of alleles. So we will have two alleles in each of the genes. So if it is 17, then that is the ultra rapid metabolizer. If it is 117, then rapid metabolizer or heterozygous, that is heterozygous. So that is rapid metabolizer. Then 1 that is normal. Then 1-2 that is intermediate, and 2-3 that is poor metabolizer. So this is how it impacts your different genotype and phenotypic informations. So these are different lists of your like anti-cancer drugs like PPMT, that is marcoptepurin, UGT-A1, so ironopectin and nilotinib. So these are different lists. Imatinib, these are ABL, BCR-ABL. So these all are given. So here you can see what is the distribution of these phenotypes. You can see this is ultra rapid metabolizer. So the phenotype varies a lot among different populations. This is what I want to show. that phenotype, it is not consistent. So toxicity will be different in one region compared to another region. So here comes the importance of basket trial, because in many of the clinical trial, what we do, we may need to incorporate some genetic baskets in the form of a proper evaluation of proper effect size of the clinical trial. Either or else the genetic baskets may neutralize the effect sizes and it can impact the final outcome. So here you can see CYP3A5 genes, 13 exons, 1*11, *1*3, *35. So here you can see the function is the impact on function. Then tacrolimus concentration, here you can see. So in this, the concentration was highest. Tacrolimus required dose, it was lowest. So if you use the same, it will not be possible. Okay, so using the same dose is not possible. Okay, we cannot use the start of a African person in India. They may require a very big size, we may require a small size. So that CYP allele frequency, these all alleles, so these are loss of function. This is loss of partial function, this is loss of total function. So these areas, this is, you can see the variation. You can see on record C1, that is warfarin metabolism. So you can see the allele frequency, that is also quite huge variation. TPMT phenotypes, that is huge variation. We conducted one study in the PGS indicator. So there we could found that around 2% were actually intermediate metabolizer. So then LUDP 15. So there is very less data from Indian population. 1 to 2 studies are conducted. So we'll have to see. And taking care of this, the FDA, they have put a list, table of pharmacogenic biomarkers in drug labeling. So you can go into the FDA website. Okay, and I will tell you how this data was generated. So coming to this thiopurine, this is like one example, TPMT thiopurine metabolism. Here you can see azathioprine, that is metabolized to 6 markov-thiopurine. There are many steps actually. I am just making it short so that for easy understanding. Then xanthine oxidase, it converts into thioric acid, then TPMT6 methyl markov-thiopurine, and ultimately 6-PGN, which is incorporated into the DNA as a false nucleotide, and ultimately its impacts the action is exerted by 6-thioguanine nucleotide. So this polymorphism of any of these can impact the overall your 6-MP concentration or 6-thioguanine concentration. If 6-thioguanine concentration is high, then what will happen? It will have toxic effect on the red blood cells, RBCs, WBCs, neutrophils, and other cells. And at the same time, if this means increased 6 markov-thiopurine is formed, then ultimately increased 6-ionosinic acid will be formed, and ultimately 6-thioguanine nucleotide will be formed. So increased formation of 6-TPMT, 6-markov-thiopurine can lead to increased 6-thioguanine, so that can be harmful. So optimized amount of 6 markov-thiopurine is required, for which optimized activity of xanthine oxidase and TPMT and SGPRT, all of these are required. Any cells in any of these can have an impact on 6 markov-thiopurine, which can lead to increased availability of 6 markov-thiopurine, can lead to increased amount of 6-thioguanine nucleotides, and which will be incorporated as a false nucleotide in the DNA or RNA. So here you can see this is one of our study, association between UGTA1A6, CYP2C19, CYP2C92 polymorphism and adverse reactions in patients with epilepsy receiving valproate, a prospective observational study. Here you can see these are the SNPs we worked upon. This is the RSID. So for each SNP you have to look for this RSID, and where is the location, then location intronic or exonic, then nucleotide. So 19TG. This means T is a major allele and G is a minor allele. So you can see what is the changes, subsequent protein changes, and protein changes position, no sense. This is the sense. So this how you can document about all your SNPs. Then after doing the analysis with the PCR, we could find this. This is a allele 1 homozygous. This is allele 1 and allele 2 equal expression. So it is a heterozygous population. This is allele 1, allele 2. So this is basically allele 2 expressed, allele 1 is not expressed. So this is allele 2 homozygous, this is allele 1 homozygous, and this is the heterozygous population. We could found the allele frequency, means each allele, the mutated allele, what is the frequency? So allelic frequency we have to calculate, genotypic frequency we have to calculate, and we have to also calculate the Hardy-Weinberg equilibrium. So Hardy-Weinberg equilibrium, that is a major criteria in all of this genotypic analysis. So now most of the studies, what happens, there we cannot find any association. Why? Because we have to see respective alleles. It is a dominant, it is a recessive. So we have to do multiple analysis as part of model. So we did a model, codominant, dominant, recessive, over-dominant, log-negative. So all these models, and ultimately, which model that is best fit? That is AIC, BIC criteria. Academic information quotient and Bayesian information quotient. So we have to use those. Those are commonly used for any kind of model evaluation, genomic, not genomic, any kind of model evaluation, even kinetic model evaluation, AIC is used. So those things can be used, and ultimately we can see there are associations in many of the domains. Then in Helpore, we could see that the effect, there was no association. But when we did gene-gender interaction, we could see gender was having a significant association. Gene-gender interaction has a significant association. I have not shown you the complete data. Here you can see this is the NRI association. In females, in males it is fine, in females. So that is another thing. This is a LD plot. Linkage disequilibrium means Mr. A is present, then Mr. B is also present. Is it true or not? So the third one is the R value. So here see R is 0.91. इसका मतलब है SNP1 and SNP2. If SNP1 is present, then it is highly likely that SNP2 will also be present. So similarly, D dash P value you can see this is the P value, so highly significant. So you can see, so these are not so much linked, but this is highly linked. There is linkage equilibrium. Now coming to haplotype. In the same study, if you see this haplotype GGAG, this is the wild type GGAG, had a higher incidence of or higher chance of weight gain, 13 odds ratio. So by this actually individually they had the odds was less, but here the odds was as high as 13.65. And ultimately what we found that with this your haplotype, was there any impact on the RNA structure? So we determined the RNA structure. This is the wild type. So ultimately this is after amplification. Here you can see UC. You can see a significant difference in the structure of the RNA. You can see this difference was attributed to your mutation. Then harder, what we did, it was CYP. So it was metabolizing product. So CYP had the oxygen, heme iron. This is oxygen form. So this is valproate, this is the oxygen, this is the iron of the heme iron of CYP. So from this, what is the distance of this mutation from this iron? This is the oxygen, sorry. This is the oxygen and this is the valproic acid. What is the distance? So we could found that after mutation the distance increased. And clinically it was found, not by us, by different researchers, that the valproate level increases in these cases because of under metabolism. This is the mechanism. So this is how we could now let it be, we have found this from our study. But is it clinically applicable? Next question. Because clinically we always go for evidence based, that is evidence profiling, level of evidence. So how to go for level of evidence? There are many formats like CPIC, PharmaCar, PharmaCat, PGRN, Pharmacology Research Network, CleanGen, etc. So what they do? They take a profile of this evidence-based pyramid. It is slightly different from others. Like primary pharmacodynamic literature, like Sir told about pharmacovigilance literature. We all are dependent upon literature. So primary literature search and search said that knowledge extraction. How knowledge can be extracted? By earlier sir used to do by manually. Now they used to what do? They use NLP. What is NLP? So that's being used. So manual curation or NLP curation. Then knowledge annotation, aggregation and integration, association between generic variants and drugs, dark gray pathways, dark standard pathways, very important pharmacology summaries. So ultimately what we make is a VIP summary. Very important pharmacology summary. So clinical interpretation. So the genotype based pharmacologic summary, evaluation of level of evidence and clinical importance. So ultimately it is implemented, clinical implementation. So knowledge consortia, CPIC or dosing guidelines or data consortia. So this is all implementation of the genomic knowledge gathered up to this phase. So this is how evidence scoring is done, scoring of pharmacology clinical annotations. There are many phases. So we can see p-value, study size, odds ratio, hazard ratio, or relative risk. These all are used to get a variant annotation score. That this is the formula. I will not go into details. So this basically take care of phenotype category, p-value, cohort size, effect size, weighing by study type, and weighing by association and significance. So all this gives us some score. That score can be annotated to this level of evidence. If it is more than 80, 22, this is the standard scoring pattern. For rare variants, this is slightly different. So ultimately, we can assign level of evidence for each of the genetic annotations. So thank you.
Any questions?
Can you repeat the slide with the levels of approach?
Pharmacology.
Next. Issue. Next one. Oh. Last.
Previous one.
Because another very important is that if you do a multigenic study, there are lots of, if you do a multigenic study, there are lots of actually testing, repeated testing. So alpha adjustment or alpha, there can be alpha inflation. So alpha adjustment is very, very important. So we cannot take just P 0.05. We have to do by divide by the number of tests or all those things we have to take into. So that is, those are the issues.
Any further queries in the online members? Chat box?
No.
So in that case, thank you so much, sir. It was an elaborate presentation. We simply say personalized medicine. We are moving towards personalized medicine. But it is not as easy as we just spell it. Just one part of the personalized medicine, which is very important, that is pharmacogenomics. I could see the experience of Bulan Sharma sir, how far you have to work on a single genomic sequence. So that is going to be there for each drug, how many genomes you have worked on. So it's a great task, and thank you so much, sir, for sharing your experience with all of us. We'll move on to the next session.
Thank you, sir. The next, we are moving on to the next important session by our eminent speaker, Dr. Anand Patel, sir, Professor, Department of Pharmacology, D.Y. Patel Medical College, Navi Mumbai. Sir has experience of working in national and international pharmaceutical companies and CRO. He got the Best Teacher Award by D.Y. Patel School of Medicine. He is ready for that. He's absolute man for the Best Teacher Award. Sir is an excellent teacher. And he got the Sherlock Holmes Award by the Student Council of D.Y. Patel School. And he's also National Award for Research Scholar in APTICON 2023. Sir is credited with 150 plus publications, 80 in PubMed, 77 in Scopus, and several book chapters, with 1,400 plus citations. And he's also having credit of an associate editor of 5 books. And he's also got a 4 copyrights related to pharmacology. And he is a resource person in several conferences, workshops, and symposia. And he is also an editorial board member of 6 journals. And he started the famous PG Pharmacology Forum, which is a very excellent, producing excellent services in the budding pharmacologists, covering 1,600 from plus PG students across India in January 2023. And is also Mayo Clinic USA certified stimulation instructor. I think a lot more to go, like a session, like introducing Sir. So now I'm going to limit this, and we can have the session with Sir.
Thank you so much, Madam, for the kind introduction. Kalai Vanakkam. Good morning. Can I have the presentation, please? Yes. So after the 2 excellent presentations, one by Ravindran and one by Pulen, I think my job is really difficult. So I'm going to speak about my experience of using simulation in medical education. So what I'll be covering in next 25 minutes, because I've been told to cover it in 25 plus 5 minutes. So I'll restrict to those 25 minutes. What I will be doing is, first of all, I'll talk about what is simulation and what are the different types of simulations. And finally, I'll give my own experience of using simulation. So this is my plan, and maybe 1 or 2 lines about animal simulation. So what is simulation? Simulation basically is a created and guided experience of mimicking the real world conditions. That's more important. And we do all this for achieving an educational goal. For example, today my education goal is to understand how the patient will respond to injection of adrenaline. Now that's my educational goal. So we will create a situation where patient has gone into anaphylactic shock and is being given injection of adrenaline. What would be changes that would be seen in heart rate, blood pressure, and all the clinical parameters? So with this educational goal, we create a real world scenario, and that's been guided by the instructor like us, and that is what is simulation is about. So simulation basically is a medical teaching methodology, and it's a medical teaching methodology with a strategy. So it's a method wherein the practical implication, if I thought that adrenaline will increase the heart rate and blood pressure, so that is theoretical knowledge. But actually, does it happen when I inject adrenaline to a patient? Is what is we teach in simulation. So it's a process by which we try to achieve the results which the doctor will see in actual clinical practice, and we try to give as realistic experience as possible. And most importantly, is an interactive session that happens in simulation. Second question is, why simulation in healthcare? Simulation in healthcare is important because it enables the students to work in an environment which is as close as to the resembling of the hospital. So before actually they go to hospital, they should have an experience of how does hospital work. They can get experience before they start working as a professional. Students can put everything that we have taught them in the theory class that they can practice into the simulation. And importantly, they can cope up with the difficulties and problems that can be encountered during clinical practice. They can make as many mistakes as possible in the simulation, which cannot be done on patients, because there is no harm to the patient, there is no damage to the patient because we are not using patient. However, the realism is as good as they're treating patients. So it's a safe environment where there are no any associated risk, physical or any psychological risk to the patient. So with this background, what is simulation and why simulation in medical education? I'll speak more about the clinical simulation and patient simulation, and a last slide about animal experience. So my encounter with the simulation came in 2019 when I was trained by Mayo Clinic team on the simulation as a simulation instructor. So I did this course. There are 2 courses that I did. One of the basic and going beyond basics. And one more time when I went to St. George's Institute in London, that is where again I got an experience of how simulation can be integrated into medical education. You all agree with me that it's risky being a patient today, because we do not know whether the hospital has all the capabilities, whether the doctor that we are encountering or we are being given responsibility to have enough knowledge and the skills. And of course, the doctor also is risky. And we have encountered this so many times. We have been witnessing this day in, day out. What is the solution to this? And why is this happening? Because there are some challenges that we have. The word simulation has come from aviation industry. And we all have traveled by the aircraft. We know there are a lot of similarities between the aerospace and the healthcare industry. Complexity. If I go and sit on the pilot seat in the cockpit, I will be thoroughly confused and thoroughly anxious. Same thing would happen if the pilot comes and goes into our OT, because complexities are completely different. Communication. This point is extremely important because there have been evidence or the data which suggests that most of the mishaps, they happen because of lack of communication. It is not that we don't communicate. We don't communicate effectively. And 2/3 of the mishaps, both in the healthcare as well as in the aviation industry, they happen because of this point. And I'm going to speak about that, how simulation can help in overcoming this. Care and the cost. All these are similarities, and that's why healthcare has been following the simulation practices which are used in the aviation industry. Our modus operandi is different than theirs, but the concept is similar. Because if the pilot has to take a flight, there are 200 passengers sitting, and he's been only theoretically trained how to run the plane, and he sits on the pilot seat. Same thing happens in the healthcare industry also. So medical profession where we are in, this profession is dynamic, we all agree. Because the guidelines, when we studied MBBS, most of the, not most, but some of the guidelines become obsolete. And we have witnessed this during COVID. The yesterday's guideline is not the today's guideline. And that is where we have to be updated every now and then. It's ill structured because every patient is a different patient and we do not know what is going to come next. There are immense time pressure, especially if you're working in a clinical setting, especially in the emergency rooms or in the casualties. Multiple players that we need to address to. Sometimes the outcomes are uncertain and we have all high stakes because we are dealing with the lives. And that is where the minor mistakes sometimes can be very grievous consequences it can bring to. Again, you all agree with me that successful medical professional should have both technical and non-technical capabilities, non-technical skills. And to me, you will also agree with me that technical skills one can learn. Maybe if I do a course of maybe BLS for 10 consecutive days, I can be expert. Even layman can do that. So technical expertise is not what I feel is really difficult. What is difficult is this, because this area is not being focused too much. And I'll speak about how simulation can overcome or maybe teach this non-technical skill. I'm not denying the fact that technical skills are not important. They are equally important, but they need to be also be focusing on non-technical skills of the students. Now, having understood the importance, how do we use simulators? The simulation, the simulators, that is the mannequins or the facilities that we use, it can be classified based on how realistic experience they can give us. And based on that, there are three different types of simulator that we use. One is called as low fidelity, medium fidelity, and the high fidelity. And I'll be speaking more of the high fidelity simulator. But let me explain you what is the meaning of low fidelity, medium fidelity, and the high fidelity first. So low fidelity basically is a static model and it doesn't have a realism. And that is what we typically use when we teach the injection skills. For example, how to give intramuscular injection, subcutaneous injection, intradermal injection. There is no realism. They are static. They are useful for teaching the basic technical skills. So that is where the simulation would start. So this is just a skill. It's not a simulation. Moderate fidelity, it resembles to the reality. And I'll show you some of the simulators that we have. They have the pulse. You can actually check the pulse like what we check for the patients. You can check their heart sounds also. You can check their murmurs. You can check their maybe different breathing sounds, breathe and bronchi and everything. And high fidelity is extremely similar to the realism, except that they don't have the light. Otherwise, everything is almost same. When I was talking about you about the simulation that I saw in London, I took a student, about 80 students to London. That was an educational tour, and we went to St. George's. There were simulation sessions which was specially maybe planned for us. There was a simulation instructor like us, and there was a person next to him. And the scenario was how to break a bad news. And that patient was a patient of lung cancer. And the doctor had to break the news of lung cancer. And it went on up to 20 minutes. And the scenario was the students and I, all of us got so emotional because the way the news was broken to the patient and the way patient responded. And at the end of the session, we came to that this was not a real patient. He was a trained actor. So this is called like the standardized patient. They will already trained. In case I ask you this question, this is what the answer should be. So that is again fidelity that resembles the natural scenario. These are the pictures from our simulation lab. We have this HPS. I will speak about HPS. It's called a human patient simulator, and this is one of the world's costliest simulator. And I'll speak about why it is so. Then there is something called as PeriaSim, NeoSim. Then we have Lucina. I'll show you one picture of Lucina as well. Then we have the surgical simulator, laparoscopic simulator, cath lab simulator, part-time trainer. This is the bronchoscopy simulator. So before they go and do bronchoscopy on a real patient, they should actually get a certification or maybe some kind of experience on working on the simulator. Then they can go and work on the real patient. This is the human patient simulator that I was talking about. This is our simulation lab, simulation group. You can see everything is real. These ventilators, the monitors. Now, because the realism is so much, I have seen even patients, the participants becoming emotional when they could not save the patient, stimulate the patient, because they see everything real, including drugs, including the CPR, including the all the instrument that we use there. This simulator cannot be taken out of this lab because it's a fixed. The reason why it's fixed because it works on the same gases that we have in the anesthesia operating room, and that is why this is the costly simulator. The other simulators we can take to other locations for conducting workshop. So as I said, high fidelity because we can hear their breath sounds, heart sounds, we can check the pulses, we see their chest exertions, airway patency can be seen. We can even teach them how to give a defibrillator shock, how to select the jewels, what is the importance of giving different types of shocks. This is the Lucina that I was talking about. This can be used for showing them how to conduct a normal delivery. And we can give them scenarios like suppose there is the obstructed labor, there is the postpartum hemorrhage, there is cervical dystocia, and then they manage this scenario. And I'll speak about how do we run the simulation session over a day. This is our student, these are a group of our students, and this is our simulation lab. This is the room where we do the debriefing. I'll talk about what is debriefing. So high fidelity simulation is an educational methodology because it brings realism. We send 3 or 4 students for managing one patient, and we see in a team how do they work, who works the best, who can be a team leader, what are the other participants doing, how are they distributing the responsibilities, who is communicating, who is not communicating, and then after the session is over, we debrief them what went right, what went wrong, or what could have been done differently. Obviously, technical skills we teach them, but most importantly is behavioral skills. You know, I was talking about the aviation industry when I came yesterday from the Mumbai. Every time you sit in the aircraft, the air hostess will come and give some kind of announcements. They have been so trained on the behavioral skills because they are handling 200 people at one go. We are handling one patient or maximum in one ward there are 20 patients. We lack here. And that is the reason because the simulation, they have been trained how to behave with the customers. Unfortunately, this area is not focused in our curriculum, and that is where we find a lot of clashes between the patients and the relatives and the doctors. Hopefully, this area, if you use simulation more in the clinical teaching skills, we can encounter this because I don't see this is the problem. Technical skill is the problem. So simulation, we do scenario based. So it is useful for teaching. Now, how do I teach? This is me sitting here. So before they go to a simulation, maybe encounter, I brief them. Hypothetically, there is one case, and this case is presenting me, say, for example, depending on educational goal, it could be myocardial infarction, it could be maybe trauma, or it could be, say, anaphylactic shock. So once I brief them, this is the case, then they have to go into the simulation room and they have to manage. These simulation rooms are audio and video recorded, so that in case there is some mistake being done, we can show back. We can run the video and say, this is where the mistake was done. So videos are recorded not for criticizing, they are recorded for the purpose of teaching them what can be done better. It helps for practice, it helps for self-reflection. And we don't tell them that you did a mistake. We say, watch this again and let me know what could have been done better. And I'm not telling that you did a mistake. So then they reflect on what they did, what could have been done better, and that's what is called as the debriefing. There again, we don't criticize them. We give them the corrective feedback. We don't say that this you should have done this and that's why the patient landed in complication. We ask them what could have been done so that this mistake could have been avoided. So we discuss different measures to mitigate, and we also discuss what could have been the result in case the same thing would have happened on the patient. What would have happened? And then they will never forget in life because they encounter this in the simulation. So the advantage is that there is no risk, physical injury risk to the patient. The scenarios are pre-planned. There are softwares wherein I prepare the case, I feed in the case, and there are alternative options. If they go in a right way, then what will be the outcome? In case they do a different method, what would be the outcome? So there are alternatives, and this can be pre-planned. We can run on rare scenarios. Unfortunately, during COVID, you all must have seen there were limited number of patients in the hospital. Now, 3 years people have done medicine and they went out of the hospital with their MD degrees. We do not know how many such cases they have actually seen in practice. But when they go into realism, they are going to see this patient. Simulation can help us to get and manage those patients on a simulator. As I said, video recording is helpful for discussing the error, not for criticism. This is for education. We can stop any point of time. We can redo the same scenario again and again, but same mistake I cannot do on a patient. That's the biggest advantage of simulation because I can stop when the situation is going out of the hand. I can stop the
simulation and redo it. Team dynamics I spoke about. Crisis management. I think this is where the simulation has got a birth from the aviation industry, because air crash, 200 people in a flight, they should know how to do a crisis management. Objective assessment also is possible. In fact, the examinations can also be taken on the simulator because everything gets recorded. And there is no subjectivity in saying that I did right. I can show you the printout. This is what you did and this is what is expected from you. So assessment can also be very, very objective. So these are some of the sessions that we conducted. This is the ultrasound simulator. This is the software that I was talking about. There are two softwares. One is called the Touch Pro and one is called the Muse. So Muse is a software where I would pre-plan the scenario and I would feed everything about the patient. Like in the examination, we give 40-year male patient presented with these symptoms. This was the heart rate. This was the pulse rate. This is all we record here. And then they go into the simulation room because I have told them what is the case. They go here. They manage the patient, and while they are managing, 4 of them they are managing here. Rest all are sitting outside, and they are observing what is happening inside. So once they come out, they narrate what was the experience, what they did, and this group. Then they will ask what you would have done if you were there in this place. So that we learn as a group, and in a day maybe 3 or 4 cases can be done, and that's the one complete day workshop that is being done. And this is the debriefing. You can see this is the video. In case there's some conflict, I was observing something, but my narration is not matching with what he is saying. Then I can show you the video. See here, I was talking about this and he was saying this. So that there is no conflict between what I am seeing and what I am observing. So high fidelity simulation is useful for learning, provided you have all the available resources. Most importantly, resource. Anticipation and planning is what again we focus on. Don't wait until the complication happens. Anticipate that the complication can happen, and in case that happens, you have planned to manage it. Asking help when necessary. Begin the scenario and see whether they ask for the help. When the help was available, do they make use of that help? We see how distribution of work they do, how effectively they communicate. Do they have fixation errors? The leadership and the followership again can be seen in the team dynamics in the simulation. So to summarize, simulation, if you want to use the high fidelity simulation, we need the collaborative effort between these 3 teams. Technical team. Technical team means those people who can manage the simulation, or the simulators, the mannequins. Simulation instructors are the trained people like us who actually know how to design a scenario, how to run the scenario, how to do a debriefing. That is the team of simulation instructors. And in case, initially, for example, I want to run a case of maybe some complicated case in cardiology or gynecology, I would need the help of subject expert at the beginning to design the case. Maybe 1 or 2 scenarios can be run with the subject expert, and then I become the expert and I would only take the simulation, even if they are not there. So that was all about the patient simulator. My last slide about animal simulators, and we all have used animal simulators because when we were the students, when we did PG, we all did guinea pigs and the dog and everything. However, today, because of those 5 R's, we started with 3 R's, reduce, replace, refine. And now again, they have added 2 more R's, rehabilitate and reuse. So that is where the animal simulators are coming in. And we all know that we have been teaching students on doing how to check the effect of drugs on the rabbit eye, which we did actually on the rabbit eye. Effect of drugs on the dog blood pressure, heart rate, and the famous one is bioassay. And there are different softwares available. Most of them they have tutorial modes, then they have practice mode, and they also have the exam mode. So I'm not going to focus on this one, but just a briefing slide about what animal simulation is. So hopefully I manage the time, and this is my last slide to summarize. Simulation-based medical education is nothing but mimicking as close as possible to the real life, so that we learn the educational goals and without doing any harm to the patient. This has been there in the aviation industry since ages. Medical simulation has helped us to acquire the clinical skills. High fidelity mannequins, they can be as alternative to real patients, and there are multiple benefits of high fidelity simulation in education, provided you have all the resources to manage. So with that, I thank you all for the patient listening. Thank you.
Thank you very much, sir. Exam session on simulation in education is a milestone in our medical curriculum, and his innovative approach, the stepwise approach, will overcome the challenges we face in the CBME curriculum. Thank you, sir. Any queries?
No, sir.
Thank you so much, sir. Simulation is a must, SimLab is a must in all the medical colleges after the CBME curriculum. So as far as our discipline is concerned, we are dealing only with the low fidelity simulators. Is there any possibility, because I think you have more experience in bringing about, incorporating the high fidelity into the pharmacology curriculum? So can you elaborate a little bit? So if we have a wonderful fully functional SimLab. I think every medical college has it now, especially the private ones.
Yes.
So we are not utilizing it, frankly, other than when we go in for the injection skills. The communication skills, of course, we do it in our regular, and we have the animal experiments which are done in our computer labs. So a full-fledged SimLab is not being utilized fully as far as our discipline. So I just wanted you to elaborate how we can incorporate the high fidelity simulators.
I think if you have the facility of using high fidelity simulator, this is the biggest advantage that we have. Most of the pharmacology can be taught on the high fidelity simulators. Be it a respiratory pharmacology, be it a cardiovascular pharmacology, be it the emergency usage of drugs, be it a poisoning. Because on the simulators, we can do morphine poisoning, we can do alcohol poisoning, we can do snake bites, we can do maybe opioid poisoning, morphine opioid poisoning. So these areas, typically the critical areas, can be very well taught of. Even with the communication, and we have the maybe the screens where the actual monitor what is seen in the hospital is there. So when you administer the drug, instead of just saying that adrenaline increases heart rate and blood pressure, let them administer adrenaline, because we have simulator that HPS I told you about. You just have to mimic that you are administering adrenaline, and there is a barcode on the adrenaline syringe. The barcode detects how much adrenaline has been given, and automatically the system changes the heart rate and the blood pressure accordingly. So for all the drugs, especially for the drugs which are there in the software, and there are syringes with the barcodes, those barcodes are automatically detected. So they have to say adrenaline injected, and then we know was it real adrenaline, because we can see the changes, and those can be taught to them.
I have actually different opinion, because I was advisory board member for LMC. So when they started, they took us to several places, medical college. There are very sophisticated, models are available. Other college which is not that quality. I put the question in different way. Do you need this? Okay, because if I see, I was administrative for PGI, we get 10,000 pesos. Okay, you go to any corner, there is nothing like it. I worked in UK, we get only 3%. So that means there is a limitation. I just give an example. I was in Mayo Clinic. One of the PhD PDF ladies, she was suffering from amoebic colitis. She went to the emergency. She was there for 3 days. They could not diagnose. And I said, you take metronidazole. Come back. Now, is there any approach has been made that whatever conventional way we're teaching, and now competency-based teaching, any head-to-head, that need to be looked at. Because why I'm saying that, I went to one of the very remote medical colleges, and they said that, principal said that, students, they do not come to a round. Many medical colleges, they have a evening round where they discuss a clinical case. I remember I saw a cystic fibrosis case in the extreme periphery. I never forget that. Okay, so this is critically looked at, because you know that why I was taken to different place, because frankly speaking, it was a company driven. Okay, so really you have to look at, because I went for a meeting, the training program in Chhattisgarh. Somebody had asked me a question. I really asked him कि आपने MBBS कहाँ से किया? Okay, I remember one of the WHO meeting, one of the secretary had asked, what training we're giving? MD student, they cannot manage, market infrastructure. What training we're giving? And after 1 month, he was shifted from the ministry. He was a relative of Radhakrishnan, Sarvapalli Radhakrishnan. So I think you really need to critically look at, or maybe comparative study, what output skill you are going to give it after doing that. Okay, so that really need to look at. I look at that way. Thank you.
So just one comment subsequent to the question, is it really needed? The answer cannot be straight away yes or no. It would be based on the situations. For example, when I was a student, some of the medical colleges have 50 students, and when I am teaching now, there are 250 students. If I want to hear the murmur, maybe a mitral stenosis murmur, and then one patient admitted in the ward, they go to the ward and 250 students are lined up to check murmur. If I am the patient, I would never go to medical college. That can be very well heard on the simulator. So answer cannot be straight away yes or no. We have to take decisions based on the setups and the resources available.
That I agree, sir. But my question is, we can agree that most of the private institutions where you lack the patients, definitely you need to teach them somehow or other. So that is where this holds a great advantage. My point is just a simple procedure like suturing or something. What is the difference? Have you seen the students you taught with the simulation when they are exposed during CRMI to actually do the procedure? What difference they make? Like definitely there will be at least 30% of difference in the tissue, what they handle and the simulation, what they have. Have you noticed any difference in as far as a conventional learning and the simulation learning makes in the students in performing the skill?
Absolutely. Although there is a high realism, again, I'm not saying that there is a 100% realism. I think high realism. Sometimes there will be extremely high realism, but you cannot match the patient. However, at least you get the confidence and maybe that fearness or anxiety that can surely be taken off when you do simulation. Unfortunately, as Vikas sir said, we do not have a head-to-head comparison to saying that. With empathically, I cannot say that this should be a replacement to traditional teaching, but certainly it can be a complementary to the teaching that we are doing.
Yeah, one thing is right that we have to go hyper with the technology. So our students should be familiar with the technology, but we should not forget the traditional method.
Absolutely.
That is what also. So it should be like that. Do not replace the whole thing. And obviously you said 250 students. Earlier, like we have a limited one, we can directly one-to-one, but it cannot be replaced. That will go in the wrong direction. Thank you.
Any queries in the chat box?
First of all, thank you, sir, for this beautiful presentation, sir. The thing is that when you were talking about communication skill and these simulators, my question is, you had also given an example of an actor in UK. So how do you place a real human being as a simulator versus mannequin or some computer-driven communication strategy, especially countries like us? When communication, we can also say we need to approach very in a personalized way. Just a beautiful presentation by Dr. Pulen Sharma about personalized medicine. Our communication strategy also should be personalized. In this country, there are different people and they want different types of communication approaches. So what is your thought? So whether we should borrow some actor or like that when we are talking about something for communication skills.
I think that's one of the major challenges. Even when you teach communication simulation, these high fidelity mannequins, what we do is there are already softwares with the responses feeding for the patient. When the question is asked by the maybe trainee, then the responses are already fed. However, in case there are different responses, I become the voice of God because the student is not seeing me because I'm sitting at the backside. He is not visualizing me. I can answer on the behalf of the patient. So the student feels that patient is responding. So that is where the communication from my side goes up. But when they want to have the physical presence of a patient, then we can bring actually some another person who is not known to the group. When you bring the same person from the institute, they know this is the person and the communication cannot be so effective.
Two questions.
Which simulations are last?
I think we spoke about apart from the routes of drug administration. So as I said, there is no mandate from the NMC apart from routes of administration as far as the simulation is concerned. However, based on your available resources, your available time and the expertise, you can use the simulator that I talked about, respiratory pharmacology, the cardiovascular pharmacology, poisoning on that. I think I already answered that question.
Just add one comment. Actually, I have started, we have started using all this management simulation, CAL and all those things. I think it's very good in one or the other way. But if you consider the way we have been taught, sometimes, so we had very good animals, direct animals, we used to do the experiment and all tissues we handled. Definitely, there, the live and specimens handling is, there is no way we can compare. But keeping the environment, regulations, everything, I think it really makes the people to, especially IV or whatever we are teaching, IM or routes of administration, we give a very standardized format for them, they memorize, and it makes them, at least streamlined with the process. So that when they start doing, at least, like when we were taught, I think maybe we did not draw back the syringe before pushing, maybe 1 or 2 times. Then we learned that there will be issues, but these people are already taught. And in that way, standard operating procedures are, set in. I'm sure, there is this is the end for us to teach. The learning is a continuous process. We should continue. Thank you.
One more question.
Thank you for your session. We move on to the next session.
We'll move on to the next session. I would like to introduce Dr. Shambhu Samajdar. Sir had completed his MD and DM clinical pharmacology as a gold medalist. And I could say the topic given for him was just apt one, clinical pharmacology experience sharing in research as well as contribution to the nation and subject, because he has done fellowship almost in many of the clinical subjects, respiratory and critical care, allergy, asthma, immunology. So he has done so many clinical oriented fellowships, and he had published 94 articles in index journals, author as competency based practical pharmacology, 40 book chapters in different national and international books, fellow of Indian Pharmacological Society and Diabetes India, Indian Academy of Diabetes Award, Dr. J.C. Patel and C.C. Mehta Best Paper Award in 2021, and in 2024 Innovator Award and Young Researcher Award in 2022. We are happy to have you, sir, here to share your experience on the medical pharmacology.
Thank you, madam, for your kind introduction. What I will discuss for next 20 minutes, that will be on my experience with clinical pharmacology as a student of clinical pharmacology. And let's start. We'll try to cover on this aspect. At first of all, we need to understand what is clinical pharmacology and what are the different roles of clinical pharmacology. How we can be utilized in therapeutics here. And this terminology is very close to my heart, that is clinical pharmacological reconciliation, review and feedback services to optimize patient care. And what are the future directions and what innovations can we expect from us? So when we talk about clinical pharmacology standard textbook, we know, and even this is from our NMC DM clinical pharmacology curriculum, that it is the study of drugs in humans. Although this line is very short, but we can see that big circle and inside so many things is there. And it is not only about any one particular aspect that we talk. We need to understand the whole this galaxy of perspective, which are very closely related with clinical pharmacology. Yes, we are talking about clinical pharmacology, but when we are talking clinical pharmacology, we need to again sometimes revisit the preclinical pharmacology, different cellular events, different transporter mediated reactions, etc. And then how we can apply it in individual level. And ultimately, yes, there are some process of drug development, or it could be balanced prescribing, how balance between risk of prescribing one drug versus risk of not prescribing that particular drug in an individual. So when we talk about clinical pharmacology, it is a bidirectional movement, not only from bedside to bedside, but sometimes we have to go back from bedside to bedside. And we need to understand the molecular pharmacology too. And this is a definition by British Pharmacological Society. When we talk about clinical pharmacologists, they are the clinician, that they had some specialized training in clinical pharmacology and therapeutics. Their core goal is how to improve patient care through safe and effective use of medicine. We know we have a diverse career paths, role of clinical pharmacologists in this country. The first is, of course, how we can manage acute medicine admissions, emergency, how to run outpatient clinic, and also how we can act as a consultant in some specific specialized areas for therapeutic skill. We cannot claim ourselves as a diabetologist, as an endocrinologist, but of course we can claim ourselves as therapeutic specialists in that particular subtherapeutic zone if we have proper training. Apart from that, the toxicology is another area where we can provide some specific care. Scientific research, there is an obvious arena for clinical pharmacologists. Then the education, how to teach prescribing practices and act as medical experts in clinical setting, how we should approach in a referral specialist. Sometimes our other clinical colleagues can refer us some cases for our consultation, and there we need to give our expertise decisions. And there are role in regulatory bodies, policy making. Of course, we have a definite role in pharmaceutical industry. But now we are going to discuss, especially as I am going to share my experience with clinical pharmacology. Generally, I am speaking this area, how we can improve patient care. And this was a 1970 document by WHO. They had actually identified 4 areas. First is to improve patient care by promoting safe and more effective use of drugs. Second is to increase knowledge through research, so research activities. Third is the teaching academia activities. And 4 is providing some specific services like analysis of particular drug, particular problem, drug information, and designing experiments. So again, clinical trial designs. So this area, we are going to discuss how we can improve patient care. So when we talk about patient care, there are different types of services that have been generally provided by clinical pharmacology departments or their specialists in this part of world, starting from therapeutic drug monitoring to independent drug information services, clinical pharmacogenomics, already discussed by Dr. Pulen Sharma beautifully, and these 2 arenas where we had given our service for our patient, that is the clinical pharmacological review reconciliation feedback of drug therapy through our OPD services, and inpatient rounds, how we can identify drug-induced disease and drug-related problems like it could be drug allergy and how we can manage those cases of drug allergy. Especially it is important to understand when we talk about differential diagnosis for any particular disease, this drug-induced disorder is often overlooked. And that is the area where we should focus. So this is a picture of a very unfortunate girl, and that had evoked a response in US. And we know that after heart disease and cancer, the medical errors, the prescribing errors, that is the medication error, that is the leading cause of death. So third leading cause of death in US. And what is the situation in India? There is a documentation that almost 52 lakh medical errors occur annually in India. But we need to acknowledge this is just the tip of the iceberg. The same paper is suggesting that 43 million injuries each year happen due to medical care, and nearly 23 million days are lost as a consequence. We have done one small study in a clinical pharmacology camp. We did we almost 305 patients where we found they were elderly population. We found 27% polypharmacy, that means taking 5 or more drugs. 42 of these polypharmacy patients were on 98 potentially inappropriate medications. So not only the number that matters, we can define polypharmacy in a quantitative way, but it is important to assess that prescription qualitatively. So how we can assess qualitatively in prescription? There are certain tools, especially in elderly population. We have Beers criteria. We have the potentially inappropriate prescribing or medication appropriateness index. So the system will tell us what is the score, and we can decide. And another important issue is the anticholinergic burden. And if it is 3 for a particular prescription, so that is significant, carrying some risk with the patient. And that was found in our population, and that was associated with cardiac autonomic neuropathy. So this was the finding of our study. So we propose how we can tackle this problem, this clinical pharmacological reconciliation review feedback for patient safety. We had proposed this terminology. This was from a journal of clinical pharmacology. So first of all, we need to evaluate whether our prescribed medicine is unnecessary or redundant, or no or a wrong medicine is prescribed for a given indication. So appropriateness needs to be assessed. Then we need to do the de-prescribing, the rational de-prescribing of those who are unnecessary or redundant or contraindicated or having some adverse drug reaction. Most importantly, in-hospital care that should be associated with identifying different types of omissions and commissions during transition of care. From ICU to HDU, the patient was receiving pantoprazole intravenous. Now, when transferred to HDU, on top of pantoprazole intravenous, the patient is getting rabeprazole tablet. So this should not be happened. So tailoring the dose adjustment to the individual need and perspective. So individualization is an important area, and how we can prevent, minimize, manage the adverse drug reaction, especially the prescribing cascade that we will also discuss today with some cases. Improving adherence is another important goal. How to consider affordability and availability of medicine vis-a-vis the adherence. So that is again a critical area, how we can approach ourselves to improve patient care. Then individualization, accommodating all those patient factors. Yes, we don't have that facility of clinical pharmacogenomic lab in our city, but there are certain centers who are providing these services too. But apart from that, we need to understand other patient factors, like what is the eGFR of that particular patient, what is the liver situation, what is the childbirth score for that particular patient. So this all need to be assessed. And ultimately, our goal should be improving the quality of life. And when we talk about quality of life, we often being taught that we need to focus on disease-oriented evidences, DOEs. But it is important to emphasize on POEMs, patient-oriented evidences that matters, because that is the thing, how we can improve the quality of life for a particular patient. In a 89-year-old, why we should continue to provide atorvastatin 40 milligram? What is the need of that? We need to understand. If a patient is suffering from pancreatic CA and I'm providing too many fancy drugs to that particular patient for some outcome benefit, what is the need of that? So this also we need to understand. And I think there was a beautiful lecture by Professor Anand Patil, and he had mentioned that we physicians are at risk and patients are also at risk. But we physician and patient both are connected by one piece of paper, and that is the prescription. And I think prescribing is a very risky behavior that we need to appreciate. And we often forget it is prescribing is just a cross-sectional thing. We believe that it is a snapshot, but it is not. It is a continuum. It starts with therapy initiation, but we need to follow up prospectively how we should titrate the dose, how we should deprescribe or add some other drug, and switching or ceasing drug therapies. Not only that, we should follow up what is the outcome of that action, what we did, maybe deprescribing or adding some another drug. So this was a case, just briefly I am telling, a 68-year-old lady. You can see she had pain in both knee joints, but severe weakness for 5 days, pedal swelling for 5 months. So osteoarthritis, both knee, hypertension, type 2 diabetes, ischemic heart disease. One thing need to be focused, that is the BMI 36. This is all the drugs she is consuming. This was the finding. HbA1c was out of control. You can see 8.6%. There is hyponatremia, hypokalemia, creatinine elevated, eGFR was below 42, but other routine tests were normal. The thing is that, again, if you go by these symptoms, pain both knee joints, and I am focusing on this BMI again. Now, severe weakness for last 5 days and pedal swelling for 5 months. Now, what happened? There are certain drugs, like these are the continued medicine. She was prescribed a fixed dose combination which contains diclofenac for maybe 5 days for her low back pain, long back. But as she got relief, she was consuming repeatedly for knee pain relief. The thing is that when we are prescribing, it is also our duty how to facilitate informed prescribing. Why I am prescribing? What are the risks if the patient is taking the same medication over the counter? That we need to tell our patient. But that was not done probably, and she was taking it twice daily. Now again, you can see the pedal swelling decreased a little bit. Furosemide 40 milligram for last 7 days. Why furosemide was given? For pedal swelling. Now last 5 days, there was severe weakness, and this is the result. Now again, if we go by this pill burden for this particular lady, and just think that pedal swelling part, and we can see the patient is consuming pioglitazone, amlodipine, pregabalin. Now, without looking these drugs, the patient was being added with furosemide. Now, we had already discussed that the patient is taking diclofenac for a long time. So, what is the need of that? without de-prescribing this drug, probably these are the causes of that fatal swelling. So we are not identifying a drug-induced disorder. Rather, we are giving something drug to that particular lady, and that drug again is causing another drug-induced disorder. So this is the cascade we were mentioning. And another few issues, this is very simple but important to note. When the patient is taking calcium carbonate for a long time, but of no use because the patient is again taking pantoprazole, we know we need to change that salt to calcium carbonate to calcium citrate. These are the simple pharmacology trend. And again, if we go by more details, the personalized medicine, the EGFR based prescription, the rosuvastatin was not appropriate for this. And there are so many drugs which have not that much evidence level when we are talking about evidence-based medicine. What is the level of evidence with rose hip extract in case of osteoarthritis? So this is what is the level of evidence with this type of combination? What will happen to them when they enters into our stomach and exposed to gastric acid? Any evidence? Now this is what we are talking about, the prescribing cascade. Without identifying a drug-induced disorder, we are treating that disorder with some other drug, and that drug is again causing some adverse effect. We are not understanding that adverse effect is due to particular drug. We are adding second drug. So the cycle will go on and on. So what we did? We did this. We used GLP-1RA because the patient was having obesity. We reduced the dose of metformin. Initially, it was being treated with basal insulin as there was some hyponatremia and hypokalemia, and then dapagliflozin was given, paracetamol was given SOS basis, salt was changed, atorvastatin dose was modified, and that was the result. BMI become 28, and with the loss of body weight, the patient gets symptomatic benefit, and we can see the EGFR benefit was also there. So we had published this in JAPI also. Now coming to another case, an interesting case we had faced last year. So this patient, 67-year-old lady, was admitted in CCU with ischemic CPA. So background, type 2 diabetes, hypertension, chronic kidney disease. And this was a dictum. I think, I don't know what happened in Chennai, but without any cause, if the patient is being admitted in ICU, they will get a super antibiotic. And that is the 5% tazobactam it was given. What happened? Initially, there was no fever. But what happened after 5 days? There were some fever. Count to us, you can see that is not that much changed. CRP was a little bit elevated. And that fever was changed with high fever. So what they did, the creatinine was 1.6, EGFR 35.1 according to the CKD EPI formula. Now, sensorium normal, fever panel negative, blood culture sensitive pending. They had initiated with now another super antibiotic, imipenem cilastatin, 8-hourly 500 milligram. Why? Because they thought, okay, so that could be some ICU infection, super infection. They were taking, the patient was on 5% tazobactam, so we need to give something more. So give that. Day 7 of admission, there were 3 episodes of generalized tonic-clonic seizure, but fever was still persisting. So generalized tonic-clonic seizure was managed by lorazepam, 2 milligram IV stat at night. We know that time the senior doctors are not available. So junior doctor give lorazepam. And what is the consequence of lorazepam? That immediately the patient deteriorated. SpO2 falling, drowsiness, required intubation, mechanical ventilation. Now all these tests done. Routine blood test otherwise normal, only the creatinine is again little elevated. Total leukocyte count was not that much high. So manage with levetiracetam now instead of lorazepam. Day 9, fever persisting. Now the blood culture sensitivity report came and there was no growth. So what they did, they stopped now imipenem cilastatin. Now they had identified this is a case of what? Drug fever. And after 4 hours of discontinuation, the patient was being afebrile and discharged after 15 days of admission. So there is a prize question. Our president, sir, will give one prize who will give the right answer for this question. Right, sir? So which statement is not appropriate? So diagnosis written in the discharge paper, type 2 diabetes, CKD plus CTA. Now, second is carbapenem can cause seizures by their ability to bind to GABA receptor and inhibit the GABA response competitively. The when we talk about drug fever, so who will give the answer? Relative bradycardia and rapid recovery after de-challenging. That is the two important feature of drug fever. And eGFR value considered here was also inappropriate, leading to overdosing of imipenem. So which is the right answer? Anyone? President sir will give you a prize. So I think who is the first? Yeah. So I think this is very important. That is the common mistake we always did. We often forget about the drug-induced disorder. Here, I just want to focus this point, the eGFR value. We can see the 67-year-old female whose eGFR creatinine was 1.6. So eGFR, according to the CKD-EPI, it comes around this 35.1. And if we go by the prescribing information of imipenem cilastatin, we can see this comes here. So 500 milligram every 8 hours, the patient was being prescribed that only. So the dose was appropriate, right? But what happened? Actually, we missed the clue here. We had calculated eGFR there by the CKD-EPI formula. But in the prescribing information, it was clearly mentioned the Cockcroft method. And when the weight is an important factor, eGFR varies. And if you calculate here now, the eGFR in the Cockcroft formula, it comes around 25, so much below. So actually, that dose should be 500 milligram every 12 hours. So this is very important thing we need to understand, because medico-legally also we are very much vulnerable nowadays. So we need to protect ourselves medico-legally too. So this case again we had published very recently in IGAG, Indian Journal of Academy of Geriatrics. This was one of our old study which we had published in JIMA, that anticholinergic burden. So we prescribed lots of drugs in our elderly population without understanding we are increasing the risk of anticholinergic burden to them. And if we do right time deprescribing, that can prevent. This was again another paper which we do this clinical pharmacological consultation in diabetic patient care, that how we improve our output. And after that, also this is a report from TOI, Times of India, which had also emphasis how we should integrate clinical pharmacology services in different hospitals, because in Kolkata we have only 2 hospitals now. Initially we have only School of Tropical Medicine, now we have Archigor Medical College. I think that is not infamous due to a very unfortunate thing, but that was again a premier institute in our state. And the clinical pharmacology department had been started there. Just there are different cases we had published. This is from IJPP. The thing is that many times we got referral that whether this is actually drug-induced disorder or not. This case, what I just want to focus, the allergen immunotherapy developed systemic lupus erythematosus. So this case was referred to us, whether it is actually related with allergen immunotherapy, SLE was related or not. So again, this is our responsibility to establish the causality. And in that case, we had found there is no relationship between allergen immunotherapy and development of SLE. So that is also our duty. At the same time, these are a few important drug-induced disorder cases, we had noticed one ranibizumab-induced left middle cerebral territory infarction. After that was intravitreal injection and a tibial fracture in an elderly female patient of rheumatoid arthritis patient. So again, Professor Patil sir was mentioning about the simulation. I think this is again an important simulative option, the toxic drone approach. And I don't know how many of our pharmacology students will agree they will provide this type of emergency care in hospitals. So we have to also provide emergency care. So if we want to popularize this service, we need to provide emergency care as a clinical pharmacology consultants. So this was again a case how we actually identify an anticholinergic toxidrome by this toxidrome approach. Now the last part of my presentation, it is also important to evaluate new and old therapies that also we did. From our perspective, when the lopeglitazone was being introduced in Indian market, there were lot of hype with this molecule. They had done some pharmacophore change, and that made it some novel thing, some advantage over pioglitazone. So we need to do systematic review meta-analysis, and we had found not significant effect in favor of lopeglitazone. And I think now you can see lopeglitazone is not that much being prescribed. At the same time, we need to do something like we have done this saroglitazar systematic review meta-analysis in NASH and this semaglutide. And after that, the Brazilian Diabetes Society, their position statement, they had cited our paper and they had included the GLP-1 agonist in a level A evidence as a first-line treatment for steatohepatitis in people with type 2 diabetes. So this is also our responsibility. Again, some company, we got that news, some company is trying to bring this cangrelor, which is a very costly molecule, intravenous molecule. They want to bring this in India. So we had done this survey and we had found no extra benefit when we compare it with ticagrelor. So for a time being there, having some pause, we had done this molecule systematic review meta-analysis with vonoprazole. We had subsequent vonoprazole meta-analysis, and this was definitely being proven better molecule when we are having pantoprazole resistant GARD. So the thing is that we had challenges too. We need, because lots of private hospitals are including clinical pharmacologists. In the name of clinical pharmacologists, they do not have any medical degree. So that is important. We need to include medical professionals as clinical pharmacologists, at least MD pharmacology or MD internal medicine people who has training in clinical pharmacology. They should get in the position of clinical pharmacologist. Of course, there is an important role of clinical pharmacists there. They have definitely a supporting role, but as a clinical pharmacologist, we need to provide, as we know that in Indian clinical pharmacology, there are very few people in this country. So we need more people from MD pharmacology who are being trained in clinical pharmacology, or MD internal medicine people who are having some so also this was a issue we had done. Lastly, we'll discuss about some generic issues. What we do, yes, India is a generic hub, we can say. This is the pharmacy capital of the world. But this was an experience from our study when vildagliptin brand become off-patented. What happened with that 96 prescription of branded generic vildagliptin? Each prescription of branded generic vildagliptin resulted in almost 2.29 pharmacy visit, and upper limit of that pharmacy visit had reached up to 30. So this is something really concerning, and 28% of those patients again switched back to innovator brand, 41% switch to other branded generics, 31% patient receive the prescribed branded generic. So if we talk about the generic medicine, they are required, but at the same time, how we can tackle this problem that also need to be addressed. We are also developing some devices. I am not going. So this is my final slide. I think we know about the Vishwarup Darshan at 11th chapter of Gita, where the Sri Krishna had shown his Vishwarup. Yes, clinical pharmacology is something like that. Vast thing. It is not possible to cover all arena of clinical pharmacology, but to actually foster the clinical pharmacology here, we need to go back to the Purushottam Yoga of, that is the chapter 15 of Gita, and where we need to think ourselves free from those vanity and delusion. That means we are having lots of degrees and lots of papers in our bags. Then we need to overcome the evil of attachment, because yes, this attachment evil is important for us. Here, Krishna tells we need to constantly dwell on the self and the God. Here, I just modify instead of God, we can place clinical pharmacology there, because we are student of clinical pharmacology. So constantly on the self and clinical pharmacology, who are free from desire to enjoy the senses, are beyond the dualities of pleasure and pain. Such liberated personalities will ultimately attain the clinical pharmacologist's eternal abode. And I think that should be our goal. We need to do our work. And of course, I need to acknowledge the contribution of my guru, my mentor, Professor Shantanu Kumar Tripathi sir, who was my guide during my journey with clinical pharmacology. So thank you once again, global people and organizers for giving me this opportunity.
Thank you so much, sir. That was an elaborate presentation. You just shared the scope of clinical pharmacology from WHO point of view to all the points, what can be done by a clinical pharmacologist, such a horizon, and ended up with Gita. That was a wonderful presentation. And for want of time, we are just moving ahead with the next sessions. And you can share your views or you can ask your queries during the lunch time with sir. I think we can conclude the first scientific session of today's program. I, along with Dr. Anusha, thank the MPSCON team for giving us this opportunity, especially for the wonderful topics they have chosen and the apt personalities whom you have chosen to deliver the lectures. Thank you so much, sir. Thank you. Thank you.
Thank you so much, speaker, for the wonderful session. And as we come to the end of the session, it's time to express our gratitude to the distinguished speakers, chairs and co-chairs who are sharing the knowledge today. And to present mementos to the chairs and co-chairs, I request Dr. Preeta ma'am to come and give the memento.
Ma'am.
I request chairperson and co-chairperson to give mementos to the speakers. I would like to invite Dr. Sapna Patel to the stage to get them. I invite Dr. Ravindra sir to come forward and get the memento.
Thank you so much, ma'am. I would like to invite Dr. Srinath sir to come forward and to give the memento to the most promising young MD pharmacologist award to Dr. Kulan Sharma sir. Sir, please come forward.
Can you read the name?
Better always Please, sir. Sorry, you are student. You should be here. You should be in the student.
Thank you so much, sir. Now I would like to invite Dr. Shahnaz ma'am to give the NPS Most Promising Senior MD Pharmacologist Award to Dr. Anand Patel, sir. Anand Patel, sir, please come forward.
Motivation, so many.
Thank you so much, sir. Now I would like to invite Dr. Shrimurthy, sir, to give the NPS Most Promising Young MD Pharmacologist Award to Dr. Shambhu Samchada, sir. Sir, please come forward and give the award.
Now we will move on to the next last session, scientific session of the day. It is my honor to invite Dr. C. Sudhakaran sir. He is the Associate Professor in the Department of Pharmacology, Sarita Medical College and Hospital. He has been awarded with UK CET Prize and B. UV NAS Prize by IPS for best works in clinical pharmacology and autopsy pharmacology. And he's been the first person employed in the world for Accenture when pharmacovigilance was outsourced by the pharmaceutical company. And he is involved with 13 IECs in various capacities. Now I introduce Dr. Ashokan sir. He is the chairperson for the next scientific committee, and he is the professor and ex-HOD pharmacology in the department in ABM and VMRF Puducherry, and he is ex-MEU coordinator and chairperson IAEC ABMC, and he has 28 publications and 5 patent registration. I invite both chairperson and co-chairperson to introduce these speakers. It is over to you.
Good afternoon, everybody. At the outset, I apologize for the delay for the sessions, and we are running short of time. So what I would like to do is that probably we have to curtail the session and then try to complete as fast as possible. So that's the thing. But I have the honor to introduce one of our distinguished speakers, Professor Vikas Mehdi. Dr. Vikas Mehdi is a well-known personality as far as the Indian pharmaceutical world is concerned, or Indian pharma departments are concerned. And if there is a contest who is the best pharmacologist in the country, probably 90% of the people or 95% of the people will be able to answer it as Dr. K.D. Tripathi. And probably Dr. Vikas would be a close competitor for him, and probably might come out with the percentage of around 89%. So I have been associated with Vikas Mehdi for the past few years, and his work is exemplary. He has been the professor of pharmacology from the prestigious Institute of Postgraduate Institute, Medical Institute, PGH Chandigarh. And he's also the editor for this journal, Indian Journal of Pharmacology. Dr. Adityan and Dr. Ravindran made this journal, Indian Journal of Pharmacology, as one of the treasures for Indian Pharmacological Society. And it is Dr. Vikas Mehdi who has taken it to the dizzy heights, and probably now it is one of the most acclaimed journals in the next to Indian Journal of IJ Medical Research. This is a journal that is coming close. So I have immense pleasure in inviting Dr. Vikas Mehdi to deliver this August lecture. So he has written a book on experimental pharmacology, and he is a clinical pharmacologist by profession, and he is associated with so many ethics committees, and is also a member of the DTAB, Drugs Therapeutic and Advisory Board of the Central Government of India. So these things speak volumes about the character of Dr. Vikas Mehdi. And of all the things what I like about Vikas Mehdi is that even though he has all these credentials, he is a down-to-earth person. And he is a very, very affable person who can mingle with anybody in this room. So I take immense pleasure in inviting Dr. Vikas Mehdi to deliver this opportunity. Dr. Vikas, stage is yours. So during the next 25 minutes or so, he will take us through the thing that what has happened to him and how these things are going to evolve in the next few minutes.
Yes. So thank you very much. Let me tell you that I came physically because of some other reason. I have taken online. Continuously. So if I look at last 25 years, right? Are you going in the right direction? That is my first question. In the field of pharmacology. I may be critic to some of the people, because last year I attended a meeting of LASACON. LASACON is a bigger forum for animal experimentation. So I met a person and he said, when is the next meeting? He said, there is a LASA. LASA become a LASA. So if I look at pharmacology, like I always counted how many society has been created. It's good to have in society, but there is a responsibility to contribute to our student also. Because last 2 meetings I attended, and I could see in European setup how they encourage the student. I was really interested. They want to have their skilled person. It's a direct contact. And that is what, like, we conduct a meeting, then next 1 year there is nothing. I think this need to be changed. Maybe some people will not be able to, like that comment, but we are going totally diverse direction. We need to be integrated that one. I just wanted to say that, how actually we can contribute. Like if you say, contribution to different fields, experimental pharmacology, clinical pharmacology, regulatory pharmacology. And if you look at today, as you say that we should be at par with the technology. Today you say that next 20 years and 30 years, do you have an expertise for medical devices? Do you have an expertise for, any of the food with medicinal value, natural product? That need to be developed. Today, if I ask you a question, can you name some toxicologists in India? I can count 1 to 3%. Okay, so there is no expertise we develop on toxicology. How you extrapolate animal toxicity studies to the clinics for writing the page on protocol. I can count the number. Of course, we have clinical pharmacologists, but at the practical session, when you go, like if you work in any developed countries, they're in a part of clinical decision. They go for a rounds, they're actively involved. And if you today say that how you, give your importance, if you go to hospital, because I ran the hospital for 10 years as an administrator. So as a pharmacologist, how do you get an importance if you give a service? How many of the medical colleges we have TDN service, or is it drug information unit, pharmacovigilance, material vigilance, or the new field? That is required actually. We need to be innovative. You need to be innovative. Today, if you ask what you wanted to become, they will say, I want to become a clinical pharmacologist. But you wanted to become a clinical pharmacologist without any knowledge of experimental one. I'll just give you one example. I have taken requested Dr. Y.K. Gupta for some of the exam in North India. And I just told him that you ask, the question. So if you say MD student, they don't know what is the difference between the mice and rat. They really don't know. You ask, can you name some rodent? They will not understand. Can you ask for a strain? What strain this? They will not be able to understand. I'll give you a bigger example. I have gone for a professional interview in Patna. And director had told me there's a post for veterinary post. Are you going to? Because I was sitting there, I have an evening flight. I said, okay, I'll go. I started with question of, experimental animals, strain, different question. Later on, I end up of asking, Bhaiya, Januar dekha, Januar. Okay. I started asking that question. Then one person sadly you say, he was not able to speak about guinea pig. He was saying guinea pig. And that is what I just wanted to say, that we really need to look at that. If you say, is the animal experiment is banned? It's not banned. Only if we do not have an infrastructure to create. Okay, like today if you say US FDA have put that no regulatory toxicity study will be done. It will be an alternative method. It will be an alternative method. It has been signed. Can you implement that? We have discussed in a way city, we discussed with IUPAC forum also. Because if you say today, I remember one meeting of ICMR, I was called, I was in the airport, I went back. You know, the reality is that there are 1,400 crore rupees was allocated for one of the institute to create a facilities for whole pan India, from smaller element to higher element. So in that meeting, you know, there are two foreigners. One is from US and another is from Europe. And they say, why don't you direct this money to one of the NGO in Hyderabad? Okay. And during that meeting, I told them that I remember I was in Ames, I had to take a ticket. I was in a queue. And suddenly one white man came and that fellow called that white man. And I went and asked the question, when did you get an independence? We got independence in 1947. Same question I asked that person who is delivering from Europe and US. Who are you to direct us to our money, 1,400 crore for this engine? So we need to understand from all the aspect that if our students are not trained today, whom we are going to approach tomorrow? To the Europe, to the US. That is what's going on. Our students are not familiar with experimental setup, and one generation, two generation, third generation will have to depend on, will be going for a training to do an experiment. So this is how it is going on, and that is how we have to see. So I'll talk about how we can contribute to experimental and clinical pharmacology as well as some social aspect. Okay, so that is what I thought of doing that. So when you say pharmacology, if you say, just read that. I remember the first day when I joined All India Institute, and they were doing a cat experiment and dog experiment. I was so depressed. I just left the department because I was interested in surgery. I had done a lot of surgery during my internship. I was so depressed. But later it was switching on. Today, if you say that, you know, blood pressure experiment, how do you look at the reflexes? Cat is an ideal animal. What are the anesthetic agent you are going to use that? You know, you have a simulation method, but we have done it practically. And you learn a lot of mechanistic approach, how it is going to like. If you understand the physiology of it, and definitely you can go for it. Like if you refer it to, like if you are in, I was in Cambridge for a couple of weeks. So there if you say details, how they did it. He just put a, you know, cannula into carotid artery. And that's how we have a direct measurement and indirect measurement. Same technique can be used for a future prospect also. If you say, you know, is it, you know, you say pressure effect, volume effect, and you say, what is a carotid reflex? Is it bilateral? Is it unilateral? You can debate that. Because one point you have already put a cannula, other one we are lifting the carotid artery. So all this knowledge need to be implemented through a simulation, or you can discuss also. And that's how we can see that all, you can see pharmacology, experimental pharmacology. What we did is, we are giving a training to the PG student. We started with neurobehavioral program. Why we started with neurobehavioral program? Today, if you ask who are the people who are doing experimental studies, very few, you can count it. And the reason behind they're not doing experimental studies, they will tell you that it is not permitted like that. I remember the day we went for a KGMC, one of the MD exams. Morning, there's a big newspaper. I end up in Delhi. This newspaper said that all animal experimentation are banned. And when I went to that exam, and people are so happy. They were very happy, all the MD students. Then you don't have to do any practical. Then we said that, did you get any notice? It is a media report. Then we started an experiment. Okay, but if I say if you don't do it, our next generation will not do it. They're not able to do it. But one thing is that, as I said, we started with neurobehavioral program. How do you extract that animal behavior to the human? Okay, so we have been training all the batches every year and 6 monthly. And basically, if you say that, can you create an ideal model for a disease? For example, if I talked about Alzheimer's were number of models. One is beta amyloid, tau protein, or streptozotocin. And you can see the change of concept over a period of time. Earlier, we only rely on beta amyloid. So you give it intracerebral, ventricular, and 21 days, it develops Alzheimer's. But if you say that human condition, it only develops after 70 years or after 65. So that means you have to calculate how much you are going to give, and over a period of years, it will be accumulating, it will develop, Then it was switched over to that. It's not only beta amyloid, it is a tau protein. There is a new beta-protein. So we put an isoproterenol. Then we have a diabetic link to the Alzheimer's. So altogether, if you see that students should be familiar with that, can you look at that model? You look at the constant validity, phase validity, and predictive validity. So if you have that, gross knowledge, how you look at the constant validity, phase validity, and predictive validity, then you can see that whatever you have done, how much it mimic the clinical situation. Similarly for other model also. So if I take an example of IBD, it's a common model. You can also create 4% acetic acid. Within 4 years, it is going to have an inflammation. But if you say this disease has very important component of immunomodulatory property, immunological. So you switch over to DNBS or DNCB. So any chronic situation in experimental setup, if you go beyond 4 weeks, then you say clinically it has a chronicity. So these are some of the models we actually talked about, and all this research, safety, kinetic, or how we are going to postulating, we initially started with kinetic studies like for a rabies. Ideally, you can give the drug, you can take the blood sample repeatedly, you can estimate it. So you can all this together of therapeutic intervention or pharmacokinetic and drug interaction. Initially, you can generate the preclinical data. As you need a skill, that today we talked about that how to give an intravenous, but how do you take a blood sample from a mice? Somebody from microbiology, they asked me that, can you take out the blood sample? I said, I thought it is 4 or 5 mice. And when I went, there are 80 mice. I had to do that. So if you look at the vein, there's a middle cubital vein, there's a 2-side vein is there. How do you do that? So simple question, if I ask that, you go to the clinic and you ask what is the cost, like blood bank, you use 18 gauge. And minimum, when you go for small needle, it is 26 gauge. Many times we ask the question, how do you look at this gauge? Okay, suppose this gauge is like 18 gauge, 1 inch cut into 18, and this is 1 gauge. Similarly for 26. Okay, so if you do that, then you can always go for, in case of predictive population also, you can easily find out the vein and you can do it. So these are clinical skill as well as experimental skill is required for any of the students. So here you could see that we need to work for, I'll talk about some of the programs, how we do it, public health and innovative research model. So these are the model is there, like, that there is a, Vietnam War. And after the Vietnam War, they could notice that there are a lot of cases of autism. So if you today say that you go for any of this, meeting, how clinically relevant is that? I remember one of the meeting I had gone to Singapore, and they call a couple of patients there. It's an epilepsy congress, and out of these 5 patients, there's a patient who is an Olympian. She already got 5 gold medals. So necessarily, I asked the question, why did you call the patient? And they said, you need to look at it, what is their suffering, their practical reality. Then I asked that, why did you call the Olympian? Then they said, if this Olympian would get 5 medals after suffering from epilepsy, why not other people? I asked them that, why did you call the lawyers? And they said that this lawyer is from Netherlands. Those who are seizure-free for 1 year, and he is fighting a case in the parliament that they should get a license. These are social impact, you can think about. I remember one of the meeting we had in Pharmacology. You must be knowing that there's an organization called Pharmacology who only look after export of the medicine. And in that meeting, they call some of the patients or autism, ALS, okay, some rare disease. And when I look at after the meeting, we started this, lab for neurobehavioral lab for autism and neurological disease. So you must think that what contribution you can give. Suppose if I say many people they believe that we have medicine for all diseases. You believe that as a student, MBBS or MD student, but you just make it a list of diseases we do not have a medicine. One is autism. We have a lot of cases of celiac disease. What do we offer after diagnosis? So we offer only gluten-free diet. There is no medicine is available. Okay, so you can make a list of this. Second point is, last year I could realize that I was in the regulatory office getting an approval of a medicine for ALS. And suddenly I asked the cost, and they said the cost is 1.5 crore rupees. Last week, there is a meeting for a spinal atrophy. And similarly, we asked the cost of the medicine, it is 17 crore rupees. 17 crore. So this is also important that we need to look at the dose we require. Today, very few people they work on rare disease. I request that ICMR to have a registration of the rare disease so that you can say that can you take up an issue of a rare disease? We had written an article editorial on rare disease. That I got a letter from Mysore Institute and they asked me how to define the rare disease. And this institute actually said a terminology for all medical terms. So we have to be very clear that if you wanted to work on rare disease, natural product, that should be the motivation as a contribution to the field. Okay, so this is how we can go for overall. But if you say, how do you say? We always tell the student that, are you familiar with OECD principle for a preclinical study? Are you familiar with ICH for a clinical study, clinical research? So we need to be implemented. Like today you are discussing, I have been to some of the university in Malaysia, Indonesia, and other countries. So there you will discuss that whatever training you are getting it currently. Can we create a global platform that we have a new format? Okay, today if you say all the MD students in different medical colleges, are you getting the same training so that you are equivalent in a same platform? Like I'll give you an example. I came to this institute, I was very happy. That MBBS students are doing in silico study, in vitro study, in vivo study. I was very surprised. I think, I used to tell other people also, why from the beginning we can train them like that. So as a PG student, do you understand what is in preclinical study and when you call it non-clinical studies? Can you see the difference? Because people are trying to develop an alternative method. So the terminology of non-clinical has come. Today they are saying that you don't go for it, like you have a concept of microdosing, or we have released a guideline, we must wait on a human model. We wanted to accelerate the process of clinical research. So this is how we go. Preclinical experiment, definitely you have to be trained. But what we did in COVID time, COVID actually, we could realize how change of concept is there. I'll tell you, COVID first meeting, I was a task force member. I worked as a chairman for vaccine and 8 working group. First meeting when they called, and we wanted to, see that how they are doing it. So we called New York Hospital, and we asked that how you're managing COVID, and they said we are also contacting Wuhan Hospital how you are managing COVID. So first day, when we wanted to decide for hydroxychloroquine, the CDC has released the guideline, how many drugs can we go for any purpose. So it was chloroquine, hydroxychloroquine. But we went for hydroxychloroquine. There is one reason that we look at the PKPD data, on 5th day it get accumulated. So initially, on a first week, we are only thinking that it only involved the lungs. We never thought of multi-system disease. Okay, So we go for hydroxychloroquine, but when you go for a global database, you could find that it causes cardiac arrhythmia, it can cause hypoglycemia. So we put a recommendation that before you initiate the drug therapy, why don't you go for a simple ECG or look for all these areas. So this is how we can, actually we had work on different in silico method. And one of the paper we published is how to target the coronavirus. And during that time, you know, that you might not notice that there is another virus case called hantavirus. Did you read? And that was more detrimental. So we are ready with hantavirus, that how we can repurpose the drug. Today we talked about mpox and now. So this method, like students should be familiar with in silico, how you go for in vitro. Basically, you could see the change, you know, in the regulator also. We have given so many emergency approvals of all the medicine existing in the database. We try for a repurpose. We have used the off-label issue. But in a vaccine also, you might have seen that it was not completed phase 3, it was approved as a clinical trial mode. So these all supporting data is going to tell you that how example is there. Okay, so this is how we can say that. But if you say the change of research pattern also, like if you say 50s and 60s, people are more into prostaglandin. All people they are working on prostaglandin. 70s and 80s, if you say people are into nitric oxide. Then 90s and 2000 people are into endothelin. Obviously, we develop many of the products based on prostaglandin, nitric oxide, or endothelin. But last 15 years, people say people are in nanotechnology, stem cell. And today we talk about that everybody is looking for artificial intelligence. But you say that when you talk about simulation or all artificial intelligence, I remember I came to Hyderabad for an USFDA inspection. We're in a hotel. There are 7 people from USFDA. There's a young fellow. He said that we have to go to Genome Valley. And he just opened up the mobile and he said it is going to take 1.5 hours. And I said we'll reach 50 minutes. And exactly we reached 50 minutes. Then he came and asked me that, you know, app was showing 1.5 hours and you said 50 minutes, how did you come into conclusion? Then I told him that this driver, I've been roaming around for the last 3 days and I know how he drives it. And that is why I said 50 minutes. So you need to also, you know, do not lose your skill. Okay, apply to your mind. If you say, a lot of MD students now, if you ask, you know, they use ChatGPT. And how do you get to know? I say, I call a meeting of all the editors. Then we ask that if you like, you can check for plagiarism, we have different software. If somebody had done it with a ChatGPT, what are you going to do? Nobody can verify that you have done. At least you say that student comes and there is no references. It is on ChatGPT. And there are upper grade version of ChatGPT also. I'll just give you an example. My son is very interested he wanted to become a director of a movie. So he used a ChatGPT also. He said, "Ladki gaon se aayegi, shahar mein, kisi se shaadi karega rich person. Now you make a story. ChatGPT make a story." Then I wanted to say that, you know, I put that I'm giving a gastric ulcer for drug to be given. And it all came NSIDs. Start with paracetamol, all NSID. And last line was that please consult with a physician before you take the medicine. And that is why we say that do not, you know, for a writing skill also you use, you know, grammatical software. There's a paid grammatical software. If you use that, like setting up a references, there's a software. But if you start using software, you will never get to run. How you do it manually. And that is why I always request the student, do it manually, develop the skill, and later when you do not have a time, you can use the software. Okay, so that is how you should take it. Like you can say that we have done a lot of studies with nanotechnology, stem cells. So I'm not going detail. So definitely all analytical. If you say that how the skill should be there for an PG student, you develop an expertise for experimental. At the same time, you should develop an experimental for skill for clinical. So when you say you develop experimental for analytical, you have to see the scope, what you wanted to become. And accordingly, you have to develop a skill. But our thing is that we do not go into narrow area. But when you go to Western setup, they go to very narrow area and they go in more deeper. So you can have a generalized skill for doing the every 3 years. Then you can select the topic that I'm going to work. If I say I've been working for the last 25 years, what is my contribution? Did I contribute, which is applied to any clinical practice? And that's how I say that I contribute minutely also. We never talk that we talk about all publication. Did we talk about any innovation? Student can make an innovation and which can be applied. Okay, so one of these like student had come, it is published in Lancet. He did a simple device for cancer chemotherapy. You know that all the patients who receive cancer chemotherapy, they lose the hair. She come up with a device that can reduce the temperature so that the hair can be retained. So similarly, you can do that. So these are some of the studies we have done, but definitely clinical research, how you can, like COVID, we have learned a lot of concepts. We have a decentralized clinical trial. Okay, there are new concepts that we learn. So similarly, when you do it conventionally, you can think that what are the areas we do not have a data. Accordingly, you can do it. So regarding systematic review and meta-analysis, we have been training the people. Okay, because of time constraint, I'll be very quick. So these are research and development. But simple example, if I say that we published one data, and it was not in a great paper in a sense of impact factor. Okay, it was published in Carver, but Goodman-Gilman had quoted that. And that is why I say that go to the rare area, concept with a new concept. It is going to be more cited, you'll have more citation and popularity. So this is how we can contribute. Now, there is an issue during 2013 when compensation issue came. We wanted to brief the industry, we went to Bombay. And one of the professor has said that when we approach for a student thesis to the regulator, it takes 1.5 years and 2 years. Then it was said that Tata will be given exemption. So then I come up with an idea. We made a concept paper, we submit to the parliament, and that's how academic clinical trial was started. So we have actually contributed in a regulator or other aspect also. Today you say that all the MD students must undergo GCP program, must undergo GLP program. Do not blame me, but that is the requirement for the future. So this is what the concept of academic clinical trial was there. And you can also see the GCP, we had submitted the GCP guideline. I've been appointed as the chairman of GCP for Government of India. So you can do that. But if you say that, did you address the issue of natural product? There are a lot of product has been practically used, but there is no scientific evidence. So as a part of thesis, you can do a lot of studies of natural product. Like you can say that IFL has created Lotus database. You go to Lotus database and you can see that you have in silico data, you have in vitro data, you have in vivo data, if there is a clinical case. So all of us, if you say that we are starting an antibiotic program, we make a list of plant product is available, which is culturally approved. Okay. So then if you go to tribal area, somebody has used that can be used. So this is one of the area you can do it, and definitely education. Education in a sense that, like we talked about antimicrobial resistance, we have a program of Pan India. We are teaching the school children across India. I met a cabinet minister. He is a minister for tribals. I said, can you help me? He immediately called the PS and we completed 300 tribal schools. Okay, so idea is that if you can target all the school children, they're going to discuss with the parents or to the grandparents. So that's how we can see that. So these are some of the programs we are running 20 skill development program. Obviously, if you say that students do the thesis, they do not publish. And if you look at the data of India, we contribute only 4%. And if you look at that, inside data, it is 1.38%. So we started a program, public skill development program, systematic review on all this program. But we need to have a basic program of OECD GLP, GCP, and we started a program of pharmacogenomics. Reason behind, if you know that, JIPMER is the leaders. by Dr. Aditya. But after his retirement, we started the program. I was very happy. I went to one of the PhD, interview. And that girl says, I started pharmacogenomic thesis after I attended your workshop. And that is what practically, like, if you feel happy if some students are doing good. If you learn the technique, it's not that you attend the lecture, then after that you forget. So these are some of the programs. You could see that IJP, BJP, or all these programs, you can say that all the programs, GLP, GCP, all the programs. But in this meeting, actually, I was trying to make it kind of a harmonized. As I say, we have more than 28 different societies. I call each and everybody to Chandigarh. Can we harmonize? Can you go to mainstream line? There may be differences of opinion. Okay, individual, some interest is there. But if you can harmonize, definitely for a long future, you can do. So there are so many programs we have done along with that, all these programs on experimental and clinical. And these are the programs we have done. So definitely we can go ahead and we can train the people. So I'll not go in detail. But if you see that some of this contribution, like recently we released a book on pharmacogenomics. People can go, but you know that it's not theoretical knowledge. People can come to PGI and go for a hands-on workshop, how you do it, okay? So that is an idea. So ultimately I joined, Ayufa is the chairman, and I'll be there till 2030. And main thing is that it is contribution to the global problem. Because whatever you do, I said about global platform for syllabus, for not only India, for other countries also. And that's how I released a program for Asian countries, 10 countries. And I had completed 3 training programs. And in Indonesia, 9 training programs. Recently in Nepal, we have been trained. So something like that, when we did it last year, all these medical colleges they came, 19 medical colleges, including Nepalese army. And last 15 days back also, we had done it. So if you say that why I started in Nepal, I went for an MD exam. I used to go. I asked the student after MD, what you were going to do? We asked, are you going to join academic, industry, or other? And they said, they don't know that there is an industry perspective. Okay, so that is why they should be familiar from the beginning of it. What are the career opportunities there? So you always say that you need to know what are the career opportunity, how another 20 years and 30 years it is to go, and that's how we can develop. Those areas is a gray area. I said medical device, food. There are a lot of industry guys nowadays who should work to the food. I've been looking after food for last 15 years. It's a huge career. Okay, so you can adopt it. So I just wanted to put some of my thought, but I always say that when you say contribution, somebody else will acknowledge your contribution. Do not claim it. I'm not claiming anything. In one of the meeting in PGI, somebody said we are equivalent to Mayo Clinic, staying for. Then say, who are you to say it? Somebody else to say it. Then only you can say it. So thank you, and thank you for your question.
Thanks a lot, Dr. Vikas. It was really, we had probably gone back to the nostalgic days of working in Madras Medical College, and we used to work with the dog experiments and other things. And really, it's thought-provoking. What I request Dr. Vikas Nedi is that to cultivate this habit among the different pharmacologists, whomsoever he is coming across. And he has been doing it, but my sincere request again is to go beyond this and go on cultivate this, inculcate this habit among the pharmacologists in India, if possible abroad also. So with these few words, I thank Dr. Vikas Neti. Since we are running short of time, probably we'll go into the next session. Sincere thanks to Dr. Vikas because he has traveled all the way from Chandigarh for this. And we are delighted to have Dr. Vikas with us.
Good afternoon to all. As we are running short of time, at the same time, it's pre-lunch period, so everybody in hyperglycemia. it is always very difficult to run the show. Pre-lunch as well as in the post-lunch sessions. Before that, I thank the Department of Pharmacology, head of the department, Pranavkar sir and his team, as well as the MPSCON President Shivamurthy sir, for having given me this chance to appear co-chairperson for this session. Now I am very happy and privileged to introduce our speaker, Lini Subi. Lini is a distinguished professional in the field of regulatory affairs. So far, we are in the various AAS clinical trial sections. Now we are in the regulatory track, boasting more than 2 decades of experience in navigating the end-to-end regulatory process and requirements. As the CEO, Chief Executive Officer, and Chief Regulatory Affairs Expert at SIMATS Scientific, she has demonstrated exceptional leadership in the realm of complex medicinal products in Europe. Her expertise extends to providing strategic guidance on product development and regulatory strategy, ensuring compliance with global agency requirements. Her career trajectory includes significant roles such as Head of the Regulatory Affairs and Director of Regulatory Affairs in a European consulting company, reflecting her depth of knowledge and commitment to excellence in the pharmaceutical industry. She also worked with companies like Novartis, Intas Pharma, Opron Limited. She participated in many complex projects, scientific discussions with key European Union authorities from development to approval stages, and also worked for more than 1,000 marketing authorization application of marketing authorization applications of Indian as well as global pharma companies. So see, not only more than 1,000 products. We have to give her applause for that. And not only that, he is the accomplished regulatory affairs leader, founder of pharma and IT startups, and as well as budding entrepreneur, and blessed with 4 kids. Thank you, madam, for giving the chance. The floor to yours.
Very good afternoon, all of you, and thank you for the nice introduction, sir. And I'm very privileged to stand in front of you all, and I'm very honored. And Dr. Bikash had very wonderful and thought-provoking session already on the industrial pharmacology or the clinical applications. So I think he already covered many things. So I'm not an authorized person to talk about the medical pharmacology or medical affairs, but my aim is to just bring an idea why the medical affairs professional should have a regulatory vigilance or regulatory wisdom, especially in the global pharmaceutical front when you deal with many innovative therapies. We have seen so many sessions on the pharmacology and all, but here my talk mainly based on the innovative developmental side to approval. You already know pharmacovigilance and many other areas because we regularly deal with all these end-to-end aspects. Many kind of many generics, many innovative, also biosimilars, and also I'm lucky to work with some of the key European and FDA experts who work with clinical development and clinical safety, clinical pharmacology, pharmacokinetic assessor. They work earlier with EME and all. So from that experience, I just want to put a little bit on the regulatory wisdom the medical affairs professional has to have. And then again, the importance And I think doctor already explained about the innovative things that's happening, emergency approval kind of. So the regulatory pathways, being a research-oriented medical affairs professional, you need to understand the regulatory pathways little bit. So then only you can overcome some of the barriers. You will see I'll just give you some idea about the normal regulatory barriers. And then also need to understand what is scientific advice, because there the brilliant application of pharmacology or the medical affairs is coming into picture, especially when we take the regulatory approval and some essential skills and the regulatory environment in India, and then how you have to move forward as a student as well as a medical pharmacologist, and what you can contribute for India. Okay, so we all have seen or medical affairs professional or healthcare professional faced a huge challenge in the recent times because of the COVID-19. You all know, I don't have to explain. At the same time, there are that many number of diseases, still no therapy, doctor already mentioned. And then, there are more than 8,000 or 7,000, 8,000 orphan diseases are there that is still not having treatment. And then again, 300 million people are globally suffering. According to the latest statistics by Lancet, there are 300 million people globally suffering without any treatment. So there is an unmet medical need. You have to keep it in mind when you move forward with your career options. So you need to have the options of regulatory available, the pathways, the systems available little bit, to navigate these hurdles. So when I talk about regulatory in general, many people think that it's just documentation for getting approval. Do you believe? But I tell you more that, it's not just documentation, especially from my background. I handle all to people to, ask me what is regulatory. I used to say, because even pharmacy people, they don't know. Some medical people, they used to ask me. So I consider regulatory, it's a lawyer job, of course. It's an administrator job, sure, because there are some applications, some documents, some software needs to be dealt with, some kind of, legalization. There is an administrative part. But more, it's a scientific aspect involved. If you have to get through these regulatory barriers, it's all scientific. So coming to the point, mainly we are safeguarding the patient health by ensuring or demonstrating safety, efficacy, quality, mainly. I'm a quality expert too, mainly a regulatory as well as a quality expert, where I work more for the scientific advice meeting. Here, the role of the medical affairs comes more. I associated more for the efficacy and safety aspects. So here, I need to add one more. When you take an innovative pathway, any innovation, any ideation, that go through a phase of safety, efficacy, quality, and then patient access. So the ultimate aim is to how quickly you are making this medicine available to the patient. We have witnessed that at the time of COVID. So here, the strategic knowledge, both regulatory and the medical affairs, these two are the these two areas are very actively involved from the pre-discovery to the approval, even through the post-approval. You all know the preclinical requirement, especially animal toxicology requirement in silico now. All the applications in Europe then require in silico, even US and other. I don't know to what extent India started asking those kind of requirement, but now even for a generic, you need to have this in silico data, QSAR, we call for the related substances. So it's a very active requirement. And then for, if it is innovative, you don't have to say, like that many number of animal tests and there. So very active role as a preclinical pharmacology, then comes the phase 1, phase 2, phase 3. So all these stages then comes to the regulatory, then again we need to have the whole pharmacology literature evaluation data in the dossier that is going to the authority. So it's a very dynamic role. And then more, I would say, the strategic knowledge at the right time of the this clinical phases, because with one clear strategy in the very beginning of the drug discovery, you cannot move on, because sometimes you need to continuously interfere in the clinical studies or kind of applications in between, and have to provide the clinical support as requested by the authority, or as required by the internal teams. So if you have that strategic knowledge and then application of guidelines, then only we can drive this innovation with the compliance and ultimately with the patient health outcome. So ultimately the patient access will happen if we have that high grade of strategic knowledge. So the importance of regulatory vigilance, I just quickly take you, what is vigilance. So vigilance is nothing, it's a proactive and continuous monitoring of regulatory changes, updates and whatever. Then only you can make sure that whatever you are submitting or whatever you are dealing with, the regulatory activities is compliant and it's aligning to the global and the international standard. So here the key components of, not all, just to quickly take you, monitoring the regulatory changes. So whatever changes happening in the industry or the regulators, sometimes it even could be some safety updates or a product recall. So not only from India, any global authorities, you need to have this vigilance from now on, not only when you need this kind of wisdom or the vigilance you need to have. So that will ensure that the company's practices or the hospital or whatever, the practices remain compliant across different regions. And then compliance audit and risk assessment. Okay, you hear about a change. Okay, you need to think. Or you heard about a new guideline or a new requirement from FDA or the EU authority. You are working for India, it's okay. It's okay. Or you are a healthcare professional, it's okay. Have you ever checked? Is it compliant? What I'm doing, what we are doing at the company, what practices you are following, what changes you are making in the industry, or the safety analysis or whatever you deal with is compliant. So you conduct a gap analysis and do a risk assessment, so you can make sure that it is not reaching to a larger issue or other kind of problem. So interfering at the right time, that will only happen if you are vigilant about the regulatory changes. So I think now onwards, you have to keep an eye on, especially different therapeutic areas, and then whatever changes happening in that area. So according to your interest, you have to keep an eye always and conduct a gap analysis. Another component is post-market surveillance. I'm very sure that you all know very much about the pharmacovigilance. When we talk about the post-marketing surveillance, people will say mostly safety reporting, adverse event. What will happen after that? Anybody thought of that? I think this is the area where India is lacking. This is the area because, as I mentioned, the introduction you have seen, I worked on so many marketing authorization application, even post-approval for European region. They have a very strict pharmacovigilance practice. Okay, so whatever signals, whatever ADRs reported, there is another regulatory phase. This data needs to go back to the authority, or authority will ask the company to update your product information. And that will happen only after you file a regulatory change in association with the medical expert or the medical writing team or the clinical development team or the pharmacovigilance team in consultation with the people who are involved, make the necessary update and file a variation that will be approved by the authority, and then there will be an implementation phase. You will replace all the products in the market. Is this happening nowadays in our surroundings? So there is a big regulatory phase. This is why many product recalls happen. I tell you, I have given a case of pharmacovigilance also about one company at the right time completely renovated or reformed their pharmacovigilance system. So they could be compliant after the pharmacovigilance implementation or whatever. But there's an actual case in front of me. I'm not telling the company name. A bigger generic company from India that has been sold and not in the market, not active. The name is not active in the market. But some years ago, it was the #1 generic player from India. Okay, they faced this kind of not only pharmacovigilance, packaging compliance related matters, and I think MHRA or one agency asked one of the consultancy or the company to outsource to audit all the data and the packaging in the market and whether it is compliant. So all is happening. ADR is reporting. Everything is there. The regulatory communications is also there, and it must have filed also. Then not appearing in the actual packaging in the market. So there is a compliance, bigger compliance. So medical affairs professionals also need to ensure that this is correctly reported. And here one thing, India, I mean, we always demand that India should have a SPC database. I think it is in progress. That's what we hear. Are we referring any maybe MHRI or any authorities, SMBC? We need to refer always. SMBC means the prescribers information. It should be very authentic document, approved document. It's not a document like we have to refer here and there. That country, what adverse events or is approved, that has to be appeared in the SMBC. So this is very demanding and this is very challenging. This is very challenging area, and there are other complaints. And then companies started looking at the data after at the time of renewal. So then that's a hurdle for regulatory. We need to see what all safety communication, what all things the PSU are, whether correctly updated. No, are we having this process in India? You think maybe you are better knowledgeable for India about these matters. So the post-marketing surveillance and the role of the wisdom the vigilance is very important. We have to always keep an eye on the happenings, not only the databases what we have locally or internationally also from different areas what is coming, and we even at time of prescribing we check. You keep an eye on globally on this kind of updates. And then again, I'm not limiting cross-functional collaboration. There is a very active involvement, especially in the early stage development. You need to collaborate with other experts of, regulatory affairs and research and development team, formulation team, and other kind of teams. Then only you can devise a strategy in the early. So, in order to do that, you have to be very vigilant on the regulatory updates happening. So, I already gave a case. Now comes the regulatory wisdom. It's nothing. Whatever knowledge you have that you are applying, you are ensuring that we are taking the product at the right direction. When I talk about generic products are okay, but when you take a new therapy or a new medicine, new molecular entity or whatever, new drug application or anything, if it is of something particular use, you need to see what quicker approval pathways available in that country. Doctor already mentioned many emergency use approval happen from India. That is one option. But then again, there are many incentives. There are kind of separate support from the EMA or FDA or other global authorities. They provide you quicker approval and strategic support in between or during the development also. So it's not a straight go from the very early discovery to approval. You need to continuously interact with authorities. There are different options available in the different systems across the globe. So this information definitely help you to navigate the legal framework or the complex drug development process to approval. Then only the ultimate aim of the company, the success happens only when this medicine is approved in the market. So the role of medical affairs, they collaborate closely with the regulatory affairs to ensure that the drug development process adheres to applicable regulations and standards. Okay. So this is essential for the successful launch and approval of innovative therapies. Just a quick overview of the different pathways available. Here I mentioned, in some countries, the initial marketing authorization with a limited data, that is conditional marketing authorization, especially for some breakthrough therapies and all, is available. And then some yearly, especially for the rare diseases, some yearly access options. There we can continuously discuss with authorities. And then some priority review options available with some authorities. And then joint assessment. So authorities collaborate and review in parallel, like EMA, FDA in parallel. Singapore and some other, there are some collaborative mechanisms available globally. So need to have these kind of knowledge to, accelerate the drug development. So understanding the pathways and system to support early access is very essential in navigating the regulatory pathway or anything, even clinical trial. These are some of the key challenges I mentioned, already explained through different class sections. And then addressing all these challenges enhances patient safety and industry success. Then another thing, scientific advice. This is a very, very technical area of the involvement of the medical pharmacology professionals are there. We are designing the study or, discussing the strategy with the key authorities of EU or FDA even before start of the study. So we can have the cost-effective clinical trial approaches, and there are many benefits. We will know we are going in the right direction. So I mentioned all in the slide, different areas of the clinical, non-clinical areas coming in different scientific advice sections. So it's a brilliant area of expertise where pharmacology professionals can actively involve. And these are some essential skills for navigating regulatory pathways. Most importantly, you need to have the scientific background in making all this communication with the complex situations with the regulatory authority or the professionals involved or with the company. And then you have to have excellent communication skills, and also you should be knowing the digital platform, how to exploit data. A lot of literature review, the pharmacology review is there. So from all of these, you need to have the skills to analyze and have the strategy. You need to devise the strategy. So that kind of skill you need. And then attention to detail, I don't have to tell you. More important, the critical thinking. Then other than the normal pharmacology knowledge, you need to have all these kind of skills. Then only we will reach to the decision-making process in the companies. And then how to stay updated, of course, networking, this kind of workshop. And one other thing, conduct gap analysis, the last point. Conduct gap analysis of the compliance standards of what you are doing in the company. So that will also give you some knowledge or any new updates. Accordingly, you do a gap analysis or compare the activities that will give you the differences and help you to implement the strategy. So there are and then again, continuous learning. So these all will help you to gain regulatory knowledge. And I have to bring a thought on you, this is a statistics from FDA published in 2022 for the innovative products approved in only US. This is the US strategy statistics. There you will see almost 35% of the trial recruitment happen from US. You will see all other countries the percentage, and where India having only 2% for the innovative. These statistics of India improved a little bit in the recent times after the COVID. You can see the WHO statistics, but I would say more of the phase 3 or the late stage trial. So the innovative pipeline, India, so that is lacking. So here the professionals like you have to bring your thoughts and work for the country. So I think especially phase 1 and phase 2, a lot of debates happening nowadays, you know that. And a quicker thing, I think it was another slide. It's okay. So we have seen the regulatory pathways. You need to have the wisdom of the knowledge of the regulatory pathways. And when you take any words into the global standard, you need to know how I can harmonize. Okay, you need to include Russia, you need to include China, you need to include different European countries. What are the standards available in that country? Can I go with the same trial or same kind of information with all of these? So there could be some hindrances, especially Russia, China. You look at, some highly recurring local trials. So these areas where India needs improvement, and especially collaboration. Being a regulatory professional, I would be happy if India is leading the world in assessment. So globally, many countries have started, especially the joint, the collaborative and reliance pathway. Reliance pathway means already FDA assessed or European agency assessed. Then can we take this medicine to the other country? I mean, straight away can we approve it or not? So there is a reliance that the authorities have to have an understanding to each other on the standard. So that will only happen if India work out on some mechanisms and you people can think of what improvements we can make in these areas. And then regulatory interacting with the regulatory authorities, again India needs some improvement in that, especially for the innovative pipeline informal scientific advice. We need better transparency, even guideline. Orphan drugs, already mentioned, India need to have very transparent approach for how I can have an orphan designation in India. What is the application process? Do we have that? So you think about it. So medical affairs professional can contribute for the betterment of our regulatory environment and also think of innovative pipelines. So here, the way forward, my intention here is just to bring an idea like I already mentioned, you need to have that vigilance and regulatory wisdom. So the aim should be to bring India as a hub of innovation and make the system improve. So you people can contribute because there are many areas medical affairs professionals work in the safety efficacy related to the efficacy safety. So if you work after working with countries like Europe and FDA, there are a lot more improvement needed for the Indian environment. So I think both collaboration from regulatory as well as medical affairs and then healthcare, all needed. So a collaborative approach can only bring. So the takeaway here, you use it brilliantly, the regulatory wisdom, use it brilliantly to ensure the compliance. Thank you all and thank you for this opportunity.
Thank you very much, ma'am, for the enlightenment on this vigilance on regulatory affairs. As you know that the NMC guidelines are very daily changing. We are on close watch. We will be losing something. The NMC will abandon the medical college which is not following the regulations. Like that, we have to follow close watch on the regulatory affairs, on the drug development, and update the regulations according to the international level and keep the quality standards so that we will be coming forward in future. And thank you very much for your enlightening talk. And any questions, please put forward your questions. Any questions in the chat? No. Okay. We'll break for lunch. Thank you. The mic is over to the organization.
Just a quick announcement. So as we came to the end of the session, I request Dr. Guru sir to give mementos to the chairperson and co-chairperson. Thank you so much, sir. I request Dr. Sudhakar sir to give memento to Lini Subin ma'am, for speaker as well as to the sponsor of SIMATS Scientific.
We have one more memento. She is our sponsor also.
I would like to invite Alcamed Medical's sponsor for this event to come and get the moment.
Last one to enter and quickly, organize a lot of things. I appreciate it. Thank you more.
Thank you for the audience.
Thank you so much, sir. And I would like to Dr. Ashokan sir to give memento to Dr. Sachin Manocha sir.
I'd like to invite Dr. Shivamurthy sir, Dr. Melvin, Dr. Aruna, Dr. Anusha to kindly come on the stage. We'd like to honor Dr. Vikas Mehdi sir for MPS Product Senior MD Pharmacologist Award. Dr. Thiru sir also I will request him to come on the stage.
We are very happy to have sir as our office one of the member, very active member. Sir has contributed to MPS society tremendously, the same way how he has contributed to India, and he has been one of the backbone for us. We have been supported by sir with lot of workshops like genomics workshop, flow cytometry. I think 5 sessions, 5 editions of genomics workshops we have done. And flow cytometry workshops we have done with sir, and cytopharmacology workshops we have done. So sir, we are very thankful to you, and we need your guidance, and we look forward for your support. Thank you.
Thank you so much, everyone, and let's break for the lunch, and we can reassemble again around by 2:15. Please come back. All the prizes will be given post lunch. So presenter, please stay back. All the committee members, we are requesting you also to stay back. Kindly proceed for lunch. We'll have the prize distribution after lunch. So please come back at 2:15 to the same hall. Thank you.
यहाँ पे कितना दूर है? मेरा तो एकदम दूर है सर, मैंने गलती से पता है यूएस कॉन्सुलेट के पास मेरे को 1.5 घंटा आने लगा, पर ये कितना दूर से
लगता ही है।
Really struggle when you come back to India. That is a problem. So many, whatever you can do to that. You can do.
अभी मेरा मीटिंग है, मैं क्लास
Everyone is right here. Yeah, this basically that was actually peak then. That poor guard had actually identified something which is going to cause problem. So that's true. Yeah, that is true. That principal is a notorious person. And actually they are running the health system. You know, in India, in West Bengal already there are a lot of scam on education system. But talking about that, if the health box will be open, that's like a Pandora box. Now that's it. Because with 10 lakh, if you pay 10 lakh, you will be fast. There are lots of, if you bring that precedent rule, after 2 months it will be off because he has the connection with all those, that Nitish Kumar will first, they will take up. Okay, it's very important.
Now I want to speak in panel discussion. I am a correct, 2023 passed, 20 years over. But pharmacology in UG and PG has gone 20 years back. That is the situation now.
क्योंकि एक्सपेरिमेंटल जो एक्सपोजर है वो बिल्कुल नहीं है इसको पूरा चार्ज मेरा भी करना है, बट क्या करूं, अभी यहाँ पे रख के जा सकता हूँ क्या?
हाँ हाँ, दे दीजिए ना, ये सब खोल के रख के, ये लोग का तो लैपटॉप है। और ऊपर ऊपर में ये भी है,
मेडिसिन छोड़ के गई क्या ये? नहीं,
ऊपर में आपका जो वो देख लेगा, कोई चोरी करेगा तो।
ओके,
इधर है, बहुत सारा है, कोई नहीं, इधर है उधर है। वो सेमिनार हम लोग का जो सेमिनार में था ही नहीं, जहाँ पे वो मर्डर हुआ।
ओके,
देवर पूरा ठीक है, क्या क्या सब बाहर का जो बाहर में भी जो था ना आपका, वो लोग को बैक डेट में जाके सब डिलीट कर दिया।
ओके,
पूरा टैम्पर्ड हो गया, जितना एविडेंस था। ये भी पता चल रहा है कि उसका दोस्त लोग जो फोटो खींचा था डेड बॉडी का, उसमें व्हाइट ग्रीन कलर का कपड़ा दिया हुआ था, लेकिन जब लास्ट में जाके जब मिला तो वो ग्रीन से ब्लू हो गया, मतलब चादर जो है उसको भी हटा दिया।
ओके,
ना बड़ा क्रिमिनल हाँ बोलेगा।
नहीं, ये तो बहुत ही ज्यादा हो गया, मींस लाइक
ये खोल दीजिए ना, वो जो
ये वाला,
नहीं वो पास वाला, ये पास वाला,
नहीं ये
अच्छा अच्छा।
एक्चुअली बात इस सर ने बहुत बढ़िया से ऑर्गेनाइज किया एंड ही हैज प्लान सो मेटिकुलसली।
हाँ,
सिग्मूटी सर ना बहुत मेटिकुलसली एंड ही
वेरी मच मेटिकुलस। मतलब मैं देखा था पिछले बार वो जो क्लिनिकल ट्रायल समिट बोल के सर किए थे, उसमें ही मेरे साथ फर्स्ट टाइम हम लोग का मुलाकात, मतलब
आपका हो रहा है,
ऑफलाइन हुआ, मतलब ऑनलाइन हुआ, लेकिन सर इतना इन्वॉल्व है, क्या बोले।
सो ट्रू, मींस लाइक मेरा भी सर के साथ काम करके ना, क्योंकि
ये जो बुक, मतलब कभी क्या होता है, सर इतना बार मैसेज करते हैं, मैं तो थोड़ा वो सोचता है कि यदि वो अगर नहीं करते हैं तो ये आपका फ्रूट भी नहीं मिलता।
एक तो इतना तो
कोई आएगा नहीं स्टडी करने।
நான் கிளம்பி வரக்கூடாது.
மச்சான் மச்சான் ஒரே ஒரு போட்டோடா. இதுதான் டைம். சீக்கிரம் சீக்கிரம் வாடா வாடா வாடா. இதுக்கு தான் வெயிட் பண்ணிட்டு இருந்தேன் நான்.
சரி நாங்களா இந்த பூ பூலாம் தெரியாதுங்களா? பூ அவிதானா சாப்பிட்டுக்கிட்டு இருக்காங்கண்ணா. ஆமா அதான் ரைட்டு தான். நீ எங்க இருக்கிற? சரி வரேன். சரிடா நான் சொல்ல சரி ரைடா சரிடா சரிடா லைட்டா நாளைக்கு போடுறேன். சரிடா 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 தக்காளி சரிங்க சரி சார் எனக்கு சரிடா.
அங்க பாத்துட்டு சிரிச்சா வர மாதிரி இருக்கும்டா. அதான் உடைக்கிற மாதிரி இருக்கு. பண்ணி எடுக்கவா?
வேணாம் வேணாம்.
நீங்க கருப்பாயிட்டேன். கருப்பாயிட்டேன். டெஸ்க் எங்க வீட்டு ஃபுல்லாவே எடுக்காது. இது வரைக்கும் பாதி எடுத்தா போதும்.
சில்லி ரைட்டா சிண்டோன் ரைட்டா
இந்த மாதிரி தான் கேட்டேன்.
கண்ணு கீழே கண்ண சிண்டோன் பண்ணுங்க சொல்றேன்.
கீழேப்பா.
சிண்டோன் ரைட்டா சிண்டோன் சரி ரைட்டா ரைட்டா சரி அவ்வளோ
வேற மாடல்
Good morning, everyone. Hello. Hello. Sound வருதுல்ல, அந்த AC sound. இப்போ வருதுல்ல, வரும்போது சுத்தமா இல்ல.
Mumbai is used to it, but still Chennai is more than Mumbai. Different. Yeah, it's different. The body sense is different, but something is different. I don't know. There's can be there. Everybody morning I came, there was no error. It didn't start.
There is no other point, no? एक मीटिंग है इसको और थोड़ा सा चार्ज कर देंगे। आप फार्माकोलॉजी से हैं? हाँ जी, हाँ सर। जिस लास्ट टाइम मिला था ना? हाँ हाँ सर, मिला था। अभी कौन सा ईयर में? फाइनल ईयर सर। फाइनल ईयर? हाँ जी। थीसिस इसमें क्या है? थीसिस नैनो पार्टिकल। नैनो पार्टिकल। किस टाइप का नैनो? हाँ, ट्रिपल नैनो पार्टिकल। ट्रिपल नैनो। ये लगा। हाँ सर। कहाँ से हो? घर कहाँ पे है? कांचीपुरम सर। कांचीपुरम। यहाँ पे सारी मिलता है। हाँ जी सर। It's nearby only, no? 40 kilometers. What are you learning? This lab they have started, JP lab, both good facilities. His name is Tamil Servan. So I came for an inspection. So he is opening up bigger facilities also. Either nearby over.
Can I have one photograph with you?
Yeah, please.
Next photograph. We can take it to the background. I will we are seated for we spoke on AI in pharmacology.
So we have 8.5 lakh. Registration for this kind of, we report them. But now is the road that so what's the certificate? Hospital do not have a knowledge test. Yesterday I was you probably in the US. European have you done
Indian they have everything. So night was popular band.
What's your name, sir?
You might leave the
so I have a university system. So we do the sanitary.
Yes, sir. Nice meeting you. I doubt you see the Fridays.
That's the place over.
What is about you?
That is so long. Thank you. Thank you. It's a direct line.
Oh,
we plan PSI with I have also a student. Medical So you were posting on Goa once a that's okay. Nice.
When I was in second meetings, we were a part of the planet. I was in medical science. Most of so now they're happy. When I was in the now have you changed now?
Oh, the problem is we can't give a food to give
Did I not know that the government is saying you come under serious and they will start making different body? They don't, they are not. Exactly. So that tell us they are looking for experience. I never knew that. They are making different bodies. So there was option, never used. I think it's like this one.
I just taking the
Answer.
अगर आपका है कि संख्या 91%, 91 चार्ज डालना है, चार्ज डालना ओके उसके बाद
सबसे बड़ा जहाँ पे रिनोवेशन कर दिया
Let's move on to panel discussion, and I would like to invite the moderator of the session, Dr. Srimati Sir, to the stage. And we have extreme panel of experts with us today to share their insights and perspectives. I would like to welcome Dr. Melvin George Sir, Professor, Department of Clinical Pharmacology, SMCH, Chennai.
Hello.
I would like to welcome Dr. Akash Darbe Sir, Associate Director, Novartis Life Science, Belgium. And I welcome Dr. Shahnaz Ma'am, Professor of Pharmacology, Savita Medical College and Hospital, and I welcome Dr. Sujitra Ma'am, Professor, Department of Pharmacology, ESI Medical College. And I would like to welcome Dr. Raghu Narayanan Sir, Founder, Samriddhi Allied Educators, Bangalore. And I invite Mr. Nagaraj Sir, Vice President, Spinos Life Science and Research, Coimbatore. And thank you everyone. Now everyone, we have everyone on the stage, and let's dive into the today's discussion. And over to you, please.
So good afternoon, everyone. Little bit delay is there, so sorry for the delay, but we'll try to go ahead with the panel discussion. And myself, all of you know already, and I don't want to spend too much of time in explaining. Now I would like to ask other my co-panelists to introduce themselves.
Good afternoon, everyone. I'm Melvin George. I'm currently working as head in Center for Clinical Pharmacology at SRM Medical College in Chennai. I basically did my MBBS MDDM, and after that, almost 12 years now, I've been working in Center Clinical Pharmacology, mainly in the clinical trials division. Yeah, that's about it.
Good afternoon, everyone. I am Dr. Suchitra. I am Professor and Head Pharmacology, ESI Medical College, Rajajinagar, Bangalore. And I am also academic registrar. And I am into a lot of IEC and other administrative and other so many of committees, curricular, extracurricular, and so on. And I'm very much passionate about medical education, and I'm very proud that I'm a medical teacher. So I like my students, I like teaching, and I want to be in this field. So that is me.
Good afternoon, everyone.
Myself, Dr. Rabu, I'm the co-founder and owner of Pharmacology and Academicians, Bangalore. Thank you.
Very good afternoon, everyone. And my last tenure was at Navitas Life Science. Presently, I'm Director and CEO at AJR Cure Private Limited. I did my MBBS and MD in Pharmacology from KMC Bangalore. I come with the experience of 10 plus years in clinical trials and pharmaceutical industry. Thank you.
Very good afternoon to all of you. I think you have seen me too much this past 2 days. I'm Dr. Chennai, Professor of Pharmacology, Savita Medical College and Hospital. I have 18 plus years of teaching experience, of which around 6 were international. My passion, besides pharmacology, of course, is medical education. I am a fellow of SMCH Medical College, female fellow, and I have publications. I straddle both boards, pharmacology as well as medical education. And I'm actually very proud to say my most number of cited papers, citation has been my first publication in medical education. So all that points out where my heart is actually enters in medical education, and I'm proud to be a teacher. Thank you.
Happy afternoon. My name is Nagraj. I'm from Spinos Life Sciences, Coimbatore. I'm basically a master's in pharmacology. I have 12 plus years of experience in regulatory, where I do submit all the submissions for US FDA and European regions, where I worked for Pfizer for around 6 years and Accenture for 4 years. And it's good to be here, meeting all the doctors and your passion to grow the problem. Thank you.
Thank you, everyone. By listening to all of you, I learned that we have a very good panel, equally balanced between academia and industry. As all of you know that today's discussion is how to choose between industry academia. So if I little bit have to tell about myself, I have 22 years of experience, 22 or 23 years of experience. I spent 13 years, first 13 years of my life in the industry, and remaining another 10 years in the academy. So I think I am first in between both, and we have good industry professionals, good academicians, and in between I am also there. So I think we have a very good mix. Looking forward for very interesting discussion. Keeping this in mind, if any of you have any questions in between, please keep noting down. And most probably, while during the discussion, we may answer some of the questions also. So keeping that in mind, and if you think that you have a question still at the end, please pass on. We will definitely take those questions. Few of them. So as all of you know that career, choice of your career is a very important decision you're going to make in your life, because you have to spend like if you are alive in a day, okay, out of that you spend 8 to 9 hours in the night you sleep, and most probably you have to give another 4 5 hours for yourself, maybe for doing exercise 2 3 hours, and taking care of family, giving time to others, and remaining most important part of your life, that is 9 hours, you are going to spend in your office. Most probably remaining 6 hours, what I said, among that maybe 1 or 2 hours or 3 hours will go in the traffic. So keeping all this, the most happiest place what you find is your working place. So do you agree, all of you? Right? So choosing the right working place or working environment or the career is the most important aspect. You always need to do it very carefully. Okay. Keeping this in mind, now our panelists will share the very important views of how they are successful. I can see that all of them are doing very well. The young entrepreneurs are there, they are founders, and some of them are again CEOs are here, and very well settled academicians are here. And I being socialist also, like I'm a philanthropist, I'm the industry, I work in industry, academic. As a mix of all those things, I have I'm able to satisfy myself. So keeping all this, now I would like to ask Dr. Shanaz, So what are the responsibilities and long-term prospects in India so that our youngsters can choose academia? So you can be, flow towards academia and encourage more people to come to academia.
I think foremost, the core aspect of academia is teaching. So you need to have a little bit, not little bit, quite a passion for teaching. And teaching does not just involve, the knowledge, it also involves the teaching skills. And our government, NMC has brought about those teaching skills in the MD curriculum. So quite a lot of it will be handled while you are doing your post-graduation. And the rest you learn, you develop a flair for how you want to teach throughout your journey as a teacher. One advice is please attend classes which are taken by your senior professors, senior teachers. Because that's how I learned teaching. It wasn't, we didn't have MEO when we graduated. I think we straight away went into pedagogy as a exam, and all what we used to learn was just from our seniors. But attending sessions with professors, how they teach, the way they handle unruly students, the way they appreciate good students, that is what you will learn from your gurus. So besides teaching, administrative skills are also there, and more so now we have a lot of research component. So that's the triad that we are looking at in academia: teaching, administration, and research.
What are the, if someone want to choose, they will definitely see that what is the long-term thing, what I can achieve. Maybe you can shed some light.
Long term, of course, you will develop great relationships with your students. I don't think that is there in the industry. We still have students who have become parents, who are going to become grandparents, and they will come and, oh, you were my guru. I learned my session, I learned teaching from so and so. So that is the satisfaction that we have as a medical teacher. And that's the long-term prospect personally. And on the professional side, yes, you can go right up the ladder. You can become associate professor, you can become HOD, and even many of our pharmacologists have become deans. So that is one side. The other side is, of course, the administration. You can get into, curriculum development. You can be a part of the people who are framing the rules. So that's highest that you can go up to.
Yes. Most importantly, if you are in academia, you should also try to become a MU member and some of the ethics committee members. These will really give you a lot of help in gaining the edge in teaching methodologies and all. And additionally, so recently I saw that some of them have become like P.P. Sharma, I saw in one of our group. He is the vice chancellor of some university. And like this, and I think one more professor in Balaji University also. He is also a pharmacologist. So like this, lot of people have become vice chancellors, principals, deans, and also you can achieve a lot. You can also become director of some of the important organizations like this. So now I would like to ask Dr. Akash. So what are the same question? Only thing is that what are the green aspects of industry?
So I should say only green aspects of industry, not the red aspects. Okay, fine. Thank you so much. No, thank you so much. So the greener aspects of industry, as an MD pharmacologist, you have multiple options. The only branch in the field of MBBS and MD pharmacology where you can flourish, post MD pharmacology, the horizon is really wide. You can explore into different options, right from medical advisor to medical writer to the medical monitor. You can flourish even up to the level of CEO. The CEO of nowadays is Mas Narasimhan, who is an MD person. So you have plenty of options. You can start your career from the advisor role till you become an CEO. An additional thing, what you need to develop during the course of when you start your journey in the corporate world to learn. Like what Madam has mentioned that in teaching you should learn, you should attend the classes. The same way when you join a corporate world, you need to acquire new skills. You should be in a competitive world. So unless and until even in corporate world, you will definitely develop a relationship, and definitely I'm sure in the corporate world there are no enemies till date. All are my good friends. So till we develop a good relationship, and the same continues in the corporate world as well. It's like a family, and probably down the lane you have plenty of options even in pharmacovigilance. Like what my friend Dr. Ravindra mentioned about the AI in pharmacovigilance. AI in not only in pharmacovigilance, even in healthcare industry, it's been expanding like anything. So you can be a budding entrepreneur. You can start working right from your MBBS days. By the time you complete your MBBS, your algorithm should be ready. You have multiple options to it. That's it. Thank you.
Yeah, so as he rightly mentioned, people can, grow. And as you know, you get the positions, you will also get responsibility, right? So you can't run away from the responsibility. You need to be responsible for what you do, what you accept. Don't take others saying that, I need 5 lakhs, 10 lakhs. So people don't give you 5 lakhs, 10 lakhs, just like that. They will also expect that kind of, cutting edge knowledge and also technology. Now I will ask Dr. Suchitra, please tell me what are the required skills to excel in academia and industry, maybe, academia versus industry.
Thank you, Dr. Shimurthy. There are many online and offline postgraduate students. So anyone thought, got a thought when you are joining for MD Pharmacology, why you are joining MD Pharmacology? So many, as Dr. Shimurthy entered into industry, so even we have, it is even recently one of my SR from AIMS, he joined industry while doing his SRship in our college. So I asked him why you are you have completed 3 years of your SRship and you could have got job as AP in AIMS only. Then he told me that this is the time I should experiment. I should find out whether industry suits me or not. So then I thought, okay, you go and experiment. If you find it okay, you continue. Otherwise, you come back. So everyone after joining MD Pharmacology, we have an idea that whether to go to academics or industry. But are we getting trained enough during post-graduation to be competent enough in industry or in academics? So that is the question mark. So as a UG, pharmacology is totally limited to the classrooms. So even during UG, it should be beyond classrooms. So students go to clinics. They are coming across the drugs. But we are not translating those clinical aspects into the classrooms. So that I am trying to inculcate in my students, that is collaborating the clinical and pharmacology while doing UG itself. So during PG, it becomes very important for you to be competent enough. Means not only you are exposed to research, regulatory affairs, pharmacovigilance, materiovigilance, HPLC, so then all these softwares, drug design softwares, all these skills are required for you to be competent enough. But what is most important is basic pharmacology knowledge to the receptor level. That is, you are not getting exposed. See, I am a regular examiner for MGR University, and I feel I've seen students and even some places the recently passed out MD graduates also struggling with even dose response curves and the basic pharmacological aspects. So they're not at all exposed to animal experiments. It has become very easy. Like pharmacology means, okay, you go just sit in the department, take 2 or 3 classes, take practicals, and do some thesis on some topic, get out with an MD degree. If that is the thing, it is of no use. You will not stand anywhere. Okay, you can become, of course, yeah, there will be options, but you need to develop yourself. This PG, see, time is very precious. Time is very precious, and you have to leverage that time in developing yourself, make a brand of yourself in the during the PG time. So in addition to these skills, that is knowledge and all these required HPLC, soft skills, now AI and all that. In addition to all that, you should develop leadership qualities, communication skills, what you call soft skills. Then you should be able to work in a team. Suppose you want to go to industry. So working in a team is very important. People management is very important. Daily you have to observe how your seniors are conducting in the department, how they are behaving or how things they are solving with the people and with the administrative things. Everything you need to observe and you need to learn to be a team leader with leadership skills, people management, communication skills. So all this you need to develop during your post-graduation itself. You have no time. You will be lagging behind if you start developing after your post-graduation. So these are the few things.
Thank you so much. Just to summarize what he said, like research and analytical skills are very important. For that, you need to do some kind of research and be able to summarize your aspects. Next is teaching and communication skills. You should be able to clearly tell. You say that you want yes, but you are saying I don't want. That is not the way. If you say yes, it should be yes. If you say if you no, no, no. Okay, you know how to tell that. Okay, communication skill is very important. And then grant writing and fundraising. If you are an academician, you need to nowadays it is very important, very competitive. People ask you how much money did you bring to your organization as a fundraised, grant writing. So try to learn those things. Collaboration and network, like our societies are there, which helps you to bring people together. Like that, you should become a member. So don't wait, don't think that 5,000 I'm spending, what I'm going to do. You might have seen that what you are going to gain over a period of time. Nothing happens just like that. It takes time. You have to make yourself contribute to the organization and grow. So like that, collaboration and networking is going to play a very important role. And for the industry, what I can say that practical application of research is very important. Project management skills are very important. You need to ensure that you learn that what are the timelines are properly kept. You can't say, sir, I am still going to a marriage and I have another thing, so I will come back after that. People they say that okay, you have been relieved from your job. So that's not going to happen. Okay. So you should be on the top of your work. Project work is very important. Regulatory knowledge is very important. What is that? I think today Dr. Lini, she told so many things about regulatory things. So please, every day you should have a habit of visiting a particular regulatory center, especially DCGI. You may be seeing that a lot of PDFs are forwarded in the WhatsApp groups about the regulatory said this, MCI said this, NMC said this. Have you ever opened those guidelines and looked into it? No, I get pissed off when people, we have forwarded so many times what are the regulations required for the associate, assistant, and professor requirements. At the end of the day, someone will send me a message saying, sir, what is the regulation, current and latest regulation? You can go to NMC regulation, you can just download it and look into it, or you look into what we have already forwarded. Okay, so if you still not getting clear, you can very well ask the question, no problem. Sir, I found that this is the, what do you mean by that? If you ask me, then I will be very happy. Instead of that, what is the relation? I will just, what I will do, I will just make a screenshot of it and send it. Please, like you be sensible so that it increases your credibility among your network. If you ask a very dumb question, then you will always get the dumb. Okay, please be very careful what you ask, how you ask, and how you communicate with the people. Okay, so and also you should have business acumen. We have good number of business people here. Okay, so like this, I will, with the interest of time, I will get into the next person. Okay, Dr. Raghu. So I would like to ask you about what are the contributory factors, usually like job satisfaction, industry and academia. Okay.
Well,
coming to the job satisfaction. So basically in the academy, it is mainly driven by the passion of teaching and mentoring the students. Where even in the research field also. When you are mentoring the students, when your students will be achieving some goals and all, that time you feel very much satisfied mentoring the very good students and all. And coming to the industry, where mainly you work on the public health in the development of new medicines and all. And in the industry, yes, there will be multiple opportunities like designations also, and even coming to the salary also very good in the industries. So these are the both things in the academia and industries. Mostly both of them, it will be driven by the passion. Thank you.
So, job satisfaction definitely, like, when you are appreciated for a particular work, you will get motivated. So for getting that one word of you are a good person, you are really done work well. If you want to, you might have seen, so many people are running around and people say that you have done well. This conference was worth attending. Then you will get that appreciation only when you take care, when you work hard, when you put your 100%. Yes, there will be, faults will be there here and there, but still people will say, you have done your sincere work. Okay, so same thing, it applies to every job, what you do. So be sincere in your efforts and you will definitely, it does not, appreciation does not come one day. It will serve, because sir is here, Mehdi sir. We have seen him, contributing to the country so long, so much. I heard Dr. Satyanarayan was there with me yesterday. He mentioned that he was the examiner with sir, and sir was sitting and started attending a meeting online. Now also he has started working. You can see. So he has another call. He has a meeting, and he will be there. When he accepts it, he sincerely comes and attends. That is the thing, we can learn from sir, that, like you would say in the beginning saying that I'm not coming, I'm not going to do it. But if you accept it, you do it. Okay. That shows the credibility of yours. And people will come back to you. Okay. People, they see business, like people will come back to you, means repeat business. Repeat business may be a work for you, or presentation for you, or it can be a business. It can translate into major grant also. Okay, don't ignore the small thing when it comes to you. When it comes, it may come as a small thing, and when the people get the confidence in you, they will keep on coming back to you. They are keep on coming back to you, means you are growing. Okay, if they ignore you next time, you think that you have done some mistake last time. Okay, please keep in that mind. Next. Network is very short. See what I'm saying is, industry is very small. We are all small family. MD Pharmacology is not a big family. Okay, we have hardly 1,000, 2,000, 5,000. There may be a lot of people there, but who are there in the family are very less only. They will get to know each other. Who is Poolen? Okay, Poolen, everyone knows. Okay, he is very good. So like that, once the word comes like that, so it keeps on ringing in the ears. So please keep that in mind. Next, I would like to ask, see, all of you might have seen that, like I've been juggling between industry, academia, and all. Some people might have, they are very much aspiring. They went into industry, they are not comfortable there. Or someone went into academy, they are not comfortable there. How do they switch in between?
Okay, so let's look at the perspective, since most of you here in the audience are doing your pharmacology, I believe, postgraduate students or young pharmacologists. So if you are having this vacillation that should I be in the academics or should I be in the industry, I think you first of all need to know this fear. Fear of what? Fear of finding yourself, especially fear of experimenting. Okay, as a young pharmacologist, if you have the slightest interest towards industry, go and explore that world. Taste what it is, see whether it suits you, because there is no formula to say that industry is the right choice for X person, Y person. It is highly subjective based on the experiences that you have
during your tenure there in the industry. Some of you might come out shining so much in pharmacovigilance or clinical development or medical affairs. You need to choose those individual careers in the industry, but then whether to be in the industry or not, that is a question that you can best answer if you explore that world. But if you are a person who really enjoys being in the academic world, you enjoy teaching, you enjoy doing research. For example, although I'm in academics, practically what I do is almost 70 to 80% of my time is spent in research, be it industrial clinical trials or academic kind of clinical trials. So that's something I enjoy. But if you ask me, don't you like teaching? Of course, I enjoy teaching too. And if you ask me, do I like industry? I'm not saying no, that's a bad world, I will never go there. Maybe tomorrow I might change. But at this moment, I'm comfortable. It's almost like a drug sitting on a receptor. It has got locked and it is enjoying its business at the moment. So we need to see where we are based on the experiences that we have. So theoretically, we can talk many things, but you need to have that practical experience by going and exploring the world if you have a little interest towards industry.
Just to point out, industry is the academia is, it's like you are doing the early part of the development of a baby. Okay. Industry is like, getting married and then going and serving the wife. So it means that you are in the market. Okay. So like that industry. Yes, it's the same thing. Why I asked that? Okay. Yes. So I'm in the industry, like job. Okay. So now thank you, madam, for correcting me. Okay. So yes. Okay. No, what I meant is that like industry is you are doing the you are selling the work to the whole world. And means in the academy means you are educating, developing the person, and like you are allowing the it's like pre-clinical work. That is like a clinical work, right? So like that's meaning what I want. So now I would like to ask Nagaraj sir. Sir, what is the different kind of research that can be done in industry and academia, and how our people need to plan well for academic research? What do they do, or what they do in industry research? How it differentiate, how it is different, and what are the methods they can collaborate to ensure that industry academy is successful?
The main difference between the industry and academy is academy just works on enhancement of knowledge. It's already done long back. That happened, things will be done, learned, gain knowledge in academics. But when it comes to industry, they apply the knowledge. They try to get innovate and predict the things, what is the thing that can happen after doing this. So they explore the opportunities of innovation. So that's the main difference between academics and industry. What I mean by that is, I have a friend who is a pediatrician with a 75-bed hospital in Hyderabad. He was just explaining to me when I met last time. He said that the technology and knowledge of doctors, what they have in Hyderabad, is always 5 years backward to what they use in Chennai. So if it is the case within only 2 metropolitan cities within India, we can expect that what is the academy scale of industry scale. And when I met my industry friends in pharma, in the last pharma conference pending FTD at Hyderabad, they were saying that India is always 2 decades before the technology we are using. So if it is the case in the industry itself, we can imagine as academics, we are using a back kind of knowledge, but things have been changing now. Things have been changing. That's good to see. And yesterday I have read that Bill Gates in his LinkedIn page has shared about there has been a collaboration going between Eli Lilly and Indiana University School of Medicine for development of Alzheimer's disease, cutting-edge technology. So what does that mean is the innovative countries, which is of course US, runs first, and in these countries, the top MNCs and the colleges, universities working together, and I don't see that happen even till today in India. So there is a big scope for this to get into that. And even if you see all the presentations from all the legends from academy and industry from yesterday in this conference, I can see that all the academic legends has presented about COVID-19. Those things have happened, and the so current industry legends, they have presented about what are they going through, what is happening in the industry, AI kind of things. So it's about happen is the industry academy happening, and what will happen is about the industry. Yeah.
Thank you so much, sir. Yes, definitely. But at the same time, industry, if you ask me, see what I did in industry, nothing is written in my CV. You see, most of the time I can say I did this. These are the these are the positions I had. But if you see my academic CV, you can see that I have 30 publications after after joining back to academics. 6 or 7 books into my into my CV, and then a patent has been filed, and and we are working on very interesting projects. It means that academics is not bad. Academics can it gives you freedom to do what you think. Okay, if you think you want to achieve that, you will be able. If you think like because academicians, especially like yesterday we saw the founder of this organization, and they say that MPS would like to develop a nodal research center. He immediately said when he was in his speech, he said that we would like to collaborate with you. That's the kind of openness you can see here, and MOUs will happen faster. And if you really want to do, you can really do, and you can apply for ICMR or DST grants. I have seen my colleagues; they are doing a lot of grants getting, and definitely, as you said, like we are. It may be that we are using older technology, but still the knowledge will be definitely updated, and you can still collaborate with us, and we will be able to deliver better.
Yeah, I just want to put. I'm just putting that. I'm not degrading academics. I'm just putting that we have a long way opportunities in the sense says to go. As it was mentioned, only we are 2% in terms of innovation. So where the terms of innovation, I was just trying to fill this gap between academics and industry. So why this is happening? Because this industry, LA Lilly and Indian University, it will collaborate, then only innovation will come from the ground level. That's what I mean. And as Dr. Mukundraj Kenny was saying that unmet needs, the opportunities. So this is the unmet need, the gap between the academy and industry is huge. That was never concentrated, focused too much because there is no much money for any one of them. So there is one definitely unmet need that can be taken as an opportunity to bridge the gap between academy and industry.
So now we would like to take some questions from the audience, if any questions are there, so that I think then we can conclude. In the interest of time, we can get into the next validatory function. If any questions are there, please raise your hand.
So what I would like to just say, because there was a discussion on academics and industry, I'm in the industry for the last 10 years. What I would like to tell PG students is when you are in academics, give a large part of your time to academics. Make your concepts very strong. When you come to industry, you need those concepts. Whatever you need for industry, you can be trained when you come to industry. But your core concepts, you cannot learn when you come to industry. Right? I have seen when some of the juniors we are interacting with the doctors, they are not able to answer questions related to half-life. I think MD pharmacologist is placed the best to answer any question related to half-life of a drug. And the knowledge of the clinician is more restricted to what is taught in MBBS curriculum. So I think these are very core concepts, and general pharmacology helps you to answer those. If you remember in my presentation also, I mentioned that we need to prepare questions that we need to answer which come from clinicians. I think your knowledge helps you there. So the clear message I want to give is don't ignore your core concepts. There is in industry, there will be nobody who will teach you those core concepts. Learn those concepts very strongly, whether it is concept of general pharmacology, systemic pharmacology, or basics of clinical trials. Learn those concepts there, and advanced things are always there when you come to industry.
Any others, please, immediately, if you have fun, please.
Yeah, I just would like to continue what he suggested. So what I feel is what we are looking at industry and academy. It's like a mirror image what we are looking for, but ideally it should not. It should be the other way around. See, industries, they run as a business. We have to accept that fact. They are there because they have something for the world to give, and they are more focused on providing it to the world. In US, in EU, wherever we go, it's the other way approach. They approach academia for the excellence. So what I feel is in India, particularly, what we should do is we should make academics a little stricter, more elaborate. Maybe the students have to get the idea that when I have these 3 years to master what is already known, and I have to work on something which is not known yet. So once we do that, then we'll see the flow, how it happens, like he was suggesting, LIB. Why they go back to the academics? Because they find the experts there. They have spent 5 years, 10 years researching one topic. You'll not find many, let us say, statistics, for example. You'll find many people who are academicians, who are statistic experts. They will tell us all the scales that we use today. What is the WHO scale? What is the language? What is the diagnostic scale? Who developed them? Academics developed them, not the industry. Industry use them, to assimilate the knowledge and take it forward. But academics should actually, gear up now. This is the right time to take it forward. In maybe next few years, people will like.
More time would like.
One more. After her, if anyone is, please immediately raise your hand so that after.
I would just like to add one point based on my experience. So I was working at Apollo hospitals for some time, but I shifted back to academics. So now I can see that what we did at corporate setup, the same thing is being pursued and implemented even in academics. Like for example, the NABH related accreditation. Now almost all the hospitals, private hospitals are also going for this kind of accreditation. So as such, we are not missing out on anything which the industry, people are doing. So that is my take on.
Concluding. Yes, I agree with you that, now I'm in academics, but I never felt that, no, I'm in academics. I'm still continuing the same enthusiasm, and in addition, I have taken more responsibilities towards the society, towards the academics, towards the publications, towards so many other things, developmental aspects. So like this, I'm sure all of you will agree with me. I hope all of you agree with me. If you have any.
Last one point, you
Yes, sir. Yes, sir, please, sir.
Make difference in salary and remunerations. Academy and such industry.
Academics is also
Previously, if you are appointed in industry, minting money like anything, there was a concept previously. Now, what they are thinking now, academy is getting down now. No, not what salary they are getting previously is getting down. I don't know that, again, we have to go only to the industry line, I think.
I will just update that. I want to get a clear picture regarding this.
Yes, so I would like to, update you all that, like if you ask me, in the early part of your career, money matters. Okay, because you are still in you're not stable with the roti, kapda, makan. Okay, so everything comes to that only. Okay, so I would say that, if you are the youngster, you should work for, at least the first 15 years of your age. Means after you are completing your MD, you first 10 to 15 years, you work very hard, go back to your industry or wherever, and if you are really passionate about it, Okay, and if your skills are updated and you are able to, convince the investors, I would say it's always in industry, it is always investors. Because they are investing 1 lakh, 2 lakh, 3 lakh, or 5 lakh, or 10 lakh rupees on you per month. It means that it is an investment on you and they expect the returns. Okay, in academics, it is, like now the salaries are not less in academics. To be honest with you, so what the industry beginners get, the same amount is given here also in the academics. And it is much more, like if you are really focused in academics, and you can really, earn more, not only money, a lot of respect, Respect don't have any, terminology like how much. Okay, so there is no, we cannot estimate what is the value of the respect. So, respect of guru is there, and respect of everything, sir. Like, to become other, like, if you join early academics, you can become dean early, you can become vice chancellor early. So you can be a very good educator, you can be an administrator, you can be a guide to the NMC, guide to regulators, and there is no end, sir. Actually, academics, you can go to any, you can collaborate with the international, national universities. So all those things you cannot do in industry. Okay, sir. You can't do industry means, you are like you have the, horse, closed eyes. They will tell you where to go. So you just have to go that direction. But on the way, you will learn, you will earn, everything you will get. But it is like, like you have earned for that day or that month, that's all over. The moment you leave, you don't carry anything back to your home. Only salary, that is bank balance, what you earn, you have to save and you have to invest somewhere else. And if you want to plan very well, especially if you want to become a investors like Dr. Raghu or Dr. Akash, okay? So if you want to start your own entrepreneurship, sometimes definitely these skills are going to be matter. Otherwise, I don't think, anyway, it's not going to be of any help. But connections, see, what you take home is the learning, the skills what you have learned during that's the, and also you had so much of adrenal rush during those academic industry practices. That will definitely, when you come back, you can comfortably work in academics. So that I am the example for it. Okay. So anyway, thank you so much, respected analysts. I hope it was very nice, enlightening panel discussion. I think if any other words, if any of my panel members want to give, please.
Yeah, just a last word. The corporate world is like 2020 and academia is like 50-50. Choose wisely. I would also want to say that if you are thinking academics is going to have a very cool life, it is not so. Don't dream that being an academician you can have a very cool life like a test match. Okay, you might think it's a test match, let me join, and then you will be realizing that it's not even 2020. It's even worse than that.
Exactly. With CBME revised guidelines and NMC guidelines, it's really tough to be in academics, but you are going to enjoy if you are passionate. Pharmacology, as you explore, there are more opportunities. It is like a ocean of opportunities. They are there in pharmacology. You will never be frustrated about it. So you have to put your effort to be happy.
So academic life is not cool at all. Because I used to go to Sars Lab at 8 a.m. in the morning, and Sar will leave at 12 at night. We will leave at 2 a.m. at night. That was the life for me for around 8 years. Ma'am, I used to take hard also to the lab. So she now knows how to do all kind of molecular works and all. So that's how I somehow managed. But it is very competitive and actually very, very competitive. It is not like that. That's very good.
Guru wants to add it. You said something. No, actually, one of the students should not happen. Yeah, no, one of the student from Chennai also he joined. Pradeep.
So then he told me once that he had a concept that 4:30, 5 o'clock is closed. Okay. Then that concept, he said that it's gone, like I work till 12 o'clock, leave it at 1 o'clock, and we can work. Nobody knows that how many agency I work. Like if ICMR call, just now DCJ had called me, then I have to open up the computer. Okay, then DPT do not know what I am doing like that. So you can divide the time, but only thing you can perform well if you keep it cool. This is the point. I'll do it in 15 minutes or 30 minutes. You can do it. But if you take a stress, okay, like I give a concept that Saturday everybody leave by 1 o'clock. It's a half day. But if you think it's half day, by 3 o'clock you'll really get tired. I'm standing here after 6 days, I did not sleep, but don't do it. It's not a good habit. Okay. But I used to continuously work till 3 days because I used to work in AIMS, New Delhi, in the emergency. And it's not a mental work, it's a physical work also. If attendance is not there, you're putting the, everything, holding the patient. So that actually give a capacity. That actually give a capacity. All the books I have written, it's in early in the morning, in a cool light. That time you can just think that. So normally you have to address what are the difficulties, student face. So you want to address them like that. You can work and you can collaborate. That is also one thing that you can take an input. Somebody is working for last 20 years, you can have a discussion and you can highlight the point. You can carry over that. Okay, so that can be done. I think it's a good discussion. I really enjoyed. Thank you very much. Yeah. Since he has with us, he's waiting very long.
Before we move on to the panel discussion members, we want to facilitate them. I'd like to call upon our TNMC observer, Dr. Mohan Raj. Please give a big round of applause to Dr. Mohan Raj. He is a very senior anesthetic and he is the backbone of our function. We would request HOD sir, kindly honor him. No, sir, no, sir, no, sir. Okay. Thank you very much, sir. Can we have a photograph for TNMC purpose? We request all of us to just please come on the stage. He needs to submit this officially, so all that who can fit in, please come in. All our organizing members, sir, please, sir. Thank you, sir.
I'd like to call upon Dr. J. Tirunavakarthi sir to hand over the mementos to the panel discussion. First, Dr. Shivam, please. Dr. Shenaz, sir. Dr. Akash. Dr. Melvin. Dr. Rahul. Dr. Rahul.
We'll take a group photo here. So please bear you all on the commenters. Here's the training for this, yeah? All right,
Thanks, we look it up.
Okay, that's fine.
Next, we move on to the validity function.
How is the battery function?
Now it's time to give memento to all organizing committee members. I request Dr. Shomoti sir to come and give the memento. I call upon Dr. Radhinav Garisa sir to come and give the.
So first of all, before getting into valedictory function, okay, I would like to first appreciate the organizing committee members' efforts in making this MPSCON 2024 a successful. All of you, please get up and give a standing ovation. Please, all of you come here. Please, all of you stand here. We will take those mementos done, but I would like to appreciate when everyone is standing and giving your appreciation. I want all of you to join here. And most importantly, I would like to appreciate Shaila's madam. She herself volunteered. I would like to again say on the record, she herself volunteered and came forward to take this conference. Okay, so this is the first conference, annual conference, what we have organized, and your efforts will be there in our mind forever, madam. And this is the first one, and it really went very well. It really very well. All of you agree? So all of you agree, right? So with this, I would like to also appreciate Thiru sir. I came here when madam called me for some meeting, and I came here, and I have all of you can sit down, please. I came here, and when I met sir, really, he welcomed us, and he accepted our request. Both of us joined together and requested sir. Sir accepted our request, and today all of you have seen how it went. And I would like to thank personally all the members who are standing here by my heartfelt thanks on behalf of MPS. Okay, all of you are MPS members, and on behalf of all of you, I please accept my sincere thanks to all of you. One and all of you, please thank you so much. So I would like to call one by one. So we'll just distribute. Take the moment of Abhinaya, please come here. Arun. And Kanchana. And Yashwant, next one. Divya. Maheshwari. Kirtana. Okay. So next moment of all.
I just like to thank the whole team. Actually, it's not a single person's effort. Right from our leader of the team, Thiru sir, anything that we say, he immediately says, "Madam, you go ahead. I'm standing with you." So that is the team spirit he has imbibed in us. Definitely a very amiable leader among all of us. Then I'll start one by one. In absentia, Dr. Deena, she was responsible for the scientific committee. Then we have the two young compares, Dr. Abhinaya and Dr. Arun. Big round of applause to both of them. I think the toughest job is we were changing the whole schedule within seconds. So Dr. Abhinaya and Dr. Arun, Dr. Divya, our postgraduate, joined in today. Then the man behind the scene, we started off with a little bit of glitch, but Yashwant and Dr. Arun both sorted it off. Big round of applause to Yashwant, Kanchana, Divya and Yashwant, they were all there in the presentation. Dr. Sultan took over all the technical, the printing, the banners, everything, and also took care of the presentation. And Dr. Preeta, she's a professor, but nobody believes that. Everybody thought she's a young AP. She looks so young. So big round of applause to Dr. Preeta. She was handling the registration part, food and other whatever that we have imbibed today that Dr. Sudhakaran took care. And Dr. Kalai was also involved in that in the food committee. Besides this, our backbone is our office staff. Ms. Maheshwari, a big round of applause to her. She is the secretary of a department. Mr. Karnan and Ms. Jayanti, we cannot do without them. I think we'll be totally lost without all three of them. So thank you so much to all of us. I hope I've not missed out anybody. I have included everybody. Thank you so much.
Thank you so much. On behalf of MPS, we are inducted with a lot of, all the goodies what you have given. And I'm sure, our collaboration will continue in more, different ways. And we will definitely, we would like to have more programs with you through MPS. So please do consider and let us know whenever you need any support. At the same time, MPS is always, collaborating with all the organizations wherever possible. And we are open, we have the open arms at any time. Please try to call us at any time. We will be happy to collaborate. Thank you so much. All.
So we come to the last part of our session. I think most of you are waiting eagerly for that. Before we announce the prize winners, you ready?
Yes, ma'am.
So all of you who are not members, you can see there is a QR code there. Okay, so please, you can scan and then you can become immediately members. You can pay 5,000 rupees. Students also can become members. But you have to pay 5,000. You will get a student ID but that will be converted as the permanent ID once you complete your MD. Okay, after you just have to resubmit the same form with all the documents with the same receipt what you have, then you will get the permanent ID. And we are giving the membership ID and also the membership medal to the full lifetime members, and it is a one-time payment. Okay, so I request all the youngsters who are here and every senior who is not yet become members, please, you can pay and join. And you may be wondering that why should I become member? I think in the opening remarks in my yesterday's talk, I have given you some of the insights what we have done, and maybe like you can play the achievements of MPS video. That will be nice if we can have 2-3 minutes. This will be 3.5 minutes video. So in between, I request all of you to see that, and I will upload anyway into the MPS YouTube also. All of you please subscribe. And in addition, I request all of you to join the society, and most importantly, in future, what we want to do. Just 1 minute. So what I want to say that we would like to establish nodal centers. Okay, nodal centers for research, doing research. We would like to, like Dr. Raghu is here, he has agreed to take us to the government for bureaucrats and politicians. So we will go there, we put a request for getting the land for research, means developing the MPS Bhavan and MPS nodal center for research. And we would like to have a building there, and we would like to develop the, all the LCMS, all the top instruments, whatever required for supporting the undergraduate and postgraduate research requirements. Similarly, we would like to develop another, like any mutual collaborations we can do with specific skills and specific techniques are there. We would like to do that so that we can channelize the students to go there and have some internship or channelize their research there. So like that, we would like to collaborate, and we would like to develop central ethics committee. We would like to develop ESND. We would like to do journal. Okay, next, Dr. Melvin is here, so he is the in charge of development of journal, and Dr. Poolen is also he is the assistant editor currently in IJT. Sir is the editor. Sir, I request you to help us to establish the journal. That is the Journal of Medical Pharmacology Society, or we can call it a little bit differently, but we request your support in establishing this journal. So in this way, we would like to move ahead, and anyway, we have the crucial pharmacology trends. Book is going to. So we have. I appreciate all of you. We have received. We wanted only 50 chapters, but we have received 56 chapters. Okay, all of them are already submitted. We just have to edit it, and I believe that we will have it 2 volumes. We will divide it for 2 volumes, and we'll make it available, because 1 volume can only take 500 pages, but I think it will go beyond that. So we'll have 2 volumes, volume 1 and volume 2. And in this way, we are progressing. I think all of you have already got our book. That is the clinical trial management book is already there in your hand. So like this, we are giving opportunity through this conference. I would like to say that we have given more than 200 opportunities. Okay, 200 people have got one or the other opportunity, and every member will be given one or the other opportunity. So take it from me, it is my promise that we will ensure that everyone get involved in one or the other. It's not that you are just becoming member and you are ignored. No, nothing like that. So anyone who has asked us, we have given. And we will please have some patience. It may be not this program or next program. You will. Okay, thank you so much. Looking forward for your. Please watch the achievements of MPS society.
So the moment that all of us are waiting for. Let's start off with the UG posters. Before we read out the prize winners, we just want to inform all of you that all the judges had been informed that there should not be any conflict of interest. So if you had a student who was presenting in the same session, you were not allowed to be a judge and for that particular session. And in fact, we asked all the judges whether they had any of their faculty or students presenting, and based on that, we selected the judges. Another point, no judges were there from Savita Medical College or from Dr. Shivamurthy's institution. So, UG posters, there was a tie between two people for the second prize. One is Mr. Bhagat R. Dr. Chandrama Dayanand Sagar Institute of Medical Education and Research. The title of the study was Sunited Malay-Induced Hepatic Toxicity, a Rare Case Report. A big round of applause to the student. I request Dr. Firoz sir to please give the prize. The students are not there, so the
proud that actually I was not a part in what I don't know. I did not even go inside also, and my students have got.
And the second prize also actually goes to his own institution. Again, I repeat the disclaimer that he had no knowledge. The judges were not unduly forced or something to come for the next conference or given another prize for the next conference. And both the
my students.
Both the second prizes. The second prize is Tanya Vijay Jadhav. The title is Does Vildagliptin Cause Chorioepitoid Movements While Treating Type 2 Diabetes? So big round of applause to both the second prize winners. It was a tie. Now coming on to.
As she said, I did not know anything what is going on. All of you have seen here and always here. But I'm very happy. Actually, like both of them, their papers are ready for publication. So I just gave them the knowledge, and they themselves have performed well. And in that way, I would like to congratulate my students for doing their good job. And I will hand over this that I have just received on behalf of them. I will be giving this along with the I will take this to Jean and I will hand over information. Thank you.
The first prize for the undergraduate poster is Mr. Ashwin K. from Sri Ramachandra Faculty of Pharmacy, Sri Ramachandra Institute of Higher Education and Research. Do we have Mr. Ashwin? Big round of applause. The title was Unlocking the Therapeutic Potential of Noloxone in Glioblastoma glioblastoma multiforme through network pharmacology, molecular docking and ADMET analysis. Big round of applause to the UG. Moving on to the postgraduate posters. The second prize winner is Dr. Ayyappan, Novel Drug Delivery System in Advanced Parkinson's Disease, a systematic review, Sri Atal Bihari Vajpayee Medical College and Research Institute. The first prize in PG poster was again a tie. There were two first prize winners, Dr. M. Raj Sekharan from Government Medical College, Anantapuram District, Andhra Pradesh, KAP of Vaccine Vigilance among Medical Professionals in Tertiary Care Hospital, cross-sectional observational questionnaire-based study. Is he here? Okay, we move on to the second first prize winner. Both had a tie, same marks. Dr. Ramya from Government Cuddalore Medical College and Hospital, Annamalai Nagar, Chidambaram. Is Dr. Ramya here? The title was Analgesic Utilization Patterns Among Post-Operative Orthopedic Patients in a Tertiary Care Hospital Observational Retrospective Study. I request the winners who are watching us online to please contact us through email and we will courier the certificates and prize mementos to them. Oral postgraduate. The second prize goes to J. Uvita from Government Field Park Medical College. The title of the study is a randomized open label study of prebiotics and probiotics in recurrent vaginitis as an add-on therapy to standard treatment. On behalf of Dr. Uvita, Dr. Vishwanath will be taking the prize. And for the oral first prize for postgraduate section, we again have a tiebreaker, Dr. Bhagya Lakshmi from Kilpak Medical College. Title of her presentation is Lixtroside, a potential candidate in the management of bronchial asthma and in silico approach. The other first prize goes to K.E. Balakumar from Maulana Azad Medical College. Big round of applause, please. Efficacy and safety of saroglitazar in diabetic dyslipidemia. We move on to the faculty prizes. Faculty poster prize. The second prize goes to Dr. Sultan Al Rashid, Savita Medical College and Hospital. Again, the disclaimer: we had no influence on the judges, and all the judges were not from Savita Medical College. The title of the study is Enhancing Metabolic Syndrome Diagnosis with Fasting Insulin Measurements. The first prize in the faculty poster goes to Dr. Manjunath Bidaroli, Amrita School of Medicine, Faridabad. Title is Polypharmacy and Anticholinergic Burden Scales in Older Adults, Longitudinal Cross-Sectional Study among Psychiatric Outpatients in Tertiary Care Hospitals. The last prize winner section we move on to is the faculty oral presentations. The second prize is Dr. Amrit Kiran, Manipal Academy of Higher Education, Manipal. The title is Dose-Dependent Diuretic Actions of Crude Aqueous Extract of Tribulus terrestris fruit. Do we have anybody from Mahan here? Big round of applause to Dr. Amrit. And it gives me great pleasure to give the first prize to Dr. Pudavendan Tangaraju, AIMS Tripod. The title is Analysis on the Use of Any Forms of Amphotericin B alone or with posaconazole in COVID-19 associated mucormycosis at the time of pandemic disaster in the tertiary care teaching hospital. Thank you very much.
Traveled enough during this last 2 months. Tell how did you feel about working with them?
I think we just approached with all 4 or 5 blindfolds on. I had not opened my eyes inside the blindfolds when I approached her to do this conference because I didn't know what I was getting into. So doing this is the first conference that we have conducted here after many years, and I think hybrid conferences are a different game totally. Doing an on-site conference is much easier. Doing a fully online is much easier. Hybrid is you have to coordinate the technology. I think Dr. Yashwant and Dr. Arun and our IT team tried to salvage the situation. We thank them. I'm not going into much details, but I just like to conclude that we had a very great learning experience conducting this conference. As far as the finance aspect is concerned, money was freely flowing. So we were able to give the best what we felt at that moment. We have the book launch. There were 75 papers which were presented, 30 oral and 45 poster. We had 22 national all over India and 3 international faculty. You already saw the panel discussion, which was very rewarding and informative. Awards were given to the prominent pharmacologists all over India, both senior, junior, upcoming, and we had corporate sponsorship. We had 6 very generous sponsors, and this conference, I think, is the beginning, and I hope there will not be an end to the MPS academic pursuits, and we like to be involved, as our chancellor is also committed. We like to be wholeheartedly involved personally as well as an institution. We thank all of you for gracing this conference. We are honored by your presence. Madam, your students, big round of applause to Arna Madam. 2 of our students have got prize here. Thank you so much.
Yes, so final acknowledgement I would like to give. I would like to thank Laila Cremona. So she is really, when I just messaged her, one message said that we need support from you for conducting this. So she really, she herself asked, so how much you require? So can I give this much? So, your support was very generous, and thank you so much. And you yourself, personally, you are here both the days, and you graced the occasion. So definitely you added a lot of color to our program. Thank you so much. Wow, both please give a big round of applause for taking time. They are AI-based companies and also training-based, they would like to systematize a lot of training. So hope you will have a strong hold in India, and we are here to support again. And we promise that. So second, I would like to thank Spinus Research. And again, it is, they are also very generous. They came forward and they accepted our, like we had it was not a big discussion, so they finalized very fast and they made it, and their support was really, instrumental in finalizing our agenda and everything. And thank you so much for your generous support, and we would like to have more of such kind of, support that can, so that we can do more creative programs. Then we had three silver sponsors, AJR Pharma, AJR Pure Wipes. So they really supported us, and then Alcama came in between, and then Silmet. So Silmet is there since the beginning, and everyone backs us, and that way we are able to conduct this. And definitely online participants, I would like to thank all of them. So we also like to apologize if any inconvenience. I'm sure there were inconveniences were there. So but technological, we tried our best, but the technology sometimes it backfires. Some AI is good, but it has to be monitored, and it should be properly handled. So that's how we can conclude this. What is the experience? But at the same time, I would like to thank 4 donors here. Dr. Sapna Patil, she generously agreed to give fund for our books what we have given you, and then Dr. Madhav Rao, he also helped us. And then one Vidya Sagar Tamil Shetty, so he also funded, and I also funded. So in that way, I think it's more of hard work and dedication, and finally working as a team. So both Savita and MPS, they all work together, and we made this conference a grand success. So I would like to get the views of the participants. Some of the participants, I would like to invite some of you to come forward and say a few words. How was your experience? What can be done better, and how we can move forward? And before that, I also would like to thank Dr. Pulan Sharma for taking the next responsibility. Okay, we would like to announce that like Dr. Pulan Sharma has come forward, and he will be hosting the next conference in where? Where is the place? All of you just say it is. So it is in AIMS Guwahati. Okay. So AIMS Guwahati, we will be traveling all the way to AIMS Guwahati to make it a successful. All of you agree? All of you agree? Please, please clap for him. So you would like to say a few words?
Sir, actually, it is very nice. Actually, this time, sir, this like very nicely planned and very nicely executed. So we would like to do the same in AIMS Guwahati, and we invite you all to the next conference in AIMS Guwahati. Hope to see you there. Thank you.
I would like to get the views of the participants. Some of you, anyone who would like to volunteer and say a few words. How was the conference? What can be done better? Any?
What did you get?
So, for me, it was a very humbling experience. So it was a learning experience for me as well. And I would like to thank MPS for giving me that opportunity to come here as a speaker. So everything was nicely executed right from the intimation about the conference, and we made the noise in the right direction. So so that we had maximum amount of participation. I think definitely there are some learning areas, some areas to cover. So I think which we can overcome in our next conferences and workshops. So my best wishes. Thank you.
Well, this conference was really very, it was like a mix of both academic and industry. And all the topics were almost covered, not just pertaining to industry, but also even the academic speakers had good and relevant topics, whatever is relevant to the present day. So although little bit of technical glitch was there initially, but I think later on it was a smooth.
Thank you so much.
I feel happy that I came physically, so definitely you will give a support to MPs, and it will be a little more frequent, in terms of. So I'll focus on the rural part, rather than in metros, so that our rural student will get more exposure, and definitely it's coming to Guwahati, so I'll be contributing. Thank you very much. Thank you.
Thank you so much. I would like to ask Dr. Melvin to update our participants.
So it's been a great opportunity to be part of MPSCon, and want to congratulate two people. One is the team from Savita. Great team. Hats off to all of you to organize such a stupendous conference. And we all should congratulate one person. And you all know who it is? Dr. Shivamurthy, the brainchild, the heart and soul of MPS. For Shivamurthy, sir, MPS is like a second family. And he embraced MPS and nurtured it. And we all should see how we can make this grow to a big banyan tree that can make the future generation of pharmacologists, make pharmacology such an aspiring field that people who complete MBBS would look at pharmacology with great respect and long to embark a career as a pharmacologist. Okay, so we have started this journey, and I'm sure MPS will grow by leaps and bounds in the years ahead with all of our. Yes, thank you.
I'd like to again thank our office bearers, basically Dr. Mula Pulen, Dr. Melvin, Dr. Akash, and Dr. Prakash sir, and everyone. So all our office bearers, they wholeheartedly support Dr. Bapurni. So Dr. Bapurni yesterday was there. So all of them, when we proposed that we are going to conduct here, they are wholeheartedly supported us, and they agreed to fund the program. Okay. And even though we had difficulties, but we are able to fund this program, and finally it is concluded. And we look forward for all your active participation and support, and so that we can support our. Actually, this time I would like to thank all the judges, chairpersons, speakers, everyone they all contributed by traveling by their own expenses. So their own expenses, their own stay, since it is our first step, we had to, request them. And we'll try to do better next time. Hope that, we'll have, that to, fund your, travel and stay. At least some of the expenses can be covered, but we will also come back to you after auditing all the expenses, income and all. If we can still reimburse some amount, we'll try to do that. So thank you so much for your support. And with this, I would like to say that, can I conclude, madam? So the MPSCON2024 is. Thank you so much. And now we'll continue with our general body meeting. Very quickly, we'll hold it and we'll have the general body meeting of our MPS society. So in that way, we'll try to, identify additional support for our society. Like campus office, there are some of the, people who can be included into our team to strengthen our objectives like JMPS and nodal centers and workshops, next up in upcoming program. So all these things we can have a little bit of reflection. So thank you so much. Laila, you can wait here. We need you.